A very good morning, ladies and gentlemen. I'll please request all our guests to be seated. So we'll precisely start with our sessions for the day two. Namaste, good morning. A very warm welcome to day two of our first International Patient Summit. We are truly delighted to welcome our eminent speakers, distinguished panelists, our organizers, respected delegates, and look forward to an extraordinary session today as well. We have had very enlightening sessions on day one, covering topic horizon of health literacy, women's health, communicable diseases, advanced therapies, and a universal patient health coverage goal. It is my privilege to call upon Dr. Ratna Devi, Director, Patient Academy for Innovations, to give us a brief outlines from day one of well-spent first International Patient Day. Please, ma'am, can we have you on the stage, please? Thank you.
Good morning, everyone, and a warm welcome to day two of our International Patient Summit. I'm told by my team that many of the participants are still on the way and are caught in traffic, and will be reaching in about 10 to 15 minutes time. So while we wait for them and while we see that they reach here, I'll just do a quick recap of what we discussed yesterday. The content of yesterday's discussions was really very rich and covering a wide range of topics, as Bhavna just mentioned, from universal health coverage to women's health to health literacy, and talking about, what health literacy does in a digital world. We had very interesting session from Jayasilan from Oracle, who talked about data and how artificial intelligence is changing how things are perceived. He talked about interoperability and why digital is now embedded into our life. And while it's already there in our financial systems, it's not so much into our healthcare, and that makes it so difficult to understand whether the burden of disease is the true representative based on current data. He also spoke a lot about why it is important for various agencies, whether it's the data agencies or whether it's patient organizations or academia working in health literacy, public health institutions, ministries, and other people to work together. So the health literacy session that was moderated by Einstein, who is an innovator himself, was really a very enlightening session. And then the first opening address by Dr. Soumya Swaminathan, sort of spanned across environmental health and the lifestyles as well as ultra processed food. Again, patients owning up to their healthcare and having meaningful dialogues with their providers, as well as why it is important for everybody to work together. She made a remark on why our ministries are not ministries for health, but ministries of sick care. So the ministries actually look at people who are sick and not try and prevent sickness, and why it is important that patient groups like that are gathered here work in collaboration with the ministry on the prevention aspect of it, because when as a growing population in the world, unless we have enough focus on prevention, and especially the pandemic taught us that if prevention is not done, then infections spread faster. We also cannot stop the epidemic of non-communicable diseases because there are factors outside of health that are affecting the non-communicable diseases like, say, diabetes, heart attacks, etc., which brings us the climate part of it into discussion. And if we are not addressing climate, then you have the kind of pollution levels in Delhi that you have that are triggers for cancers and heart attacks and other non-communicable diseases. So it was an extremely interesting discussion. The last session was on PCOS, on endometriosis, on NCDs and gender. And it was a very powerful panel that spoke about why women's health is not really addressed in the way it should be. And there is not enough focus on chronic debilitating conditions like PCOS and endometriosis, and why it is important that non-communicable diseases or whatever policy level discussions that we are having include these conditions as well. It's not just focus on cancers, hypertension, stroke, mental health, etc., but also focus on these areas as an inclusive policy. We also talked about access to advanced therapies, genomics, and gene therapy. And again, this focused on why gene therapy, while it sounds like a panacea and a cure for every disease, might not really be available to populations in this part of the world because of the sheer cost of treatment. And because genomic therapy takes years to develop, not every disease will have a therapy that is available. And therefore, why it is important to look at other measures of managing conditions that require these kind of advanced therapies. We also discussed the communicable diseases, and are we forgetting the communicable for the non-communicable? And usually the dialogue is double burden of disease, but we are seeing that with advanced therapies available, many patients who have long-term communicable diseases like Hep C and HIV are actually living longer, healthier lives, and they then become old and then have non-communicable diseases. However, that integration into health systems is not happening. So how do we learn the lessons that patient advocacy in HIV, Hep C, etc., and tuberculosis has brought to our forefront, and take these lessons to non-communicable diseases so that we are not reinventing the wheel all over again? So this was a short recap of day one. Day two is interesting because it's an area that I'm very, very passionate about. We have two sessions that cover patient safety. I myself sit on the steering committee at World Health Organization, Geneva, for many of the activities around patient safety. I've been part of the committee that sits on patient safety rights, and we've been drafting patient safety rights that are sort of an outcome of human rights, but more, focused towards what should happen when there is something that is untoward. How is it communicated to patients? What rights do patients have in terms of patient safety? Proper disclosure and then compensation if something has happened without having a blame culture. So our first session today will start with why do we need patient safety networks? And I'll speak about it when I'm moderating. And what is this part of the world doing, the Asia Pacific region doing in terms of building these networks? And we have very good panelists who will be joining us today for this session. That session will then be followed by life course vaccination, another area that's not very popular in our part of the world because traditionally vaccination is considered to be something that's included only for pediatric populations, and therefore pneumococcal or influenza vaccines or HPV is not really discussed. And most people think they need the vaccination only after they have had an incident in their life. When there was a survey conducted in the context of India, we discovered that even healthcare providers are hesitant to prescribe those vaccinations when patients turn up at their clinics. So there is a hesitancy at the healthcare provider level as well as the patients themselves. So what do we need to do to increase awareness so that there is more uptake of adult vaccination? Followed by in-depth case studies, a very, very interesting session today where we will hear success stories from different parts of Asia Pacific region. And these are all patient advocates who have done wonderful work in their countries and will be speaking about their success. And followed by a session on mental health and why mental health. Right now, if you see a 5x5 strategy by the WHO, it says non-communicable diseases, neurological conditions, and mental health. Whereas mental health is integrated into all. So if you have cancer, you have depression. If you have stroke, you have depression. If you have a heart attack, you go into depression. And people who are going into depression will not take care of their own health. So while the healthcare provider is providing them the information on what to do to prevent a second attack, for example, in heart attack or in stroke, they are not in a mentally fit condition to be able to follow those instructions. And usually the caregivers are also not aware. So what do we need to do to integrate mental health into all programs and not just as a vertical silo? Followed by a workshop in the afternoon, which will focus on how do we build patient safety network for India and what do? We are going to be working on a consensus document, and this document will then be presented to our ministry. So that's a brief overview of what we are going to do today. And perhaps we can start with the first session without any ado. Thank you.
Thank you, ma'am. It's always a blessing to hear you. With this, please, I would like you all to put your hands together to mark the start of day 2 for first International Patient Summit. Please, a great applause for the ladies and the panelists who are about to come. So first session on Asia Pacific Patient for Patient Safety Networks, building a regional patient network to achieve GPSAP to 2021 to 30. Our chair and moderator for the session would be Dr. Ratna Devi, Director, Patient Academy for Innovation and Research. Kindly allow me to please welcome another panelist with us, Dr. Parmeder Gautam, National Professional Officer, Patient Safety and Quality, WHO India. Can we have you on the sir? We are honored to have you here, sir. Please, a big round of applause for the gentleman. I take privilege to please welcome our next panelist, Dr. Gaurav Sharma and Dr. Anwar Mohammed. They both together will be presenting on ensuring right product at point of care using QR code. We are honored to welcome you both, sir. We would have Mr. Manveer Victor. He would be joining us virtually. Chairman Patient for Patient Safety Malaysia, board member of Malaysian National Patient Safety Council, WHO. Please, a round of applause for the gentleman. He'll be joining us virtually. Thank you. Last but not the least, Ms. Arshia Bhandari. Ma'am would be covering the topic empowering patients to identify and report patients' harm. Thank you, ma'am. Please, we're honored to have you here. Maybe when you move on. Thank you. I would leave the chairs to you now.
Thank you, Bhavna, and welcome to all my panelists. Just to I know Parminder will be speaking about it, but what is GPSAP? It is Global Patient Safety Action Plan, and this was approved by WHO Executive Board in 2019. It's a 10-year plan spanning across 2021 to 2030. It has 7 objectives, and each objective has 5 sub-objectives. So it's called by a 7x5 metrics, of which the 4th one is patient and family engagement. And we will be discussing that in more detail in the afternoon. But way back in 2009, WHO started something called Patient for Patient Safety Champions. And there is a steering committee that with people who have been working since 2009. And these are people who, on behalf of patient groups, bring the topics that affect patients and patient families to the policymakers. A lot of work has been done since 2009, but this got more attention after the Global Patient Safety Action Plan came into being. And country after country is now creating, networks of patient advocates who are passionate about patient safety and reporting patient harm. And that is why, this session is so important. And Dr. Parminder Gautam will speak a little bit more in elaboration for what WHO is doing globally as well as nationally, as well as why regional alliances and national alliances are important to carry this mission forward. You, Parminder.
Good morning. Namaste. And also thank you. I'm thankful to the organizer for having me here. I am Parminder Gautam. I am working as National Professional Officer for Patient Safety and Quality at WHO India Country Office. And this very, I think it's the last slide. So, I don't want that different. I will start with my first slide. No, actually, I have tried this. Actually, I was giving a lecture on change management, and I started with the thank you slide. So everybody was there. So I told that that's the thing. The first thing that came with change is surprises and resistance. So how can you start with the last slide? So that's a part. So all of us agree that the first and the foremost principle of healthcare is first do no harm. But still, the harm due to unsafe care is one of the leading causes of death worldwide. It's a global public health problem. It's not limited to low middle income countries. It is as prevalent across the globe as anywhere in the world. And there are everybody do agree that patient safety is important, but there is a lot of yawning gap between the intent and the implementation. I was talking about why we should have alliances and what's the role of patient. So there are several strategies that are there for patient safety. And as Dr. Ratna has already elaborated, that we have on the WHO World Health Alliance 2019 Global Patient Safety Action Plan was developed. And the 4th strategy, there are 7 strategies, and the 4th strategy talks about engaging patient for patient safety. The question is, why should we engage patient safety? So the problem is that whenever we talk about patient safety policies, patient safety guidelines, patient safety tools, unfortunately, in that patient safety, patient is always missing. So we forget patients and we talk about, so we cannot talk about patient safety without involving patient safety, patients and the families and the caregivers and the community as a whole. India has a very good tendency of involving patients, community processes of community participation. In India, we have got various community participation platforms, those are from other countries. I will just take a brief time. At village level, we have got village health and sanitation and nutritional committee. That is, and in all these committees, 50% of the members are female. All of them are community representative. They are provided with an annual grant, untied grant that they can spend the way they want. Then the PH, and then we have got Health and Wellness Center where we have got Jan Arogya Samitis. Again, it is headed by the local leader with females and teachers and all everything. Then we have Rogi Kalyan Samiti that translates into Patient Welfare Society. So we have got, and they have the autonomy to take decisions, to accept grants. So, but again, so that is again like that, then it is again about more about finances and control rather than safety. So if we can have a patient representative there at each level, that will, I think, go a great. Among the seven strategy objectives that has been given in the Global Patient Safety Action Plan that Dr. Ratna talked about, I think that the patient engagement is something which is the lowest hanging fruit. Lowest hanging fruit in the sense is that it doesn't require much of resources. You do not require a huge amount of fund. It doesn't require too much of human resources. It is just tapping the existing by tapping the existing resources and giving a voice. The slogan for this year patient safety was that elevate the voice of patient. To elevate the voice of patient, first we have to listen to them. Then only we can elevate their voice. So that is a very low hanging fruit without much of the investments. And studies have shown that wherever the patients have been involved in the patient safety campaigns, in their policies and guidelines, there has been reduction in patient related harm to the tune of 15%. So it is a very, and patients can give us a very valuable insight because patients are the only constant throughout the continuum of the care. A patient may receive treatment from various providers, from different hospitals, from different pathies, from different places, from different medicines. So place changes, doctor changes, provider changes, but patient remains the same. So they are a repository of very good, insightful information that can not only be used to improve the safety of the patient, the staff, but that will also provide us about the system's failures. What are the systems reforms that can be done to address the patient safety? Because a patient can only tell that how he or she felt about a particular sort of treatment. A patient can only tell what are the side effects. A patient only that what could have been done better. Because we always, so it's high time that we should shift our paradigm from provider-centric care to patient-centric care. So patient should be, whenever we talk about patient safety, I think that the patient should come first. So I think that nothing about me without me. So we have to consider, these can even by involving the patient, we can have improve our outcomes. How? There would be more compliance. When involving the patients to the treatment that is being provided, the compliance would be better, the outcome would be better, patient satisfaction will increase, we will have more insights, we will have better policies. And it also helps by involving, now all the solutions are made by either healthcare providers or healthcare leaders. But if the solutions come from I am also a quality professional. In quality, we say that understand the voice of customer. So it's the customer who, best of the innovations in service industries have been provided by the customers themselves. What exactly? Recently, I was looking at the insurance. Somebody was telling that there are penalties for rash driving and rough driving, but there are no incentives for safe driving. So now one of the insurance company has come up that they will give you an app, then you will drive that, they will monitor your driving thing and based how safely you drive, you will get your insurance premium would be there. So no insurance specialist would have come up with that idea. That was again from the customer. So that it improves communication with the healthcare, and there is all of you will agree that there is a huge information asymmetry when it comes to patient and the healthcare provider, because as a patient doesn't know whether the diagnosis is right or not, patient doesn't know whether the drug is right, dose is right, nothing. Similarly, doctors also don't know. Somebody came with sore throat, he is not aware whether he is on anti-tubercle treatment also, whether he has got some other communicable diseases, whether he has undergone some surgery years back or not. So that information asymmetry, because of the information symmetry, there is a lack of trust among providers as well as the the patients. So when we'll start talking to each other, when we will involve them in decision making, when we'll make shared decisions, when we will empower them, when we'll engage them, when we'll start treating them as partner rather than passive recipient of the care, then this will definitely foster the mutual trust and confidence in each other, not only in each other but in the health system. So, as a global, so there was a baseline study that has been conducted by WHO, wherein as a baseline of to what extent we are here in terms of implementing global patient safety action plan. So, I will just like to highlight this is study is yet to be published. This is the self-reported data from the member states, WHO member states. So, only 13% of the approval a patient representative in their giving them 24%. You see that 44% of countries have established a patient rights charter. Only 20% countries develop policies with involvement of patients. Only 10% countries have patient for patient safety networks. 50% countries have procedures for patients across access to the medical records, and 13% countries have initiatives to educate patients and their engagement. So you see the numbers are not very encouraging as a baseline, but the intent is there. Then again, so to bridge this gap between intent and implementation, the role comes from here. Where come this this National Patient Summit comes here, and by having regional national alliances at various level, at national level, at regional level, and at global level, will definitely help to bridge this gap between intent and implementation. So this is the in terms of intent, if we talk about, these are very elaborated, documented, and accepted and endorsed by all of the countries. This is the strategic objective 4. We will be talking about. I think that this slide is very important. Today's most of our sessions and these are centered around this theme only. So this is the strategic objectives. I have got these 5 strategic objectives. One is co-development. That is, whenever we are developing any policies, anything that is relates to patient safety, we should involve patient and patient groups. Then there is learning and consulting. Learn from the experience of the patients and explore use of care, and learn from the experience so that we do not make the harm again and again. Then there should be an option that where the patients, those who have suffered harm, they should have this ability to report the incidences. The report should be analyzed, translated, and that should be used for learning and provide information and education to patient and families, and research on patients. So these are the 5 strategic objectives around which engaging patient for patient safety usually revolves. That's what WHO recommends. And just taking cue from this Global Patient Safety Action Plan, I'm proud to say that India is one of the foremost countries which adopted this plan and came up with their next. So came up with their National Patient Safety Implementation work. It is about to end in 2 years now. But again, they're also in their that 3 priorities there, 1.4 that also advocate that also translate the same thing which has been advocated by. So it is not a separate strategic objectives. We have infection control as a separate strategic objective, because for us that is also a very challenging issue. But within the strategic objective 1, we have got established patient-centered and avoiding patients harm in their own care. So this is, again, it is education and information, developing educational and tools, multimedia tools that should be disseminated not only to the patient but to the providers. There should be an established grievance redressal system wherein people can not only report they can report their harm, their grievances. There should be helpline numbers, and should not, and there all the grievances and the complaints should be analyzed, found the insights, and used to and that should be utilized to develop policy and guidelines that will help us to improve the patient safety. Then again, patient right groups, to establish patient right groups is a mandate that is from Government of India. This is a document that has been approved by Parliament. So that also says that promoting establishment of patient right groups and facilitating involvement of policy disclosure and monitoring of the patient outcome. So we should have indicator, we should monitor how, in which direction we are going. So that's very much there. Next. And again, it is not, if you will see that the 5 strategy objectives that were there in the WHO guideline as well as this, by having alliances and networks at various levels will help us to achieve all of the 5. That's a great thing. It will help us in policy, it will help in co-development, it will help in IHC. So everywhere. So that is that I think that it is a very encouraging and a very sensible to start with the networks and everybody. So network means it doesn't mean patient and providers. There should be policy makers, government, patient care organizations, healthcare providers. So engaging family and patient community for patient safety is everyone's responsibility. So all of us, those who are in this room, have to play a very pivotal role in getting these guidelines constituted. So existing in terms of collaborative, I can say that having collaboratives, having patient networks, having networks at various levels, it has helped about. So many of you must know about the Global Patient Safety Network. It is an online tool and which involves all the stakeholders, policymakers, government, WHO member states, and everybody. And there were meaningful discussion that's going on where patient safety. So I will take example of World Patient Safety Day. So everybody, so those who remember, they were sharing that we did this, and immediately after 1 week, I found that some other country has followed the same thing. We also did this. This what we also did. The medication safety, we did this. What are the main medication errors that are being reported by nurses? So that is there. It stimulates dialogue. The webinars are organized. So Global Patient Safety Network is, in terms, it is very well established right now. Then we have also got Global Patient Safety Collaborative that has been established in collaboration with WHO and United Kingdom with Imperial College of London as our academic partner. So it provides 2 types of support, direct support and indirect support. So in this year, India is one of the beneficiary country which is getting the direct support. Recently, we have in India, we have for medication safety, we have established some these demonstration sites. So there are 3 sites that were there. Last week only we had capacity building where we are privileged to have Professor Bryony D. Franklin from Imperial College in London and Dr. Priyadarshini Galpati from Sri Lanka. So they organized a patient workshop at Safdarjung Hospital, which also happens to be the National Center of Excellence for Patient Safety at AIIMS Jodhpur, and we continue to do. So that is another thing. Another network that is there is Global Medication Safety Network. It is still in the initial stages. So those who are involved in medication, so here patients are not there, but then again, so what happens is that by having, and they have yielded very good results. So this makes a case for some of the upcoming technical products on patient safety is the WHO patient safety storytelling, because storytelling is a way in which how the harms are explained without being pinpointing fingers, without being blaming or shaming. But how can a storytelling help us to understanding the problems, understanding the root cause? It's the Swiss cheese model. So what are the cheeses with the whole through the holes in the cheeses where the problem was supposed to occur? And also engaging patient for advocacy brief that is also in development, and patient safety rights charter, which Dr. Ratna also talked about. We on this World Patient Safety Day, we had an elaborate discussion, and that will be also released soon. So now regional alliance and patient safety network with is the need of the hour. So we need to have an so regional workshop is that because in this the region which we belong are socially, economically, politically, and in terms of health disease burden are almost identical. And some very good initiatives have been taken by different countries. So that is a platform that will help us in efficient and knowledge experience sharing is one thing. It can be used as a repository for resources. If some tool is being developed, if some any new methodology has been developed, any new initiatives, any innovations that can be used, that it can stimulate dialogue and provide continuous learning. It can sharing and application of the ideas, approaches, tools, and best practices. And at a repository, it can be written and discuss that the policy. So it can be used to provide the policy, advocate for the policies for patient and safety. So I firmly believe that this is should be done. It should have been done by now, but late than to be never. Next. So what exactly is required? First of all, today we are here. We should have some consensus that what should an alliance or a network look like? Who should be the member? How should we get collected? What should be our agenda? What should our protocols? Who should be the member? And how frequently we should meet? And then we should advocate. Then we should establish a this global patient safety regional alliance. And after established, then it is required. Then we have to promote and advocate. With whatever the consensus statements emerge today about all our discussion, we will be presenting it to the WHO also and to the ministry to endorse. So once they endorse, then we establish, then we will further strengthening it by involving all stakeholders. So it should be, so even if those who are remotely related to patient, even if a patient has never suffered a harm, but he wants to be part of this, okay, you're welcome. Policy makers, health administrators, health managers, government, NGOs, everybody, anybody, those who is there, that should be there. And we should then promote it through various channels. And social media is one thing that comes to my mind. So that should be eliminated, and patients should be educated. Patients should also be told that yes, your views are important. We do care about it. There is a Mera Aspatal is an example in India where we take feedback from the patient, though visited physically. So initial response was very overwhelming. Patients were just satisfied because somebody has asked me about my opinion. So initially we had a success rate of around 78%. After 6 months, it reduced down to 64. Because initially they were overwhelmed by the simply thing that I am also considered. I am also somebody views my view, somebody value my views. So after that, then this training, then we should periodically monitor that we are in the direction, what new we can do, what are the practice we should, what should we adopt or abandon in our strategies, periodic reviews of our alliance, and then keep on improving, learn from our mistakes, try some new things, be bold, and then further improve. As WHO, I can only ensure that WHO would be happy to partner with any of the organizations, all of you, in terms of providing support, technical support, in terms of hosting the platform. Even I also that WHO can be the co-moderator of this alliance, and any technical support that's required, WHO would be more than happy to take. Thank you. So if it's not safe, it's not healthcare. Let's make it safe by involving patient. Thank you.
Thank you. Thank you, Dr. Parminder. Just a couple of questions before I call our next speaker. When we work with patients groups in the region and as part of our network, one of the questions they ask is who should we approach when we want to create this alliance? And I've found out that it's different bodies in different countries. So for example, it's the Accreditation and Quality Institute in Thailand, it's NPRA in Malaysia, it's Ministry of Health in India. So what is the advice that we can give to patient groups who approach us and say, we want to start our first workshop, but who should we approach?
Okay. So I think that Ministry of Health is the decision-taking body. But again, I think that now we have got a National Center of Excellence, Safdarjung Hospital. So I think that if we can involve them and we can take their consensus also, if we take them on board, and in the process there are regional centers also. If the National Center of Excellence, Regional Center of Excellence for Patient Safety and Patient Groups, WHO, all of us go with an intent and with a very clear agenda and concrete objectives, I think that ministry will not have any reason to say no. So I think that that should be the approach that can be taken care, will take care of most of the challenges. Any other questions I can take?
We'll take towards the end of this session. So thank you so much for that. And you mentioned that, there could be digital that helps us to gather information from patients and patient groups. And that brings us very nicely to our next speaker, Dr. Gaurav Sharma, who will be speaking about ensuring right product at point of care using QR code. And I would like to ask a simple question before we ask you to join us at the podium. How many of you actually read patient information leaflets? Those little things that are folded multiple times inside the boxes. How many of you have actually opened that and read it and tried to understand what it is trying to tell you? No one. So there you go, Dr. Gaurav. The floor is yours. And Dr. Gaurav will be joined by Mr. Anwar Mohammed, who will be giving us a demonstration once Dr. Gaurav has done his presentation.
So good morning, everyone. First of all, my sincere thanks to Dr. Ratna for inviting us, for sharing one of the experiences and one of the endeavor we did for improving the patient safety. Dr. Parminder very nicely, in a very elaborate and comprehensive manner, explained about the whole gamut of patient safety. We would focus on one very important and significant aspect of patient safety, which is ensuring right product at point of care. And we all know and we all acknowledge that informing the person who is using a medicine about the right and appropriate use of medicine is very important. And that's why we are here. And it becomes really very challenging in current scenario because there is a limited space available on the label. We have to restrict to the content. Even if we add the patient information leaflet, it becomes really very challenging for different people to read it through. And like Dr. Ratna rightly asked everyone that how many of us actually use it is something which is a thing to be considered. And we all know that the whole world is going through a digital revolution. It started before COVID pandemic, but then COVID pandemic occurred. It was an unprecedented time, which made us learn new things. And digital technology and use of these tools is one of the significant learnings which we have taken while we are recovering from the pandemic. It is also, it is said that every disaster is an opportunity to learn and to make more resilient society. And that's how we are now learning about use of newer technology. And one of them is the quick response or QR code, we commonly say, how we can leverage and utilize this technology for giving appropriate information to the users while they are taking some of the other medicine. Another important aspect is that in country like India, which is a multilinguistic country, where the language changes after every 100 miles, it is practically impossible to have all the informations made available to the users in all and every language which can be used pan-India. So we have to find ways. We have to find use the technology wherein we can actually percolate and give that information in a different or in all vernacular languages. And that's how we in Reckitt thought of having a kind of pilot wherein we started or with a thought that why not to use the electronic labeling for actually giving the appropriate information. We have jotted down some of the benefits of electronic labeling versus physical label. And I no way mean that it is a complete replacement for physical label, but this would be an additional thing which can always have on the label in form of a QR code or a portal link from where the patient can actually land on the page where he can or she can actually go through the information. And the biggest and the most important part of this electronic labeling is that it can be a real-time updation which can occur. Whereas if we have a physical label and suppose there is a new update about any of the information, then it becomes a challenge to replace that label and find out exactly, or maybe it takes around 6 to 8 months to actually bring that information in form of a physical label. So few of them are listed over here. One of the important one I have explained that it is a real-time label update. Then the content customization. This is also very important. Like we talked about the vernacular languages which are there. If we have that flexibility of letting the person understand and see the information in the language which is more comfortable for him or her, that becomes a very convenient tool for the person to understand more about the medicine. And I tell you, if appropriate information is provided about the medicines, it can not only improve the appropriate use or safety or the efficacy of the product, but it can also drastically reduce the harmful effects or adverse events which may or which can occur due to the improper use of that medicine. Also, very important part is that nowadays there is a lot of focus about sustainability. We can have reduced burden in form of reducing the paper usage, and probably this is the way forward which we can see in coming years or maybe decades where the people would adopt to this. Now, when we talk about medicines, very important part is the acceptance by the competent authorities. There has been a slow start to this, but certainly a positive start. In 2020, EMA, along with HMA, they published key principles for electronic patient information and a standard format which can be used in EU. It was published in 2022. So it is a very welcome step, and similarly other countries like US, Singapore, they have also adopted and published guidelines which can actually allow the use of electronic patient information standards. Even Japan, in 2021 August, they came up with e-labeling regulations. And as I said, COVID-19 was something which made us understand and realize and learn newer things. And some of the countries like Brazil, they took the initiative for giving exemption of leaflets, physical leaflets, because of the logistic issues, and they allowed the use of electronic labeling or information to be provided. In Australia also, the guidance on TGO 91, TGO 92, they have accepted the QR code use to provide consumers with information which can give elaborate information about the usage of medicine. Now I hand over Dr. Anwar to share the experiment which we did and how it has gone and what kind of learnings we can take from it. Anwar, over to you.
Thank you, Dr. Gaurav. Good morning, everyone. So yeah, from the yesterday's session and in the beginning of this session, already we have discussed lots of things on digital literacy, how the QR code can benefit to the patient's engagement. So I'll not go on the details. Let's go for a live demo and to get all the information. I can remember in the last session, Dr. Usha, she was also stated some of the patient-friendly communications and how to deliver the message, but with a caution. So in this pilot study from lots of collaboration has been done, and we have covered basically the 5 basic things which can give a maximum output to the consumer engagement. We have covered the digital literacy and also the supply chain consistency labeling across the market, open access information to the HCPs, to the consumers, the data protection, which is a very important pillar for the digital information, accessibility to the diverse abilities, and then combating counterfeit. That is another in the most of the times we can see the QR code technology can be used to combat the counterfeit products as well. And obviously the collaboration, I think Dr. Arsia, you have stated yesterday collaboration. So yeah, definitely. The collaboration is very important here to for this digital one. even though like in internal stakeholders as well as the external stakeholders with regulatory competitive authorities and as well as all the patient organizations. So can I move to the next slide, please? Yeah. So this is how we have divided a web page, and this is a very non-promotional web page. It has not been linked with any of the like marketing commercial web page, and which host all the safety informations for that. So if I just ask Vikas, if you can just move to the web page, please. Perfect. Thank you very much. So here it is how it has been designed. We have the like the options of the video, audio, and as well as the PDF formats, question and answer. So I'd like first ask Vikas if you can just run that video, please. So let's go through that, and probably it will answer all the safety information.
Hello there. Acid reflux,
to listen before you use the product.
indigestion,
The disclaimer, sorry, while the video plays, that what we are presenting is just for academic purpose and for sharing our experience. We are, not here to promote or do any kind of commercial,
We
message.
hear these terms, but very few people know the causes, symptoms, and treatment, like oily and spicy foods, or caffeinated drinks, or late night dinner, pregnancy, stress, or even occasionally ignoring healthy dietary habits can cause acidity and heartburn. What is heartburn? It is the burning sensation in the chest caused by stomach contents that sometimes travels back up into the food pipe due to relaxation of the lower food pipe junction, which is called acid reflux, causing inflammation and pain. You don't have to live with the discomfort of heartburn and indigestion caused by acid reflux. Good news is you have sodium alginate based product. Here's how it works. Sodium alginate is natural and extracted from seaweed. Alginates work in a different way to antacids, which only neutralize the stomach acid in a short time frame, but the effect is soon overcome by acid secretion. This product soothes and cools the food pipe. Sodium alginate forms a thick layer known as the raft as soon as it makes contact with the stomach acid. This raft floats to the surface of the stomach contents and acts as a strong physical barrier which stops acid from going upward into the food pipe. In short, it starts to work in 3 minutes and gives long-lasting relief for up to 4 hours. The product is suitable for pregnancy since the action of this product is physical and does not enter into the bloodstream. Please read the label carefully before you take this product. Each 5 milliliters contains sodium alginate 250 milligrams, sodium bicarbonate 133.5 milligrams, and calcium carbonate 80 milligrams as the active ingredients. This product is sugar and gluten-free. Check that the cap seal is unbroken before first using this product. Shake well before use. Take 10 to 20 ml after meals and at bedtime or as recommended by the physician. If you are under 12 years, it should be given only on medical advice. Always be careful to take the recommended dose. If you forget a dose, it is not necessary to double the dose the next time. Just carry on taking as before. If you take too much of this product, symptoms are likely to be minor. Some abdominal discomfort may be experienced. Do not take this product if you are allergic to any of the ingredients mentioned on the label. If you have been advised to follow a low-salt diet, for example, in some cases of congestive heart failure, kidney problems, high blood pressure and swollen feet, ankles, legs, body, ask your doctor before taking this product. Use with care if suffering from high blood calcium level, calcium load in the kidneys, or recurrent calcium-containing kidney stones. Do not take this product within 2 hours of taking other medicines. Do not use after the expiry date shown on the pack. Keep it out of the reach and sight of children. Do not store above 30 degrees Celsius. Do not refrigerate or freeze. If symptoms persist after 7 days of taking this product, consult your doctor. If you experience any side effects, stop taking the product and consult your doctor. You can also report side effects directly by mailing at consumerhealth_India@rb.com. By reporting side effects, you can help provide more information on the safety of this medicine. Take care.
Yeah, so thank you very much for being patient to watch this video. And it is just not the like video. Also, we have given the short time frame video to quickly go on. All the question answers in the drop down menus because if you can just come down. And also in the in this page also we have attached the PIL. If you come down because yeah. So this is also been attached. So if anyone wish to read it later, so they can download and they can also go on that. So ideally on this pilot, what this contents is been enriched with all what the patients or consumers, they want to understand how this product works. If I'll take a overdose, if I'll miss the dose, whether it has been safe for pregnancy or not, and even if they have the side effect, how to report on that. So it is been enriched with all the experience with the video audio format, which will give a maximum consumer engagements and they can understand their medicines in a better way. And as we know, the paper leaflets, I mean, sometimes the font size and there are lots of inconsistency. And even though millions of the paper inserts, which is being discarded every year without even watching on that time. So I think this is a great approach for this electronic labeling where we can, even though from sustainability point of view. So though there is not a near commitment, but as Dr. Gaurav said, lots of countries have been gearing up. And after the pandemic, there is a real opportunity to come with this electronic labeling. But definitely that needs to go with lots of overcoming the challenges. Can you just go to the last slides, because please. So as I stated, lots of collaborations has been needed, and also the data readiness, IT engagement, and initial setup for the industries and the collaborations with the regulators and patient organizations to make it successful. So lots of things yet to become. So, but yeah, I mean, it is a very good initiatives just to give all the informations. And very specifically, I would like to thank to Dr. Ratna, who has been associated with this project, and lots of guidance we came from what the information could be given to a patients. So, and obviously, I mean, this is one of the approach where we can phase out the paper leaflets in the future. So thank you very much to all.
Thank you. Thank you, Anwar. And a quick question to Dr. Gaurav. The video is pretty long and usually, the attention span of patients is short. So is it possible to have this compressed into small videos so that, you can look at sections instead of watching the whole video at one go? That's one very practical question. The second is, a lot of times physicians don't advise you on drug-drug reactions. So while we get the information on the product itself, suppose the patient is having heartburn because he's a diabetic and he's on metformin or some other medication, then is there some information that can be correlated so that the education of the patient becomes better and there is more information on, what other drugs could have either a lesser effect or a higher effect on whatever you are taking? Could that also be included? Because that kind of information is more informative than just the product information.
Correct. No, very rightly said, Dr. Ratna, that the attention span is very limited and sometimes the video becomes little longer and patient is not able to go through complete. So we have taken care of this particular thing, and we have divided the video into various smaller parts also, which have very specific information about one particular aspect of the drug. So there is when the patient lands on the web page, he has the choice of using and seeing only that part which actually he requires. So that way, shorter parts of the videos, they are also available on web page, customized as per the particular question which the patient or the user might have in their mind. Now coming on to your second part, that drug-drug interaction, this is also very important. And as we saw, that patient information leaflet is also available on that web page. Any patient, any person who wants to gather more information, they can go to the patient information leaflet. It contains all regulatory approved information, even on drug-drug interaction. So from there, the information can be gathered. We have right now, since it is on a pilot scale, only in one language. Going forward, we would be having all this information available in 7 or 8 languages. This is the work in progress. And we would again, once you have pointed out, we consider that what more information we can put about the drug interaction so that it becomes even more important and useful for the patient. Thank you so much.
Thank you. And I also noticed that you have given an opportunity for feedback by putting in an email. But then many people will not have an email and they are more app friendly, or if you're downloading this on a mobile. So would there be an opportunity to give a feedback in a more user friendly form than write an email? Because maybe a drop down menu or something like that, where you just click yes or no. Did this product give you a side effect? If yes, what are the things that can we make it more simpler?
Correct. We have toll-free number also available on the physical label. So that is very convenient. And I think you rightly said that writing an email could be cumbersome for some of the patients, but very easily they can pick that number, dial it, and inform to the consumer relation team about any information they want, or they have any concerns about the product, or even if they want to report any adverse event they have faced on the product.
So when they report, do they also get return, information on whether their information was acted upon? Usually what happens is you give the report, but then you don't know whether that information has been received and there has been an action on it. How do you receive a reverse feedback? Yes, that your information was received and we are looking into it. Or is that interactive, or is just one-way information?
Correct. Very important aspect you asked. So we have a complete setup wherein the consumer complaint or query is received. And then once the consumer query is received, there is a specific software in which it is entered, and it is then analyzed by the internal team. We have a risk management and vigilance team, which actually takes up the query from there. If there is a quality related to query, it goes to the quality team, and the whole complete mechanism and the channel is then followed. And all the queries, they are answered well within the time limits. If there is an adverse event which is reported by the consumer, then there are even regulatory guidelines to report it to the authorities as well, which is also being followed very rigorously. And we, even if the consumer is not reverting back on our first attempt, we have a mandate to at least follow it up for at least 3 times with the consumer, so that a proper information can be taken from the consumer, and whatever is the resolution, it can be further informed to the consumer or the patient about the product.
Yeah, but this information is not available in public domain. Meaning, if other patients want to learn from this experience, how can that be facilitated?
So the FAQs and the question answers which are there, they are made in such a way that most of the information about the product, which we think can arise as a query in mind of any user, is available on the web page. So we try to cover as maximum as possible, which generally an inquiry or a query can come in mind of a patient. But other than that, what mechanism we have is for any specific query which a person or which we cannot cover in our FAQs comes to us. So that way we try to, communicate with the patient in whatever best possible way we can.
Thank you. Thank you. That was very informative. So that actually leads us to our next speaker, Manveer Victor. Manveer, are you online? Can you hear us?
Yes, I am. Yes, I am.
Thank you. Thank you, Manveer, for joining us. So welcome. And Manveer will be speaking to us about patient-reported safety incidents, building the metrics and creating the system. And I think that's a fantastic topic to follow what we just learned about how patient harm can be reduced using digital means. Over to you, Manveer, for your session.
Good morning, everyone. Thank you for having me to be a part of this. I would love to be in India. Unfortunately, I can't. Last Friday, I had to do an angioplasty. So I am homebound for now, but still working. Thank you very much for having me once again, and very interesting discussions that you all are having over there that I've heard just now, and I want to comment something on about it a little bit later. But first, let me just go into a little bit of what I wanted to share right here for you all this morning in India, and let me just go to my slides here, and. So I think as we go to our second slide, if we can go to our second slide there. Sorry. So as you can see, we have to understand what the landscape is currently, right? With a world population of about 8.05 billion, which is of last week, we have only 65.1 million health workers. Now, this group is, of course, the workforce does have an immediate shortage. Now, this numbers that I'm getting is directly from the WHO, from their latest estimates, right? So in 2020, the global workforce has about 29.1 million nurses, 12.7 medical doctors, 3.7 million pharmacists, 2.5 million dentists, 2.2 million midwives, and 14.9 additional occupations, tallying to 65.1 million health workers. Now, give or take, it might be slightly higher, might be slightly lower right now. And according to WHO, of course, the Global Health Observatory data, there's an average of 53 skilled health workers for every 10,000 people. This is globally, of course. In every country, it's quite different. But you can tell me what the numbers are in India later. I'll just give you some of the numbers in Malaysia, where I'm based. Our population here is 32.7 million, and our entire healthcare workforce, both private and public, the total's up to about 370,000 staff. That is everyone in it, right? The people who work in allied health, health workers, and even the hospital management team. So it's 370,000 catering to 32.7 million. In your countries, it might be slightly different. So why am I setting this up for you all? Is for you to understand it is a huge uphill task for anyone in any industry to be able to take care of that many people, especially when you look at the landscape of the people that you're taking care of, these patients, they have a variety of illnesses. There's not just one illness or 5 illnesses. There are tons of them, as you can see from the doctors and nurses that you have in your own specialties. It has become very technical. It has become very specialized. And that is merely because their patients have different variety of illnesses. So how do we, at the end of the day, take care of this myriad of different illnesses, different patients, different backgrounds, like the issues that you all have, obviously the different languages? There's a variety of all of these things that are happening. Now, in the past 20 plus years that I've been involved in healthcare, mainly as a patient, then as a patient advocate, I have seen, and I have come from this background where when I first started on my patient journey in 2012, after I had my kidney transplant, I believe that the word patient had to be very, very strongly used. Today, about 11 years after this, I look at it and I say, we have to mix the word patient with consumer. And the reason I say that is because, unfortunately, when I deal with healthcare professionals, doctors, patients, doctors, nurses, and so on, when they look at me as a patient, they immediately imagine me in my worst situation. My worst situation that I looked the worst. So they have that image of me as a patient. So when they hear Manvir Victor, patient advocate, they immediately think sick person in bed, almost dying. They do not look at me as you see me today, as a media personnel, a patient advocate, international speaker, a reader of organizations like the Lancet and BMJ and all this, and a person who works in media. I currently work as an executive editor in the second largest news portal in this country. It's totally digital. So my expertise is managing over 100 over staff. So they do not see that. They have colored me with the word patient. They look at me in a bed and they think, oh, that's the patient. Therefore, he has no expertise. So while I'm talking about this, I'm asking you to color it with the consumer, because the consumer, the same person who is in bed, is also a lawyer, could be another doctor, could be an engineer, could be an athlete, could be someone else who has a different set of skills, tools, and experiences that can help the healthcare industry in itself. Can we go to the next slide, please? So what do we do today? With the WHO, with the patient safety unit that we have, the patient for patient safety unit, what we do is we train patients and consumer advocates to assist in healthcare delivery. After dealing with healthcare in the number of years that I have, I realized that there are two very important branches of healthcare. One is the absolute healthcare, which needs a clinician, an expert in that area. And then the other area is healthcare delivery. Healthcare delivery means the building of hospitals, the processes and systems, the parking, the complaints, everything else that goes into it, like managing hospitals, improving the systems constantly, digitizing healthcare, looking after cost, human resource, training, supply chain management, and obviously change management. Now, design and improvements to meet new challenges in the system, which means that this person is very much in touch with the latest technology. That is what is happening. And obviously, key to all of this is communication, both internal and external. Like Dr. Gaurav had just now shared, a very innovative way that Reckitt is doing to reach their consumers and to understand what they want. In the past, well, 5-6 years here in Malaysia, since I've been back, I realized that now and only now do I have in Malaysia a whole batch of CEOs of private hospitals who are not doctors. And this has been really helpful because when I sit down and I have these discussions with them, they understand all these things that I'm talking about because they are not medical professionals. Medical professionals go to university after doing very well in school, and then they become doctors and they specialize in some things. Now, these other CEOs have specialized in finance and human resources, digital healthcare, understanding human resources, supply chain management, understanding management, and they are building a more robust system of healthcare delivery to ensure that myself as a patient and others who come in as a patient can get the delivery of healthcare that they want in the least amount of time with the maximum efficiency and the maximum effectiveness of that healthcare within that hospital. So it is very important to use the words of patient and consumer in the same sentence. Because when you suddenly see a consumer like Dr. Gaurav and his team suddenly look at those patients who are taking their medication, and you suddenly see them, they are a consumer. They need to be reached in a different way. We need to have bite-sized information. We need to have focused information. Yes, there are regulations that tell us how to do this, but we can tweak it a little bit to make sure that the patient, the consumer who is buying that product suddenly has the information that they want in the shortest amount of time, rather than looking at a huge pamphlet in the smallest microscopic words because it is a page that you have to do with so many different languages. That's a challenge. But now when you've done it in a video, you redo it with AI and you reach people in different languages and getting straight to the core of that communication, it actually helps that healthcare being delivered to that consumer or patient. Now, I'm going to share with you something that I just got today as Dr. Parminder was mentioning just now, the Imperial College of London. This report was just sent in today. I had one quick read of it. And this particular sentence just stood out for me. It is the global state of patient safety. This is a report that has just come out. Afterwards, if you want, I will reshare it on my Twitter or X handle if you guys want to read it. Now, this Imperial College of London report that just came out today on the global state of patient safety, this sentence really stood out for me when I was looking at it. It says, a positive and just patient safety culture remains an elusive concept in many countries, while the involvement of patients as active participants in care has been slow to spread, particularly in low-middle income countries. Hierarchy often still overpowers the option to speak up, and organizational reputation can overshadow the importance of transparency or candor when an incident happens. So that one really stood out for me. And it is obviously very important for us to realize that engagement needs to be constant with the patients, right? And the reason for this is once you have a patient or consumer advocate that is trained by the WHO, working in your hospital, and I use the word working very loosely, they don't have to be employed, but they are a patient that may be in your hospital that you have chosen. You send them to your local WHO organization committee there, and they are trained. And what happens is they come back and they sit on your patient board, your visitor board. In Malaysia, it's called a visitor board. In other countries, it's called a patient board, and they sit with your doctors, with your nurses, with your staff, and they go through RCAs, root cause analysis that can happen. But what happens is now they have a patient's view on it, they have a consumer's view on it, they have been trained, so you can look at them and say, these people are approved by WHO, they've been trained by WHO, they understand confidentiality, they understand the seriousness of what they do, rather than just a simple lawyer or engineer who you may put on that board but has no background information. So it's very important to have trained patient and consumer advocates to be a part of this. I'm just going to end right now with my last slide, which is just basically just to share with you. This is how you can connect with me. I'm available on social media, of course, on X, at Manvir Victor, LinkedIn, FB, everything there. I also have a podcast, which is called Healthcare Today with Manvir Victor. It's available. I'll share it once again if you want to. And it's heard in 15 countries. And basically what I do is I try to unpack the technical conversations and have it very simply with doctors, with specialists. We've had topics like autism. We have talked about medical marijuana. We have talked about cardiac care. We've talked about transplants. But again, it is in a very simple language with the experts in the studios with me, having these conversations, but making it simple enough that other consumers and patients who want to find out about better healthcare, they are able to understand it in their own language. Because at times I find, and we have all found, obviously, that doctors and nurses tend to speak in acronyms, and they've got their medical jargon. So the rest of patients are left out of that loop. So we're trying to simplify it for a mass audience. We have found it is quite popular in that sense, because from a patient's point of view, I read a lot, obviously, trying to understand, and I have a lot of doctors around me that I'm constantly having communications with, trying to unpack actually what it is before we are talking about it. So once again, I guess my message is going to be very simple in that sense, that we need to, if you want to reach the larger audience, which is 65 million healthcare professionals trying to take care of 8 billion people, it is not possible. It is impossible unless you engage. And part of that is obviously communicating, reaching out with people and having them understand what you're saying in their own languages. I have to commend Dr. Gaurav and his team for taking that initiative to do something like that. We haven't done that yet here in Malaysia well enough, but I am thankful to every one of you guys for having me and having this conversation. I hand it back to you, Dr. Ratna.
Thank you, Manveer. And you were one of the early adopters in creating the Patient for Patient Safety Malaysia. We are still starting with baby steps and, laying the context of the healthcare workforce deficiency and why patients should be at the center of patient safety is such an important topic. And Arsha is now doing exactly what you're doing in the context of India. She's a pharmacovigilance expert. She has had a personal experience that has driven her to become a passionate patient safety advocate. And she's also the founder of an organization called PHV Fit. And I'd like to invite her to speak a little more about how she is trying to educate. She has a thought leadership that tries to educate CEOs and other senior level leaders and administrators around patient safety. Over to you, Arsha.
Okay. Good morning, everyone. First of all, I would like to thank Fair Academy and Dr. Ratna for inviting me and giving me this opportunity to speak at this forum. It's so wonderful to be amongst change makers in healthcare. And it has been really enlightening for me to listen to everyone yesterday. Just give me a second. Okay. So the topic I am going to talk about today is empowering patients to identify and report patient harm, which is very, very important and which is something that we've been talking about. And I've been in the career of pharmacovigilance. And, after some time being in this profession, I realized it's not just the job. There's much more to it. It's not just about reporting the side effects of pharmaceutical companies, creating the safety profile. It's also about creating awareness and mitigating these side effects. And that will only happen if there is awareness amongst the various stakeholders. And that's how I started my work with PHV Fit, which basically translates to Pharmacovigilance Fit. And it's a thought leadership forum that works to create awareness at different levels on patient safety. So, thank you. So when we talk about patient harm, there are certain aspects to it, which is very important. And as Dr. Ratna said, I have been a victim of patient harm. When I started speaking up about patient safety, it was just out of because I really felt for this cause. But then in the journey, I experienced medical malpractice and patient harm, and that gave me a real hands-on experience of what a patient really goes through when that happens. And it's not just the physical aspect of it, it's also the mental aspect of it. And what is it that the patient really needs at that time? So, there are like OLHA, I would say that the 4-step thing. The first is to observe when the patient harm happens. And the second and the most important aspect, what the patient really needs is somebody to listen to them. Is anybody listening? And, various parts to it is acknowledgement of the patient harm that has happened.
concern and empathy from the reporting systems of the healthcare providers or the government on what has happened. Third is, of course, the help that the patient needs at that time, whether it is on the follow-up treatment, the compensation if they have been wronged, the right guidance to take the right steps, medical legal assistance, and finally, and the most important, it is about how this patient harm will be stopped from happening again to other patients. And I think, having experienced this, that's the most important thing for me at this point of time. That what happened with one patient should not happen with other patients. And that is why it is important that the healthcare system learns, corrects, and prevents future harm. And that's the importance of patient stories. And there are a lot of efforts that are already happening when we see the Global Patient Safety Action Plan, when we see the patient safety challenges the WHO has been doing for so many years and different countries following them. A lot has been happening. So to talk about the third Global Patient Safety Challenge, that is 2017-2022, you see the very important aspect, and one piece of it was, a portion of it was about patients and the public, how to engage, involve patient organizations, reporting by patients, patient engagement, and eventually the public awareness on medication safety. Now, this was launched in 2017. Medication Without Harm aims to reduce severe avoidable medication-related harm by 50% globally in the next 5 years. That means by 2022, that was targeted. But of course, we all understand, probably also due to the COVID pandemic, we have lagged behind. So to cover that up, we have the next, the Global Patient Safety Action Plan, that is from 2021 to 2030, which has the strategic objective 4 that Dr. Gautam also talked about, which is patient and family engagement. It is to engage and empower patients and families to help and support the journey to safer healthcare. So one very important statement in this document says, collaboration with patients builds a strong foundation for healthcare system improvement. Patients travel through the entire healthcare system, and so they are more likely than health workers to have a holistic view of it, rather than a focus on one small part of the system. Patients and families are the end users of the healthcare system. They're often the only ones to have full insight into the outcome of their care. Their perspective on how care can be made safer is invariably very valuable. My question here to everyone, do we all honestly believe in this statement? There will be a lot of stakeholders who may have differences of opinion or doubts. Is patient? Yeah. So like I said, so do you think we all believe honestly in this? And one reason for this is, and which is something that we've been talking about since yesterday, is lack of health literacy in our country. In our country, or worldwide, I would say, for that matter. So let's talk a little more on the strategic objective 4.2 and what it includes. And it gives an action plan and how the patients should be involved. What is the way this Global Patient Safety Action Plan and the goal of reducing the harm in multitudes can really work out. So the first, there has been an action plan charted out for different stakeholders. First, for the governments to establish platforms, networks, and events to bring together patient safety advocates, champions, patients, and patient organizations to share their experience of avoidable harm or unsafe care and best practices in patient and family engagement. Then and this is something that's happening already, like we are sitting here in the International Patient Summit today. Create mechanism and strengthen platforms for sharing healthcare experiences of patients and families, including patient reporting on outcomes and experiences that highlight patient safety problems and point to solutions for patient safety improvement. And at various levels in different countries, this has been happening. If I give you an example of EMA, so EMA is very actively involving patients towards safer healthcare. And in 2018, there was a public hearing where patients and patient advocates have been involved, towards, a medication side effects and how they can be mitigated and what action plans should be taken. Then to ensure that the patient and family experience of harms informs the design of and information. Then is the action for healthcare facilities and services. Create a culture and organizational framework whereby the encounters and experiences of patients with avoidable harm told by themselves are an integral part of all patient safety work within the organization services. And it is very, very important. And that's where the real change is going to come. Then to include a patient and family experiences told by themselves. Of course, the importance of patient stories. And finally, to create patient reporting mechanism, patient safety reporting mechanisms that encourage patients and families to report. And by collecting and collating and analyzing patient-reported experiences and outcomes of unsafe care, demonstrate actions for learning and improvement. So why will patients report? The patients will report if they see there is a, eventual outcome that they see, and also to inform patients on how their reporting has helped. Then again, action from other stakeholders to organize national and local workshops, symposia, ensure that professional associations, specialist societies invite patients and family members with patient safety experiences to their annual conferences. And finally, there are actions for the WHO Secretariat to provide advocacy to member states to create mechanisms to learn from patient experience, develop tools and guidance to collect, collate, and analyze patient-reported experience and outcomes, and finally, to create and maintain a global collection of stories from patients and families with experiences of safe and unsafe care. So this is all, anybody can find the Global Patient Safety Action Plan on internet. It is a public forum document, and you can read what exactly the WHO has in plan for different countries and worldwide. So what is the way forward? So we talk about what is the action plan. It's also important to talk about where we are lagging and how we can really achieve it. So the first and foremost that everybody knows is patient education. And we just talked about, and Dr. Ratna posed a very important question there. Do we all read patient leaflets? And if we do not, what is the reason for that? I read patient leaflets because I've been in the career of pharmacovigilance. I knew very early when I started my career, so a medication can cause a side effect, and I could understand, I could see how much impact it could have. And that is why I became a little more regular in reading patient leaflets. But because this information or this knowledge is not disseminated in a way that patients can, feel the importance of it, we do not do that. So the first and when we call about patient education on patient harm, there are various aspects of it. First of all, of course, reading the leaflets. Now, if the patient harm has happened, where to report, why to report. And I think since not everybody here knows about pharmacovigilance, the first and most relevant question would be, why should I report? How is it going to help? And we being in the industry of pharmacovigilance, and I've worked with major pharma companies, and I know that when patient reports from healthcare professionals come, it defines the safety profile of a drug. And it is very, very important. The pharmaceutical companies are working day in and day out. There are strong regulatory requirements to report side effects so that, the signals for new events are identified and the leaflets are updated, or, so many times we hear that a drug has been withdrawn from the market. That happens because of active pharmacovigilance. But active pharmacovigilance cannot happen if there is no reporting. And the reporting is not just for healthcare professionals, it is also for consumers, and it becomes a responsibility. Then, then also it is important to make people aware of. So it is important to make people aware of the prescription, why, it is important to use medication safely. and why the prescription medication should not be taken OTC. If I give you an example, so there's been a very recent alert that PVPI shared on metal scars. Now, when we are talking about education, it is also about, and these are the alerts that PVPI or Pharmacovigilance Program of India regularly sends to the healthcare professionals. Now, for this time, this has because it's a very common medication. It has been been taken up by the media and circulated, and that has come with its own different, I would say, reactions from the public. Where now there's some panic as well. So I would say when we are educating patients, which is also important to educate, to sensitize them in a way that doesn't create panic. Again, education needs to start from a very, it cannot be abrupt. It has to start from maybe at the school levels, where medication safety education should become part of the curriculum. Then again, training for healthcare providers, and we've been talking about the paternalistic approach sometimes the healthcare providers can have. And when we are sensitizing about patient and family engagement, it is also important to train our healthcare providers to have empathy, to understand and to respond in the same manner to the patient, and to respect when they are sharing their concerns. Then clear communication, right messaging. And we're talking about the patient advocacy groups, the patient safety campaigns that have been are being carried out in different organizations or in different countries and this is sensitizing the public on the importance of patient safety. Reporting systems, feedback mechanisms, and this is a very important aspect that there are different kind of reporting systems. There are healthcare reporting system in hospitals. We have medical councils where the patients can report. We have CDSCO, the regulatory authorities where the patient can report. Different feedback mechanisms. Then it is important to integrate technology into reporting and into making medication safe. And one example that Dr. Gaurav and Dr. Mohammed shared was the QR code and the information that the patients need, the authentic information that patients need, and technology can really help there. Then again, anonymous reporting options, because sometimes the patients or healthcare professional can hesitate to report because of certain fears. So anonymous reporting options can really help. Whistleblower protection, incentivizing reporting, because and probably incentivizing could be also publicizing the success stories when patients or healthcare professionals report patient counts, how it has helped in defining the safety profile or defining this safe medication practices. And this is my last slide. So it's just one more thing that I would like to talk about. So as I talked about, EMA has been actively involving patients. So so there's a drug called valproate, which could cause teratogenic effects in pregnant women when taken. It's taken for epilepsy or bipolar disorder. And it's interesting that irrespective of, and this is a report that I share from Europe, where there is a lot of sensitization. There's a lot of information that patients are provided and healthcare professionals are really aware. In spite of that, 1 in 5 women taking valproate do not know about the risks of pregnancy. So I recently wrote an article on how it is important to disseminate information in a way that the patients are able to take it up and really assimilate that information to mitigate the patient's harm. And there are ways that needs to be done for it. So right communication and right ways of, as we say, patient language summaries, and a constant interaction with patients, healthcare providers is very important for ensuring that the patient harm is mitigated. That's all from my side. Thank you so much for listening.
Thank you. Thank you, Arshia. That was extremely interesting. We are running a little over time, so we will not be taking any questions. And for the next session, I would encourage people to bring their tea to their table so that we can use the coffee break for the session as well. So thank you, and over to you, Bhavna. Thank you to the panelists. Thank you for your insights. Thank you.
Yes, sir. Give us a minute, please. Very elaborative and explanatory session to how we can decode the outreach of patients to correct information to make it patient-friendly and supportive. We are diligently covered how database is and registry process is important yesterday. Also, I would like to make a note that please, this session is casted online on YouTube. Please share the links with your collaborations, hospitals, medical colleges, near and dear ones, so that we successfully acquire our purpose of spreading the awareness. Thank you. Please, a big round of applause for the panelists and a wonderful session we had. Very insightful, ma'am. Thank you.
Thank you.
Moving forward to our next session on live post vaccination, I'm honored to please invite Ms. Chitra Gupta, Lead Patient Advocacy, Pfizer Inclusive. Ma'am would be chairing and moderating this session. We are honored to have you here, ma'am. Please join us. A round of applause for the lady, please. I'm privileged to please invite Dr. Raj Shankar Ghosh, Senior Advisor, Environment Health, Public Health Foundation of India, Senior Advisor, Immunization Path. Please, sir, can we have you on the stage with us? Please, a great round of applause for Dr. Raj Shankar Ghosh here. Sir would be covering vaccines as a life-saving measure. Thank you, sir. A warm welcome to you. Please allow me to invite Ms. Nilima Dwivedi, Executive Director, Market Access, MD. Ma'am would be joining us online. She would be putting the points forward on adult vaccination and challenges for uptake. Thank you. Next, our eminent speaker would be Dr. Safarik, Division of Epidemiology, Department of Public Health, Ministry of Public Health, Thailand. So would be covering on vaccines for all, improving access. Next, I take the opportunity to please invite Ms. Nelia Medina, Board Member, Philippine Alliance of Patient Organizations. Ma'am would be covering patient-led vaccination campaign. Please, a round of applause for the panelists here. I leave the stage to ma'am, Ms. Chitra Gupta, the chair and moderator for the session. Thank you, ma'am.
Hi, good morning. So I think I'll request people who are standing and having coffee also if they can join. But otherwise also, thank you so much for being here and spending time. All of you are patient advocates. So don't worry if you have few seats who are empty around you. You have many, you own the responsibility and you actually have responsibility towards many patients. And this topic is very important, not only for a particular group or population or a disease area. So in this case, you can visualize your other patients and your peers around you and think about it. And also, most of you, if you see during the time of COVID, has also advocated either to the government or within your patient groups and other stakeholders to prioritize your groups for the immunization, prioritization for the immunization against the COVID. And this topic is quite similar in that sense. And the experts here are going to talk to you about the importance of immunization to all the age groups, not only limited to the infants or the young adults. So in that sense, I would now want to have a test, simple test with all of you. There is a booklet in your bag. How many of you have seen that booklet that talks about the immunization? If you have seen, if not, please take out your bags, the books from your bags and see that booklet. That's very important, eye opener, and you will realize that you will find any of one of at least something for your respective groups, relevant information regarding immunization to that in that booklet. So it's very, very important. If you don't have, please, I can ask even the organizers to provide a few to the people, one on every table. So this booklet is very important. It provides very eye-opening facts to all of you that what is the vulnerability of various risk groups for the vaccine preventable diseases. And with that, I want to invite all our panelists who are joining online or with me here on the dais, and Dr. Rajshankar Ghosh, Neelima, Dr. Sufrak, and Ms. Mania. And they're joining here from Indonesia, Philippines, India. Dr. Ghosh has experience of various continents, not only in India. So it's a very rich panel. And just any one of you who is taking back few messages is going to be, I think, successful panel for us in that term, because it's very, very important for all of us to understand our risk and vulnerabilities towards the various vaccine preventable diseases. So with this, I'll just pass So if you have the book and you could open that book, you will see a lot of facts which are presented in that book, which talks about the 3 to 10 times higher risk of getting pneumococcal pneumonia in various risk groups, like people with asthma, smoking habits, lung disease, diabetes, heart disease. And if you go to the next page, again, you will see that all the adults aged above 65, their vulnerabilities towards pneumococcal. And same is actually for influenza. And if you see, there are various other vaccine preventable diseases where your vulnerability is indicated here, whether it is for the people with chronic lung disorders or diabetes, hypertension. So you will see, scroll through the pages and you will see one of various data points which you will be able to correlate. So and I know why I called to lead and chair this session is because of my work, which I have done for almost 2 years. And before joining Pfizer, that was all about, categorizing the entire population. And the same categorization, I think, is applicable to every country, every population across the world, where we divided the population into various risk groups. And that is non-pediatric population, because we all are very clear and we all have established schedules, vaccination schedules, plans, strategies, system backing the immunization for the pediatric population. But this is all about pediatric plus non-pediatric population. And if you divide 0 to 20 is a, pediatric and young population, then 20 to 40, 40 to then the rest of the population. So if you see that 0 to 20, we have a quite well-established schedule. At least India is able to do a remarkable work in elimination of various vaccine preventable illnesses and management of like polio. Even the sustainable development goals are achieved by IMR, MMR, using vaccination as one of the most important and pivotal intervention. So with this, if you see, but we are going to talk more about the 20 to 40 and 40 to 60, where 20 to 40 population in most of the countries is living with comorbidities. At least if you see the data, I think one comorbidity in a it's a sizable number of population, and when you become elderly or aged above 50, the number of comorbidities goes high. So if you see these data points, I just showed you, I'm not going to read all this. So if you see, it talks about the comorbid conditions. So if you see that more the age, the number of comorbidities are increasing. And I'm talking about these are the published data and mostly Indian data. Then the prevalence in various comorbid conditions. Then if you see the incidence ratio of vaccine preventable diseases for adults with comorbidities, influenza, pneumococcal, and if you see with the comorbidities, the prevalence and the incidence is higher. And all this is published in the report, which I can share the details. It is available publicly. and you can download. It's a beautiful report from India, which actually can be used by anybody in that country. So if you see the lot of vaccines proposed by various organizations, I am just quoting just two, but otherwise there is a lot in that report. So if you see the vaccination, which is by various clinical associations, and many of these are part of various immunization plans also. And there are various government plans, schemes, at least in India, we have a very well established system of taking care of various population risk groups. Like if you see, there is a plan for NPCDCS, that is a plan for various non-communicable diseases. We have a program for hepatitis. We have dialysis, national program for dialysis, and people with dialysis or renal transplants, they are immunocompromised, like oncology also. So their vulnerability towards infection is very high. Then we have a national plan for sickle cell, elderly, palliative care. So all these things are there already in place. Where immunization still after the COVID, with the learning of COVID, is picking up, but I guess it is still a long way to go. And with this, I want to start and take my first question with Dr. Ghosh. That Dr. Ghosh, we have already a lot. You have a lot, huge experience of polio and many other immunization, successful immunization plans, and I'm sure you have gone through hell amount of challenges which all of us can not even visualize. So with this and the data which I have presented little bit through the slides, that growing elderly population, which is expected to grow 320 million in India by 2050, which is going to be, I think, every 1 in 5. And we want to celebrate, our senior citizens and elderly population and aging. We don't want to make it as a burden. And there is a lot, which again, in terms of the number of hospitalization, propensity, vulnerability of people with these comorbidities or elderly for the various vaccine preventable diseases. Still, we are trying to cope up and see how we can protect them. So with this, I want to understand with your vast experience, sir, that how do you see, what do you feel that how we can enhance the coverage to the non-pediatric population? Not everyone, but at least to prioritize the risk groups. We have a lot of programs, and I know in a country like India, especially, bringing anything into a program is a very difficult situation to tackle because it's a lot of responsibility comes on the government. So in that case, what do you see, whether we should focus on policy making first and then enhance the coverage, or you would suggest that we should start practicing because guidelines are already available by various clinical associations. There is a support system. So how do you see practice or policy? What do you think which should start with? We should trigger the coverage. And I remember our previous discussion, and we see the healthcare workers. So there are many such vulnerable populations. Where do you see? And in my during my study tenure, when I did this 2-year study, I saw healthcare practitioners are the one who are not still taking many vaccinations, and their vulnerability is very high. So practice, barriers, and or policies. So how do you want to your guidance towards that, sir?
Thank you. So first of all, I really wanted to thank the organizers for inviting me to this very important conversation. Irrespective of the number of people there are in the room and online, I do, want to emphasize that this is one of the most important conversations that we need to have in today's times about quality and safe healthcare delivery. Coming back to your question around, whether the policy is first or we start the program. There are two aspects on any public health product delivery. One is around the regulatory affairs. If a public health product like a vaccine, a drug, or a diagnostic is approved by the regulatory authorities of India, the Drug Controller General of India, then that product should be available for use in the country. There is nothing that should stop it from being used in the country. However, there is always an advantage of the policy. The advantage of policy is around three things. One is in order to ensure that the quality of the product that is being delivered in the right manner. The second is in terms of prioritization, which population should get it first, which population, how the program needs to be staggered. And the third most important thing is about the safe use of the product in terms of having some regulations around how to use the product so that it causes no harm. In case of, public health product delivery, one of the most important things that we need to remember is that it should cause no harm. Now, having said this, whether we wait for a policy for the program to scale up or whether we start the program, there are various ways of doing it. But one thing that we will have to remember is that there is an urgent need, and I was listening to the online deliberation about the healthcare workers in terms of their efficiency, in terms of their sufficiency. We need to have sufficient numbers of healthcare workers who are trained and their capacity is built in order to deliver the product. It's not just about delivery of the product. In my experience of vaccine delivery, I have seen many adverse events following immunization. In almost all the cases, it has been because of operational issues, because the healthcare workers were not trained. So I am not an advocate of using a product because it is available in the market without ensuring that we have the quality and the capacity of the workers who are delivering the program or delivering the product.
Thank you, sir. So with this also, like your views on, as I told you that while we were doing this study and the almost 100+ experts within the country were consulted, I think one of the top reasons that came to the low adoption and immunization to non-pediatric adult population is the physician awareness and their own immunization for their own vulnerabilities, which is very high. There are case studies in the report where the episodes of outbreaks to the physicians and through the physicians are also captured. So again, like, how do you suggest that we should prioritize again the public awareness or the physicians awareness? Even the public is aware, I think they go and demand, I think physician will certainly go and again start working on this. But still, do you think the physician awareness is more important to prioritize than public awareness, or should go in hand in hand?
First of all, when we speak about awareness, there are 4 A's that we always speak about. One is obviously awareness. The second is access to the product. The third is around the affordability of the product. And the fourth is the availability of the product. There are multiple products which are available for the adult vaccines. For example, if I take the HPV vaccine, cervical cancer vaccine, which is for the adolescent girls, even 1 year back, there was not a sufficient supply globally in order to meet the demand. So therefore, we also need to ensure that there is availability. Coming to your point about awareness, I think it is in today's world, if we say that there are no avenues of making people aware, I think it's a shame with the
something which the country has realized the burden and the importance of vaccinating okay, Nilima is also here now. So Nilima, can you hear us?
Yes, I can. And sorry, about there was some confusion. Initially, it was in the afternoon. So, yeah.
So we have Dr. Ghosh. If you were not able to speak, I was asking your question to Dr. Ghosh. So Nilima, vaccine preventable cancer, that's the only cancer, cervical cancer, that is vaccine preventable, right? And
Right.
so I would like you to, discuss with this group about the HPV infection and the cervical cancer population, the women, and various other cancers which are also caused because of HPV in men, head and neck cancer, and maybe others. So, and now India has recognized the burden and value of immunization and its consequences in managing this next upcoming, maybe the epidemic or pandemic. So I would like to understand the journey, and we all understand now that this vaccine is guided by ANTAGI for inclusion in NIP. So that's in itself is a remarkable achievement and acknowledgement of from the government on the importance of this achievement in terms of a vaccine for a cancer, HPV, is cervical cancer. So I want to understand your journey and the challenges and learnings which can be adopted and taken up by other areas, risk groups. So with this, over to you. And I know it's a very exciting journey through our various interactions, but I think it will be interesting if you share it with the audience.
Thank you. Thank you, everybody, and good morning. So, we all know that cervical cancer is ranked one of the most frequent cancer in women in India. And also the data which we keep talking about, that every 8 minutes a woman is dying because of cervical cancer in India. So we understand the severity, we understand the disease burden in India, and there are various reasons about it, and all the experts sitting over there very well recognize the reason. Awareness is one of the key. But if you look at uh, 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 so India has basically 1/4 of the global disease burden. So when we talk about elimination of cervical cancer, which is WHO, in fact, commitment uh, that by 2030 it needs to be eliminated. If India does not participate in this entire elimination campaign and does not implement NIP in the country, I don't think this is going to be possible. With the disease burden of 1/4, which is 25% of the global disease burden, India needs to participate. India needs to bring in its NIP. Hope I am audible, by the way. I am seeing myself
Yes,
on mute.
yes, you are. You are.
Yeah. So that's about the HPV. There are various serotypes, and this is the only cancer which is preventable. So we need to really see that this is a preventable cancer, and with vaccination, with 90, 70, 90 strategy of WHO, it can very well be prevented. Screening and vaccination are one of the key, followed by, of course, treatment. Uh, so this is the only preventable cancer which can be prevented through vaccination, and elimination. What we talked about is really the key which government of India needs to think. When the Nigeria and the other African countries can implement, why not India? It was initially, there was a buzz, there was a discussion, which later on, but we are yet to see the implementation part happening. In addition to that, I also wanted to talk about that we need to really shift the paradigm from maternal and child health to women health. So the discussion what most of the time we have are mostly towards the maternal and child health. I think now this is a high time, and we need to really bring that shift, the paradigm shift in the discussion. And now we should discuss more towards the women health, and also political commitments towards achieving WHO elimination goal at the state level is key. While we all know that while NIP will be implemented and announced at a state level, but at a central level, but health being a state subject, I think somewhere a state will have to also take a lead and really, I think, keep it as a goal. The third thing which I wanted to also talk about, the standardizing the benchmark towards HPV DNA. So one, of course, we talked about 90/70. So one is the testing, the screening, screening whether it is VIA or Pap smear or in fact the DNA testing. Um, so testing for the mothers and vaccinating daughters. So that kind of campaign needs to be really in place, and creating a robust data monitoring platform integrated with the screening. In addition to that, we need to also create a mechanism at the grassroots level, integrating all our PHCs, sub-centers, CSCs with tertiary care referrals wherever it is necessary. So I think we need to really work when we are talking about elimination of cervical cancer. So vaccination and screening are the key, and it has to be right from the grassroots level. And public-private partnership and also CSR support needs to be integrated. So companies like us are very much committed to work with the state government in public-private partnership in creating awareness about cervical cancer, and also for any kind of vaccination program, vaccination and screening. And then mass media awareness is the key. So these are few of the things which I really wanted to call out when we talk about HPV, because we all know that it's not only accessibility, but awareness is one of the key. Still, people feel that cervical cancer is something which happens in the neck. Still, that is the level of awareness we have in the country. So how can we really work towards this to create more and more awareness? How can we bring our parliamentarians, our policy influencers, all our patient group organizations sitting over here? I think this is the high time we all need to work together in a single voice, that that yes, this is high time, and India really needs to gear up and work towards elimination of cervical cancer. And HPV, as Dr. Chitra, you mentioned, it's not only cervical cancer. There are various other cancers which are attributed towards, like head and neck is one of the key cancer, what we are seeing. Also, the vulnerable population, the population which are on ART, right? In fact, yesterday when I was there in the conference, I happened to meet with a gentleman who was talking about this. That what about the vulnerable group? I think they also require because they are quite prone. So the patients who are already on ART, how can we really provide them a vaccination because they are immunocompromised? How can we really help provide them access to vaccine through government channel, so that they are prevented with such kind of infections? Yeah, so I'll stop here.
Thank you, Nilima. If you would have not used patients and patient advocates in your entire comments, I would have reminded you, because they're listening and they want to understand whatever community and risk group they represent. But this particular immunization is not related to any particular disease and all, but it's all related to the young girls. And I think it's up to the age of 45, Nilima, if I'm not wrong.
Yes.
It's
Yes.
indicated up to the age of 45, right? So
That's right.
up to the age of 45, we can take the vaccine and we can prevent ourselves. Although as early as possible is always going to be helpful. And Nilima, I have another question for you, but probably I'll go to first Dr. Nilia and Dr. Suprek. And then I have another question which you can prepare in the meantime, the thoughts around the excellent material which you have provided to the participants around the immunization, need for immunization for pneumococcal or influenza and the vulnerability risk profiling and all these things. So I think I would like to ask you about the elderly population, which is, I think, very much highlighted in the booklet. Also the need for various immunizations. And also I know one of the topic which you love quite a lot is the access through other channels, non-government, private sector channels like insurance and others. So with that, I'll come back to you, Nilima, and I am moving to Dr. Suprat. Dr. Suprat has was introduced in the beginning to the detailed profile. He has done a lot of work. He's from Thailand, Department of Epidemiology, Division of Epidemiology, Department of Public Health, Ministry of Public Health in Thailand. Dr. Suprat is epidemiologist and has worked as a medical doctor and has done a lot of work in surveillance. And that immediately takes us to the evidence and the evidence-based decision making for any healthcare question to be answered. And here we are answering and talking about the immunization. Talk about the National Vaccine Security Policy and the strategic plan, which was developed under the National Vaccine Security Act in 2018. And its vision statement is that everyone in Thailand has equitable access to high quality and affordable vaccines. It has 4 strategic covering the following areas: immunization, vaccine research and development, production, human resource development to support vaccine work and capacity building. So with this, Dr. Suprat, I would like to request you to again talk and consider we are talking, and the listeners of this entire discussion is our patient groups who are representing hundreds or thousands of patients in their own respective disease areas. So my question is, how has this entire planning, strategic plan and the National Vaccine Security Act has improved the access and availability of vaccines in Thailand? And does this act also cover adult non-pediatric population? And what are the success and challenges, and how do, and if you are covering adult non-pediatric population, is there anything or any mechanism where you are prioritizing either the vaccines or the risk population? So with that, over to you, Dr. Suprat, and thank you for joining us and giving us your time and talking to us.
Okay, sure. Hi, everyone. My name is Suprat. You can call me Pai. So thank you for your questions and having me today. So Thailand already has the national. Okay, so you have this slide. So I will go through in this slide real quick. Next slide, please. Next slide, please.
Like.
Yep. So I will call you a bit back to the COVID-19 pandemic. I know everyone is talking about COVID-19, and people seem to talk about the COVID-19 success story everywhere. So I won't go in much detail, but just want to recall. Next slide, please. Yes. So during the COVID-19 campaign, I'm pretty sure that every one of you have got the COVID-19 vaccinations in every countries, in India, in South Korea, in Indonesia, Cambodia, United States, or even the EU, in European Unions. So at that time, we start like a system that we have to get every people in Thailand to get these vaccinations, regardless of their age, regardless of their nationality, regardless of their ethnicities. So, but in that time, you could see that in the pictures, the vaccination cards are all in paper-based. Next slide, please. So in that case, we create the Ministry of Public Health create a digital health system that we call the MOPROM, which the name is the MO is the doctors, and the PROM is mean like the ready and promptly. We using the line application which is similar to the WhatsApp applications and all in the smartphone applications for every people in Thailand during the pandemic. Next slide, please. And this is the overall structure. So we are more like a create this infrastructure from scratch to just accommodate the COVID-19 vaccination system during that time. This system did not exist before the COVID-19 pandemic. Next slide, please.
It is fine now, please.
Okay. And in Thailand, there's we have special the place that people can get the vaccine. Not only people we just talk about the hospital, regardless of the size and the urgent care, but in Thailand we also expand the accessibilities of the vaccination system outside the hospital, including the pharmacies, dental clinics, urgent care, or the private doctors' clinic, and also even the laboratory clinics also can able to give access to the COVID-19 vaccine during that time. Next slide, please. And this is the signage that this place had involved in the MOPROM system. If the patients can see this sign over the pharmacies or over the private clinic, that means that they can come and get the COVID-19 vaccination for free for every people. Next slide, please. This is important because during that time, the COVID-19, we also had the side effect survey because the vaccines is very, very new, and we have to gather the data to make sure that all the vaccination is safety for patients that receiving the vaccination during that time. Next slide, please. And I think everyone will also remember that when the lockdown was subsided, everyone is going to travel around again. And in that case, we also require to have the vaccinations certificate, including the World Health Organizations and the European Digital COVID-19 certificate as shown in this slide. Next slide, please. And this is the dashboard that allows us to monitor the vaccine coverage and efficiencies of the COVID-19 vaccine system in real time during the COVID-19. In this case, the ministry can also allow the vaccinations allocations in real time to make sure that everyone can get the vaccinations in time. Next slide, please. I mentioned a lot about the COVID-19 because most of the system I already mentioned did not exist before the COVID-19 pandemic, and which means that we are going to use this system after the COVID-19. Next slide, please. This is the Thailand National Vaccination Act that many people already mentioned. To answer your questions, these vaccination acts cover every people in Thailand, from infant to adult and elderly. This is, I'm sorry that in Thai, this is the vaccination plan for everyone in Thailand, which people can get the vaccination for free. Next slide, please. And after people get the vaccine, they will get their vaccination record, but it's still in the paper base. This is the yellow book that we use for the yellow fever vaccine, and the paper based format is still exists during the COVID-19 period. Next slide, please. And this is the what the ANC, which the mother, the planned pregnancy will use during their antenatal time. The paper book also contain the vaccination record for the mother and her infant. Next slide, please. And why I'm mentioned about those paper-based record and COVID-19 because we are trying to adopt the system that we created during the COVID-19 pandemic to use after the COVID-19. This slide shows the MOPROM application system that I already mentioned. It's not just show the vaccination record, but we also show your diagnosis, your healthcare data on your mobile phone applications. This is Thailand digital. This is the Thailand National Digital Health that can get that you can see your own personal health record. Next slide, please. And this is the routine vaccination record. The digital vaccination record is very important because normally patients will lose their paper-based vaccination record, and many times they will get duplicate vaccinations and they will get complications from the vaccine. So in this case, we try to adapt the COVID-19 vaccination system to make sure that now everyone in Thailand will have digital routine vaccination record, which means that everything that I already showed the Thailand National Vaccination Act will also record digitally on this application system. I mean, every single Thailand citizen will have this vaccination system from now on. Next slide, please. This is important because when we have digital system that we can collect the vaccination coverage in real time, the ministry and the minister and the governments can decide on like which vaccination is lacking and which area that we need to increase the coverage. Last month, the government just have a campaign on the free HPV vaccination, 1 million doses for all our countries. This dashboard uses the same system that I already mentioned. Next slide, please. And this is also a dashboard that also use the same mechanisms. From this dashboard, the government and the ministry can see the coverage and the progress of the vaccinations in real time. This starts with the HPV vaccine, and we are expanding to the rest of the routine vaccines campaign. By the end of next year, the Thai government can see that how is the vaccination campaign are doing, which populations and which area need to be prioritized to increase the vaccinations coverage. And we also tracking the vaccination side effect. In that case, we will make the vaccination campaign efficiency with the more resources that we have. Next slide, please. In terms of the government, we have limited budgets that are our limitations. But with the system, we will also see that how can we utilize our limited budgets to improve patient safety. From this dashboard that we can pinpoint that this is the most common, the cause of the disease. This is the cause of the vaccination side effect. In this case, we can improve the utilizations of our budget to improve patient safety from Thai people. Next slide, please. I have to emphasize that before the COVID-19, everything was in paper like this one. Next slide, please. And this is my slide. We transitioned from the paper-based record to digital application platform in just 1.5 years. This is thank you to the COVID-19 pandemic that we call the digital transformation from all the Thailand countries. In this case, we can utilize the digital transformations, electronic vaccination record to utilize the vaccinations campaign to the most efficiencies. With this data and digital platform, we can localize the risk populations, which age group that we need to do the campaign first, which one needs the highest prioritized. In that case, that we will improve the overall Thailand population. And I think that's the end of my presentation here. Thank you.
Thank you so much, Dr. Suprag. I think it's you have gone much beyond after COVID in terms of risk profiling of the population, creating even a vaccination schedule for your elderly population and then tracking it through dashboards. And that's a remarkable progress, which I think all of us need to learn and adopt. And we'll come back to you with questions. And with that, I would like to move on to Ms. Nalia. So, Ms. Nalia Medina from Philippines, the trustee and board member of Philippines Alliance of Patient Organization. She's a social worker who has helped various patient groups and NGOs to stand on their feet, to run their advocacy in various areas. And this entire gathering and this conference is all about the patient organizations and their role. So to you, Ms. Nalia, we would like to understand from your COVID experience and beyond that, how you think and how you have contributed the patient groups, humans patient groups has contributed in entire objective and achievements of COVID-19 vaccination, which is something which you have a lot to speak about. But also, how do you think, based on this lot of discussion,
I think it has frozen.
Yeah, it was
There is-
frozen.
Hello? I am not able to hear anything.
I can still hear you, but I cannot hear from the conference.
Yes.
So next slide, please. Our vision is to be a unifying body with one voice that supports and strengthens patients' organizations. And our mission is to serve as a strong and active network of patient groups that will empower Filipino patients to advocate for their rights and become productive members of society. Next slide, please. And next slide, please. In solidarity with experts in advocating the COVID-19 vaccine, PAPO launched the Bakuna Nauna and the Kwentong Bakuna campaign to combat misinformation and boost vaccine acceptance. Bakuna Nauna means get vaccinated now, and Kwentong Bakuna means vaccine series. Vaccine hesitancy was a significant challenge the Philippines faced during the pandemic. PAPO stood united with the nation, advocating for COVID-19 vaccination and released a unity statement. We called for unity during the critical phase, urging everyone to get vaccinated. In the statement, we expressed the challenges patients and caregivers face daily due to various diseases, emphasized the importance of widespread vaccination, stating that no one is safe until everyone is safe. Our campaign was aimed not only to raise awareness about the importance of COVID-19 vaccination, but dispel myths and provide accurate information to the community. We have to educate and empower patients with knowledge about vaccines and address any concerns or misconceptions. PAPO encouraged patients to share their stories and experiences, including with vaccination. On June 8, 2021, PAPO held a major launch for the Bakuna Nauna campaign. We created and shared informative materials on different social media platforms that explained the safety, efficacy, and importance of COVID vaccines. Moving forward,
PAPO will continuously provide media training to patient leaders to build their confidence so they can effectively share success stories and sensitize their own communities on the importance of immunization and work towards enhancing access to vaccination. Through partnerships with healthcare experts to answer questions and provide expert opinions on vaccinations, private and government sectors, and volunteers, we have dedicated Kwentong Bakuna webinar series aimed in addressing the common concerns and misconceptions, vaccine hesitancy, misinformation, highlighting the importance of safe, equitable vaccine distribution and accessibility. So join us in making a difference, one small act, big impact. Our tagline is nothing about us without us. PAPO is open to partnering with private and government sectors in advocating immunization for vaccine preventable diseases. We will continue to actively participate in policymaking decisions concerning patients' rights and safeguard the strict implementation of laws and policies affecting patients' needs. So if you want to connect with PAPO, you can, we have different platforms where you can connect with us. So let us all stay informed, vaccinated, and safe. And in behalf of PAPO, thank you very much. Maraming salamat po.
Thank you so much, Nelia. And with this, I want, before Dr. Ghosh, because he has another commitment to reach. So Dr. Ghosh, Dr. Nilima, and other panelists, Dr. Sufrak and Nelia both. One question to all of you, that generally the immunization is considered, at least in our mind, in my mind, is the responsibility of the government. And if we have to go beyond, and so I think all the stakeholders as a partners has to come together, where we take the responsibility on the responsibility, and access to everyone is ensured through a partnership model. So with this, sir, I would like to request Dr. Ghosh that what are the different partnership models where the government serves those who are needy and who need to be taken care by the government, but rest of the population, because when I was doing this study, insurance came up as a one unified voice from all the stakeholders and the experts who joined us for the discussions, and they spoke about even the value proposition and the business proposition for the insurance sector, private insurance sectors, even the government schemes like Ayushman Bharat, where the rate of hospitalization, stay of hospitalization, rehospitalization can be minimized significantly by using immunization as one of the important intervention for various risk groups. So over to you, sir, for your views.
Absolutely. I'll be very brief. I think that in India, at least, the immunization program rests on a very solid partnership that the government has with various other international and local agencies. There are three partners in which case we can say that they are either absolutely missing or are under kind of participating in this partnership. So one is, you rightly pointed out, absolutely missing is the insurance sector, the private sector, and also the public sector, the Life Insurance Corporation. So we definitely need to look at the insurance sector, recognizing the importance of immunization as a part to healthy life, particularly in case of children and in case of elderly. The second group, I think we need to engage more deeply is with the manufacturing industry, because in terms of the product that is going to be developed, The government will have to ensure that it is safe, high quality, that all is already taken for granted. But most importantly, it is user friendly, and also, that it is affordable for the government to use. So therefore, there needs to be a very clear understanding of the market shaping and all of that. And the third section, which really the government needs to work with is the civil societies, particularly organizations which represent communities. Some of the organizations are present in the room today. It's very important that they become a part of the National Technical Advisory Group on Immunization, to voice the concern of the community, to voice the need of the community, and therefore, bring a right perspective of the community-centric vaccination program in India. Thank you.
Thank you so much, sir. And Nilima, being a private sector representative here, the only one from the industry, I think your views again, and I told you earlier, the insurance, elderly population, and you can cover other risk groups also, how the insurance play a very important role in this entire enhancement of adoption and immunization for various risk groups. And affordability comes as a part of that as a question attending.
That's right. So, yeah, I am on mute.
Nilima, please unmute yourself.
I think I am on mute. I have already unmuted.
Now you are audible.
Okay. Yeah. So, you see, when we are talking about life course immunization, India really needs life course immunization approach. What we are seeing that if you look at the demographic dividend, and for which we are so proud of and so much focused upon, and really reaping the benefit in a big way. But also at the same time, we need to think about the aging population, which is now becoming a reality and should not be ignored. Uh, if you look at India's 50 plus population has increased from 270 million to 410 million so that's basically in next 15 years, which that is the prediction, right? And by 2026, 50 plus population will be 4 times of the size of the under 5. So while India has done a great job as far as in under 5 vaccination is concerned, but for life course immunization approach, as Dr. Ghosh also mentioned, of course, public-private partnership and bringing together all the partners, all the ecosystem partners, very, very important. Dr. Chitra, you talked about bringing into Ayushman Bharat and other schemes, which is a great idea. In addition to that, if you look at again bringing all the insurance companies, because financing is one of the key area in preventable care, right? While we have some kind of financing for hospitalization and all, but what about preventing going to hospital? So the preventing part. So there, I think we need to really design again with our partners, all the private sectors, government. We all need to work together to design innovative insurance products to incentivize vaccination adoption, especially in comorbid population. And to lower the disease severity. So this is one. And second, as you rightly mentioned, that I think we need to expand these packages, these benefit package to our public health insurance schemes like PMJY, CGHS, ESIC. Public sector units have their own insurance programs. So how can we really integrate the preventive care, especially for VPDs, the life course immunization approach under insurance programs, so that there is a better financing model and people are able to really have access. So that's the other thing where all the ecosystem partner needs to work together. So, in addition to that, if you talk about UN has declared 2021-2030 to be marked as the decade of healthy aging. Uh, while Government of India has agreed and has marked that the same, that India would also follow that, but there is very little which is to be seen towards, like, no, as an initiative. So again, working with Government of India, working with all our policymakers, influencers, that how we really convert this decade of healthy aging in a real way, work with all the ecosystem partners to have this life course immunization approach. Especially in India, if you look at the vector-borne diseases like malaria, dengue, JE, these are the other big challenges which this population especially faces. How can we also work towards that, so that in fact we prevent our aging population through these diseases as well? So financing and insurance is one of the key, along with the awareness and providing access. So one, what we talked about, bringing few of these VPDs under immunization program, national immunization program. And second, the life course vaccination approach for healthy aging, where we prevent our healthy aging population through these preventable in fact diseases.
Thank you. Thank you so much, Nilima. So India is leading the manufacturing from the front for several decades and will continue to lead that, certainly. And the quality vaccines and the affordable vaccines. And we wish and we want to communicate through these sessions that India has also led the immunization for infants and adolescents and pregnant women. I think we wish that India is also going to lead the same as a beacon of this preventive health through immunization also to various other countries who follow us and who learn from us. And with this, Dr. Sufrat, because you have already a lot has been done in terms of immunization to elderly and other populations. So the Thailand, how they are you financing everything through the government, or other stakeholders are also involved in financing of the vaccination to the population? So that's a simple question to you.
Thank you for the question. So actually, my answer will resonate with what Melinda already mentioned. Before the COVID, everyone will think that the responsibility will fall on the governments only. But during the COVID-19, we know that the government alone, we have limited budget, we have limited personnel. So that we won't be able to do that with the government alone. So we start to do the private and the public, which means governance partnership, to create the COVID-19 vaccination campaign. In that case, we learned that if the government is doing this alone, what will happen when we have the new governments? What will happen when we have a new government from the new parties? They will move me somewhere else, and they might cut the budget, or the budget of the immunization will change. So in that case, we learned from the COVID-19 that we need to involve every stakeholders, all the government scheme, all the private insurance, public, private, hospital, even the military hospital, already form a correlations with this MOPROM system. In this case, we will ensure that the sustainability of the vaccinations, where people can still get their vaccinations very low cost but high qualities everywhere in Thailand. Yeah, so I think that's my answer to the questions. Thank you.
Thank you so much. And my last to you have already helped various cancer, the organizations who are working in cancer for the access to innovative, targeted, and other therapies. So now when it comes to immunization, what is going to be your take again in terms of non-government financing through other private stakeholders or insurance?
Okay, I think everyone here will agree with me when I say that patient groups play a crucial role in advocating for vaccine for every patients, not only, and PAPO, I believe, is doing our part in alleviating or ensuring that the voices of our patients group are heard by our government. So we need to actually advocate that not only that we need to have a supportive government policies that will promote vaccinations and make it available at affordable cost. And yeah, so I believe that, but for patients to be able to advocate for their own interests and for their own needs, we as PAPU need to educate them, and we need to because I believe that knowledge is power, and so health literacy is an important tool in making the patients understand the importance of vaccination. I think our government has also realized that in the past, the focus of our vaccination campaign was more on children. And but now they have realized that there is another vulnerable sector, which is like the elderly, that needs also these efforts from the government to ensure that they also get the vaccinations that they need.
Thank you so much. I think this conversation can go endless with the people like us, Dr. Ghosh, the ocean of knowledge and experience. So with this, I have at least one question, Dr. Ratna, if you allow, if we have time, otherwise more. So please.
I have a lived experience with a vaccine which was routinely given as a kid. Infants get DPT. I did have diphtheria as a teenager. I survived that. But what's worrying me now is we are talking about life course vaccination.
Yeah.
Okay, I'm not familiar with the term. But what's worrying me is the efficacy of those vaccines is, I believe, about 10 years. And with climate change, a lot of infectious diseases are going to crop up. How are we protecting the population when it comes to these infectious illnesses? Especially people living with comorbidities, with immunosuppressants and all kinds of therapy. I think I'm very alarmed, and I would like to hear from the experts.
That you would like to.
That is a brilliant question, first of all. So first of all, just to give a little context, currently I am working on the climate health issues at the Public Health Foundation of India at the Center for Environmental Health. But parallelly, we have also started something which we are calling as a startup, which is the quality, equity, and inclusiveness in healthcare at the IIT Delhi. One of the primary evidence that we are trying to gather through the startup initiative is to understand the vulnerability of the population, particularly with respect to climate change. You spoke very well. Diseases are not only emerging, but they're re-emerging. The diseases that we have thought have gone are coming back. So therefore, we will have to look at the entire evidence of the vaccine efficacy, the vaccine effectiveness, and also, most importantly, in public health, it's about prioritization. Who do we prioritize? So through this quality, equity, inclusiveness initiative, we are trying to prioritize the population that needs to get the vaccine first. And directly to answer your question, that evidence currently is being generated. It's a concern that, across the globe researchers have as to how do we address the re-emerging infections. Diphtheria is coming back in various pockets within India, outside India. We are hearing about a new variant of the measles outbreak. We are hearing about some newer diseases which could be controlled by vaccines. So therefore, I'm just saying that Probably it will take a few years of dedicated research to find out the answer to your question. And then, we can partner with the private sector, the vaccine developers, to understand if we can increase the span of the efficacy. But ultimately, the quality and the coverage of the vaccine will continue to remain the most important issue, and also the prioritization of the population to ensure who gets the vaccine first.
Thank you so much, and I hope that answers your question. And so I think one takeaway message from this particular question is that patient groups also have to engage into more and more clinical research evidence creation. So that's also very important. And with this, we would like to thank all of you for your listening, participation, and the panelists for their wonderful thoughts and guidance to all of us. And I will be able to share the report which I co-authored with PwC after a 2 years intervention and discussion with various experts in India. So please reach out to me if anyone needs that report. Thank you so much again, all of you and the organizers for having us. Thank you.
Thank you. Thank you, ma'am. Thank you, panelists. I must take
Thank you.
Next session. Thank you, sir. Please, I will request the panelists to have a good photograph for us to conclude the session, please. As ma'am rightly said, one right step can leave a big impact. Yes, and we would, I guess we all would agree, we have lived this in Corona, that what wonders can vaccines do. It's okay, it's okay. Yes, as I was mentioning, we all would agree to have lived the wonders of vaccines in Corona times, and thus the right education and awareness of life course vaccinations holds a pivotal role in sensitizing our population. I extend a heartfelt gratitude to our respected panelists for giving us the valuable time and honoring this panel. Thank you.
Thank you, everyone.
Moving forward to our next session, case studies, in-depth case studies on patients-led best practices. The session will be moderated by Dr. Mehin Vijaysurya, Founder Honorary Secretary, Diabetes Association of Sri Lanka, Founder Honorary Secretary, NCD Alliance Lanka. We are so honored to have you here, sir. Please, can we have you on the stage? Thank you. Please, a round of applause for the gentleman. Please, next, it is privilege for me to announce and invite Ms. Marimel Lamson, Trustee, Philippine Alliance of Patient Organizations. She would be covering and putting light on the topic, the Philippines Alliance of Patients Organization, Patient Advocacy. Please, ma'am, please, sir, please join us. I would like to take the opportunity to please invite Ms. Nidhi Swaroop, Chair, Alliance of Patients Organization, Singapore, APOS. It is a privilege to have you here, ma'am. Please join us. She would be putting light on the topic, building a national alliance. Please. Next, I would like to invite Mr. Prasanna Shirol, co-founder, Organization of Rare Diseases India. Sir would be covering topic, Organization of Rare Diseases. Sir would be joining us online. No, sir is here very much here. We are honored to have you here, sir. Please allow me to invite Mrs. Chun Suk, Committee Member, Heart to Heart Foundation. Ma'am would be covering patient educators of the comorbidity diseases, diabetes, heart, and kidney. Please, a big round of applause for the distinguished panelists here. Sir, I would leave the chair. Thank you.
Yeah, I think without wasting any more time, we would go to the first panelist, who is Marimel Lamson, and she will talk on, sorry. Yeah, I would like you to come here and talk.
Good morning, ladies and gentlemen, and welcome to this insightful tour of the in-depth case study of the Philippine Alliance of Patients Organization Best Patient-Led Strategy. As we begin this exploration, each slide will reveal a different piece of information, offering insights into the amazing alliances, rich history, engaging mission, inspiring vision, patient-led activities, and ambitious future goals of PAPO. Today, we aim to explore the core of patient-led initiative and comprehend the significant influence they have on healthcare environment. So, without further ado, let's get started on the first slide and explore the route the patient organization and the PAPO have blazed in their unwavering quest to improve healthcare experiences of everybody. We welcome you to embark on this illuminating journey with us, exploring the roots of their establishment and the branches that extend towards future dreams. Who is PAPO and what is PAPO? Let me give you a glimpse of our history and how we started. The consumer-based healthcare advocacy program in the Philippines was the spark that ignited the creation of PAPO, implemented from 2002 to 2007 by the Asia Foundation with the support from the Pfizer Foundation. The project enabled many patient groups and health NGOs to strengthen their organizational and fundraising capabilities, influence health policy making through engagement with local and national level government representatives, and build their institutional capacity in volunteer management. In 2009, several patient groups held a roundtable discussion on improving patient-centered healthcare in the Philippines and reached the consensus about the need to form a coalition of patient groups. Thus, the Philippine Alliance of Patient Organization was born. The PAPO's founding members group are Cerebral Palsy Association of the Philippines, I Can Serve, Link Center for the Deaf, Philippine Children's Association of Learning Disability, and Kite Foundation. In the Philippines, there is a small but growing movement to strengthen the voice of patients. The Philippine Alliance of Patients Organization, the umbrella organization of patients group in the Philippines. Its coalition of 52 patient groups help advocate, including persons with disability. A member of the UK-based International Alliance of Patient Organization, which serve the global voice of patient-centered healthcare and has a non-state actor status with WHO. PAPO is a member of the Duke and US Center for Regulatory Excellence and the Coalition to Accelerate Patient Engagement in Asia Pacific. In the Philippines, PAPO sees the Technical Working Group, TWG, councils, and coalition involved in helping shape health policy. A unified body with one voice that support patients' organization. Boses ng PAPO, pulso ng pasyente. PAPO's voice, patient pulse. Our mission is PAPO's represents patient welfare and interest in various national and international multi-stakeholder fora, serving as venues to enhance leadership, potential, and increase the voice of patients. Our three areas of focus are respect for patients' rights, universal health coverage, and patient participation in policymaking. These are the patient-led activities. Next slide. The complexity of healthcare can be difficult to navigate. We aim to provide patients with the information and resources they need to easily access and make the most of their benefits under the PhilHealth. During the PhilHealth Navigation Orientation Program, we hope to simplify every aspect of the healthcare system through educational seminars so that each patient can completely navigate their health coverage. Universal Healthcare Capacity Building Workshop, knowledge turns into an effective change agent in our quest for universal healthcare. Our capacity building workshop are designed to improve the knowledge and abilities of patient community leaders, healthcare professionals. We are enable people to actively contribute to the achievement of more accessible and inclusive healthcare landscape by promoting a collaborative learning environment. And these are the series of workshops to build the capacity of about 50 patient leaders. Next. Bakuna Now Na, with the world facing never before seen health issue, our Bakuna Now Na webinars provide an information and timely forum. These webinars, which center on pandemic response tactics, cover important subjects such immunization campaign, public health precaution, and community resilience. We make an effort to inform and involve our communities so that they can work together to address the problems that arise from the global crisis. Healthcare Leadership and Management Postgraduate Course, we work in partnership with the Asian Institute of Management to provide a postgraduate course on healthcare leadership and management. Since we understand the need of qualified leaders in the field, this program is intended for people who want to drive constructive change with the healthcare industry. Our goal is to develop a new generation of leaders committed to enhancing patient outcomes and healthcare delivery by focusing academic rigor with practical application. We customize course with the objective of building and the capacity of patient leaders to participate in health policy making in local health boards. 25 patient leaders and 5 government leaders who attend 13 Saturday sessions, 5 learning teams who work an action learning project. Topic nomination submission. Our health technology assessment topic nomination invite people and healthcare stakeholders to actively participate in influencing the direction of health technology. We make sure that the patient's viewpoint is incorporated into the evaluation of new technologies by asking for nominations and insight. This encourages innovation that is in line with the requirements and preference of the people we serve. The HTA Philippines continue to seek a strengthened collaboration with patient groups and civil society organizations to further the HTA agenda. This was also identified as one of the priorities of the newly reconstructed HTA Council 2023 to 2026, especially with Mr. Chris Munoz, a patient group representative, on board as the HTA Council Core Committee Citizens Representative. During the patient engagement on 22 September 2023, together with the PAPO and our HTA network, the patient groups and other civil society organizations, the HTA Philippines supported back-to-back events, the 2023 HTA Topic Nomination and Topic Prioritization Guidelines Dissemination Forum, and celebration of the 2023 World Patient Safety Day. The HTA Philippines also facilitated a workshop on filing out HTA topic nomination form for patient groups. And the general public during the dissemination forum for the HTA nomination and prioritization, the Department of Health was also present during the celebration of the 2023 World Patient Safety Day to show its support to patients group. Here's our future. Future goals. As a part of our unwavering commitment in promoting the rights and welfare of patients across the country, we are pleased to provide a variety of engaging programs designed to empower the patients. Coalition of Patients Living with Rare Disease and PAPO have partnered to advance rare illness support service, research, and awareness in the Philippines. Collectively, these institutions are dedicated to fostering a more thorough comprehension of rare disease among the public, policymaker, and the medical community. through establishing collaboration and increased consciousness. Their aspirations are to enhance and well-being people with uncommon illnesses and guarantee that they have the capability to obtain sustainable healthcare and resources. Partnership in Ateneo School of Management and Public Health. In order to achieve its more comprehensive objective, PAPO is also forming a strategic alliance with the Ateneo School of Management and Public Health, specifically in medical school. This collaboration shows a dedication to promote the universal healthcare and basic healthcare in the Philippines. Working with academic institutions enables PAPO to carry out research, create evidence-based advocacy strategies, and contribute to the general enhancement of the healthcare system by utilizing the knowledge and resources of the Ateneo School of Management and Public Health. PAPO now has more opportunity to participate in policy lobbying, capacity building efforts, and educational programs through its collaboration with the Ateneo School of Management and Public Health. Through close collaboration with academic specialists, PAPO hopes to strengthen the role of primary health, bring attention to good improvements of healthcare legislation, and help the Philippines achieve universal healthcare. The PAPO aims to improve primary health and universal healthcare in the nation by collaborating with the coalition of patients living with rare disease and building a significant relationship with the Ateneo School of Management and Public Health. PAPO hopes to establish more accessible and inclusive healthcare through this strategic relationship, emphasizing the health and well-being of people regardless of their medical issue. For its first Philippine Patient Conference, the Philippine Alliance of Patient Organization hopes to unite all policymakers and patient advocates across the globe. As we all know, patient conference let patients know about their condition, available treatment, and self-care techniques, which help them make better decisions about their health care and achieve better results. In addition, they act as networking hubs for people with related disorder, promote health awareness, medical profession about new developments, provide scientific and technology assessment, and help with policy formulation. Conferences can facilitate talks about enhancing the healthcare system to make it more efficient and patient-centered by bringing together patients, healthcare professionals, legislators, and other stakeholders. Thank you.
Thank you very much. We'll proceed to the next speaker. Nidhi Swarup is the founder and president of the Crohn's and Colitis Society of Singapore and has initiated inflammatory bowel disease patient support group in that region. We will hear from her without too much ado, and hopefully we'll stick to the time.
Thank you so much. I will try to rush through this first half of my presentation because I know time is crucial, but the first 5 minutes will be a little fast, so please bear with me. But the second half will be a little slower. So, okay, I will be talking about patients co-creating healthcare. But before I jump into that topic, I will talk about my background. And it talks about my journey that started in 2009 with healthcare issues. It was a 2-year journey where I was dealing with a whole lot of symptoms that kept shifting in my body from one body part to another. Every 3 to 4 months, I would see another specialist. So naturally, I would go from one consultant to another, and the whole list is given here. If you're not listed there, sorry, but my body didn't deal with that. But I think the list is 10 or 11 different specialists. And naturally, when you go to a consultant, they would run numerous tests and scans. So if you name a test, I most likely might have gone through it. I will not list and bore you, but it's on the slide. And being an Asian, you would try alternative medicine. And that is something I try to convince doctors that you cannot deny that from us. It's ancient wisdom and we will try. So I've tried almost everything and I learned a few things like even meditation, which I wouldn't do in the past. And I learned medical Qigong. I took a, 6 weeks course and it's energy healing. So I did try all of these. And I must say all of them benefit us to some extent, but not completely. And then comes 2011, which you notice is 2 years down the road. And that's when I was diagnosed with Crohn's disease, because ultimately I had a severe episode of diarrhea, which was like 10 times in half a day. And by then, because I'd grown so used to different symptoms, I had just gone to the GP, whose eyes almost fell off and said, "What are you doing in my clinic? You should be in the hospital." I'm like, okay, I take a taxi and I go to the hospital. But I did get diagnosed and I was prescribed that many medication. If you can take a look, it's around 10 or 12 tablets every day. And naturally, my initial thoughts were that, did I do something wrong? Could I have prevented it? Because until that point, I was around 42 years old and I thought everything right. Eat healthy, exercise regularly. I just thought I was doing everything okay, but something like that did happen to me. So after 2 years, naturally, when you get a diagnosis, you have a mixed bag of emotions. One is feeling sad that it's an incurable illness. Nobody has a clear answer as to what causes it. And so you're dealing with it like a Band-Aid. It's like firefighting on a daily basis. But on the other hand, it's fantastic that at least I know what the hell is wrong with me. Yeah, living without a diagnosis is even worse. So then some of us here might not be familiar. What is Crohn's disease? So just a brief summary. It's an autoimmune condition of the digestive tract. It can cause ulcers in any part of the entire system from the mouth to the anus. And in totality, there are actually 2 types of inflammatory bowel disease. One that is limited to the large intestine, and that's called ulcerative colitis. Whereas I had Crohn's disease, which could be patchy ulcers along the entire digestive tract. And in Singapore, at this moment, there are about 3,000 patients, and of that, 300 are children. The youngest, I think, was a few weeks old when she was diagnosed. There has been a tremendous increase in Asia around these illnesses, whereas if I think about it and I hear from doctors and patients who were diagnosed 50 years ago, doctors thought that this didn't happen to Chinese population, it didn't happen to Indian population, so they would ask if there was mixed blood. Was there any Caucasian blood in your family line? That used to be the question to people, but it's changing now. In any case, how I coped with it was I used some of my counseling skills here. So I used this simple diagram to draw your attention at the neutral point, that when everything's fine, that's where we are. But when certain symptoms and signs start and we don't do anything, we could be moving towards the left, leading to premature, departure from this earth. Or if we take some action, we could probably move towards the right, where we can create some education and awareness around it with your friends, colleagues, and other things, and you can move towards wellness. So that is something I decided to do, that I have 2 choices. One is I could focus on the things I can't do anymore, or I could focus on the things that I can do. So I literally did a SWOT analysis on myself. This slide naturally brings a laughter in my crowd when I speak at various platforms. So just to elaborate, SWOT, I think everyone knows, but it's the strengths and weaknesses. So if I look at my strengths, I have 2 master's degrees, one in operations research from the Delhi University, and I have another in finance from UK. I also have training in counseling from Australia. So I put all of them together, and also my experience was running a charity. I was the executive director of Rotary Foundation and had been working there for 10 years. So I could use that experience, and I was told, maybe you can start a support group. I'm like, okay. And then comes a service gap because there was no charity taking care of patients with this group of illnesses. And the other thing was the threat that if I don't manage it properly, I could spiral downwards. And at that point, my illness was a mild case of Crohn's disease. Whereas I'm thinking mild case and the number of consultants I had to go see is alarming. I don't know how patients who have moderate to severe illness. So my heart actually went out to these people. And I decided to start a charity. That's what I did to help other patients living with this condition. And if you look at the top left, I think of your slide is my Rotary connection. I've been a member of a Rotary Club for 22 years now. So I just called some of my friends in Rotary that it was a strategic pool of people that I needed certain lawyers, auditors, doctors to come on board to set up this organization. The requirement in Singapore is you need 10 board members to set a society. So that's what I did. And if you notice the date, it is within 1 year of my diagnosis. So this was started at that time. Along the way, what happened was I was diagnosed with 4 other conditions, and they're listed there. I don't want to bore you, but what that means is I had 5 specialists taking care of this one single body. And each doctor always said, this condition is not related to that condition. And I would sometimes laugh at them and say, that's how science works. That's okay. You work in different segments, but this is one body. And I don't believe it can not be connected in any case. The turning point came in 2018, which is very interesting because I went for another scope and I was told there are no more ulcers. And somehow, okay, I don't want to go into many details, but I'm on 0 medication since that time. Now, COVID propelled me onto the global scale, which brought me into various regional and global platforms, speaking at seminars and conferences. And what I realized is globally, various stakeholders actually coming together to enhance healthcare. And there's a fundamental shift from sick care to preventive health and precision medicine. A lot of things are happening, and the focus is towards quality of life, which I thought was very interesting. Personalized healthcare is becoming more and more important. If you look at certain papers published by Copenhagen Institute of Future Studies, I found that very enlightening. So on the right of my screen, you could see the case study of Singapore. So I was invited to be part of the SingHealth Patient Advocacy Network. So SingHealth is one of the 3 key players in the public health space. And 80% of our population actually uses the public health system. So in that, we have at this moment only about 50 patients and caregivers who are part of this network, but we've done more than 100 projects with the hospitals to improve their services and patient experience can be enhanced. So one of the things I always challenge my audience is, where do you think are the patients? So when we are speaking to other stakeholders, unlike this group, here we have a lot of patient advocates, but if you're speaking to doctors and you're speaking to pharma, many of these people speak about patients being in clinics, polyclinics, or hospitals, or community hospitals. But I say, actually look around. Everyone is either a patient or a caregiver. So do not think of the system as us and them. It's all of us in it together. Okay. So my tiny charity, the Crohn's and Colitis Society, actually has worked with the Ministry of Health. And we've published a simple brochure that talks about treatments for Crohn's and ulcerative colitis. In collaboration, this was done, and the patients absolutely love it. So that's just one example. I've also served on certain ministerial committees, advisory committee to set the fee benchmark for private doctors. So that's just 1 or 2 things I'm sharing that patients can be part of the process. Then comes the other part, which is the real topic of my presentation. So this is a busy slide, but that's the platform we have just created, which is the Alliance of Patients Organizations Singapore. Because given my operations research background, I have to look at things holistically. And I just felt every stakeholder was working in their own little silos, and that's not done if you really want to make a difference. So came this idea where all stakeholders should work together and co-create the future of healthcare. So if you look at the top left is the Ministry of Health, then you have the Center of Regulatory Excellence, you have research organizations, which could be hospitals or institutes or universities on their own. There are philanthropic organizations or foundations. Then you have the healthcare providers. These are the hospitals. And then you have the industry partners and patient organizations. And surprisingly, just last year, the WHO also became a significant part of this whole thing. And if you notice, there are arrows going both ways when I come to all the stakeholders, because we don't think it has to be a one-way process. It cannot be top-down or bottom-up. It has to be a co-creation process. Okay, so the Alliance of Patients Organizations was registered on the 20th of September. And this news I got while I was flying back from the Geneva Patients Conference, and I was super excited. So we are new kids on the block. We have just created this system. And here is the logo. And I will end with that. Thank you so much for your attention.
Discourse about yourself and the condition, which is a bit of a hidden item in most people's minds. And it's like chronic, as the name implies, and people live with it without knowing what they are living with. So I think you're bringing it out into the open domain. It's very useful to all. Now, I would now proceed for Prasanna Shiror, who is the co-founder and executive director of the Organization for Rare Diseases. Now, we are one step away from being called rare diseases, but it is a rare disease. He founded and is the president of a parent support group for children with ultra-rare disease, lysosomal storage disorder, Support Society India. So we'll hear from Prasanna what he has been able to do about it.
Good morning, everybody. First of all, I would like to thank Dr. Ratna Devi and the organizer for giving me this opportunity to talk about ORDI and its milestone and how it changed India's rare disease landscape. So we started our work with the rare disease helpline way back in 2008 onwards, include my own journey of being a father of a rare disease patient. There is a lack of information in the country. Number one, either for the diagnosis or post-diagnosis. What to do, what should I do, where should I go? And there was a tendency of patients traveling in India on an average of 500 to 700 kilometers in the country in search of a specialist. We wanted to address that. And as a result, our helpline, which is operational from 2013 onwards, till date, we have got around 12,000 calls where we have navigated the patient to the right resources and also helped in identifying the local healthcare provider, because rare disease being a progressive and long-term illness, identifying a local HCP is more important, and then maybe you can connect with a specialist once in a while, and that we have effectively done. Roughly around 8,500 patients who are associated with us, who have come from a different varieties of rare diseases. And we are able to facilitate treatment. As you know, treatment is very exorbitant and costly. Only recently we have a national policy for treatment of rare disease, but before that there was no. But with our unique intervention and helping the patients identify different sources of funding, we were able to fund, support 372 patients, which roughly translate into around 284 crore worth before the national policy is in place. Then another important thing which was in the country, every country we noticed that there is a rare disease definition and India did not have one. As early as in 2014-15, we published a peer-reviewed article along with noted, who often called as father of genetics, Dr. I.C. Verma, who's the contributor and different specialist in the country. And we announced it as 1 in 5,000 as a rare disease. When we published this, there are many questions, on what basis? Obviously, it is based on a WHO figure and extrapolated. But at least it started the debate in the country. And till now, we do not have a definitive rare disease definition. But however, in 2017, ICMR, where a group of geneticists and doctors came together and announced it as 1 in 2,500. And later on, the Clinical Trial Act also declared it as, to decide as an orphan drug. If number of patients in the country are less than 5 lakh patients, then it will be an orphan drug status. So these are the discussion. Till now, we do not have, even the policy also has not yet addressed. Then when coming to patient support, there was a need to take care of the patients holistically. So we created a concept called Rare Disease Care Coordination Center, addressing from end to end, right from identifying the patient, diagnosis, treatment, supportive care, end of life care, and also navigating the patient through various clinical trial. And if there is a possibility to encourage the research and development activity, which is happening from the day one. And as a result, we keep doing many patient related activities like diagnosing camps and other things. And when we talk about rare disease diagnosing camps, in one single day, we get average around 250 to 300 undiagnosed patients in a rural area. And also when we conducted in the cities, it is the number of the same, which again, when we talk about rare diseases, they are no rare. It's only that they are undiagnosed in the country like India. Of course, it is worldwide, but in India, it may be very high, where we estimated 70 million patients, I think, which translate whatever our efforts and what we found out. Then also in the Karnataka being one of the first state in the country where we started the treatment supported by Karnataka government based on a 4 to 5 years of advocacy and also filing a PIL, that is going to the court, public interest litigation by an organization. Then when the treatment started, there was a need to facilitate this treatment because the first started was enzyme replacement therapy for LSDs, lysosomal storage disorder. And there is a specific nurses are required, healthcare professional was required. And since the patient has to come every week or 15 days, we wanted to create a special atmosphere so that the children and the parents do not get burdened. Then if you see the photograph, we have created this exclusive first daycare ward in the country for rare diseases, where the nurses are appointed by us, and this is established in a government tertiary care hospital. It's like a private hospital setup, which is running from 2015 onwards. And today, more than 250 patients take treatment in this center. And this also considered as one of the largest ERT, enzyme replacement therapy center in Asia. And also, apart from this, we work with various hospitals. And recently, there are 12 COEs, the Center of Excellence, nominated by, designated under the National Policy for Treatment of Rare Diseases. And we work with, 5 of them as an MOU. And in the 3 COE, where we have based our coordinator again to help and support the patient, including, AIMS, CDFD, Hyderabad, and Bangalore. And what impact it has made is, since it's the beginning of the journey and support from the government is limited and national policy is for the central government, but we have that state government, which is, health is a state subject, still a infrastructure need to be built and support the system. Support is not there. So our coordinator is able to make a difference. And recently, Indira Gandhi, one of the COE under this policy, we crossed 100 patients in supporting the treatment. And the only center which has stated 100 patients, where still other centers are, trying to find solution and move ahead with the supporting more and more patients and benefiting the policy. And another interesting area which we took is, because of the numbers are more in every category, we identified certain category like DMD and SMA, where, and also, there is a lot of patients where in the country, and we wanted to navigate them with a proper structure of supportive care and also long-term care. So we created a disease-specific clinic called Nerve and Muscle Clinic, focusing on the neuromuscular conditions, that is DMT and SMA. And we have seen more than 1,000 patients in this center in last 4 years. And this is managed, this is in the coordination with the Baptist Hospital of Bangalore and lead doctor, Dr. Ann Matthews. And when it comes to awareness, there was definitely a need to create awareness, not just in public, general public, but also medical fraternity. And right from the beginning, we were doing continuous CME program, continuous medical education program, conferences, international conferences, and also webinars, which took off after the COVID. If you look at it, we conducted a 160 webinar during the COVID period alone, and more than 6,500 HCPs have attended this. And two of the major programs we are associated with IAMG, Indian Academy of Medical Geneticists, and AOCN, Association for Child Neurology, where we conducted a 16-week, 17-week program, participating both national and international experts, which created, awareness among most of these genetic and neuromuscular conditions in the country. And on an average, we work with 3,300 plus doctors, various doctors across the country. And coming to general public, we created a very unique, probably world's one of the largest event to create awareness in rare diseases called Race for 7. Race for 7 is a run, walk, or a marathon, and 7 indicating, symbolically representing 7,000 rare diseases, average diagnosing period of 7 years, and also estimated 70 million patients in the country. We wanted to create awareness about this, and somebody sees Race for 7, at least it should make them think what is it, and finding an answer would create an awareness. We started in 2016, and in last year we conducted the 8th consecutive years, and we conducted in 13 Indian cities. And also we get we have cycling, runners, everybody in this. And this is our annual fundraising also awareness, where we involve different cities and different HCPs and local celebrities. And these are some of the snapshots which starts early morning at 7 o'clock on last Sunday of February. And this is one of the snapshots where you can see the participate. And if you look at all these people are not related to rare disease at all. They are from the general public, IT people who come and support and be part of it, expressing their solidarity. Because most of the rare disease patients don't come and participate. One, because of the stigma. Second one is early morning they cannot come. But idea is to educate and create awareness. I think we are successful doing it, because all these IT people also post this event in the social media, which creates a ripple. And apart from this, when large gathering like this who come and support, assemble in one area, is a loud message which goes to the policymaker, because when we go and meet the policymaker, they all think that we are small in number, but these messages takes them, we are not alone in this country. And so far, 40,000 plus people have participated in our event physically. And also 2 years we conducted it in virtually, where people run from their respective places near the house and apartment. And apart from this 40,000, as I told you, it gives us an opportunity to talk heavily in print media, TV media, and social media, which goes to millions and millions every year. And last but not the least, advocacy, which is very important. And from the day one, we are a lead organization which starts talking about a rare disease policy in the country. And we work with various advocacy patient group and advocacy leaders. We also have our own advocacy committee, which decides and talks about what is needed and what need to be focused and talk to the government. And we keep writing letters. And media is one more important channel which helps us to take our message, because in a country like India, meeting every time the policymaker is not important. I mean, not so easy. But these messages, media helps us to reach our message regularly. So these are, we involve all the, health ministers, policymakers, celebrities, wherever it's possible in every city, and which again helps us to, continue. So if you look at it, it is not ORDI alone. ORDI is the initiator, but created that platform about rare diseases in India. But over a period of time, many individual organizations and many companies and many pharmaceutical industries, diagnostic has helped. If you look at the chart, entire spectrum in rare disease started moving, especially after 2014-15 onwards, where we have a national policy which came in 2017, which again got refined in 2021. But finally, the amount started releasing from 2023. We got orphan drug policy to address the rare disease drugs. Then we have ICMR, which started talking about patient registry in 2017. But although there was a delay, now they've started entry into. Then we also focused on clinical trial, there was a long gap, big gap in the country, India, for various things. But later on, it also got focused to certain rare diseases. Then a race for 7 again. Apart from this, 2020-21, we also see a lot of focus from global companies. Earlier, they're hesitant because they never thought India can get into reimbursement model or a support from the government. But the policy has created an attraction from global companies to India. Now we see a lot of focus coming. Then finally, in 2022, after the policy, many things have started changing. Everybody is focusing on rare diseases, and 12 COEs are, we started with 8 COEs, but today government is extending. I'm sure our vision of at least 1 COE per state, and then district will definitely realize in coming year. And also recently IGST, if somebody is importing medicine for the rare disease, personal import, now import duty is exempted. Although it is not so easy for a patient to import, but whoever are capable, few of those, it helps. So looking at this, the scenario, we can expect a lot of hope from rare diseases, where we started from zero in the maybe in 2010 onwards. I think many of us are looking at hope, and we are hopeful that government will support more and more. And very recently, ORDA is now completing 10 years, and we wanted to forge ahead, because when there is a policy, obviously all the stakeholder comes, and it's a long-term activity, never-ending activity. Couple of years, we have started thinking what should be our next, and with absence of 95% of the condition do not have treatment, we thought we should focus on our last objective as an ORDA, the research. So we started conducting a redress program in coordination with TIGS, Tata Institute of Genomic Science. And this year, ICMR also has become a knowledge partner. And this is one of the unique platform where academy, like IASC, IITs have started participating, healthcare professionals and scientists, researchers, patient, industry, everybody is on one platform, including ICMR and funding, which talks about rare disease research development in the country. Yeah, this is the last slide. So if you look at it, ORDA is we have been doing activity 100%, 360-degree view, covering the entire spectrum of rare diseases. Thank you so much for the patience.
Thank you so much. I think this is the most interesting lecture that we had for the whole period of this conference, because it is something that is always swept under the rug. And I don't think patients do not exist, but the patients do not exist in a favorable environment. And I think all of us should contribute something in our practice to alleviate the suffering of this lot of patients. Now I pass on to our last speaker, who is, I'm sorry if I don't pronounce your name properly, but Shensuk Retnagam is the prominent patient advocate and board member of the Heart to Heart Foundation. Let's see what she has to say.
Thank you. Patient educators of the comorbidity diseases. Heart to Heart Foundation was established in year 2009 in accordance with the intention of Dr. Sengwan Nitiyarampong to bring together the patients with chronic diseases that require high-cost treatments such as cancer, heart, and kidney diseases, in order to empower them. Dr. Sengwan Nitiyarampong the first Secretary General of the National Health Security Office, who passed away by lung cancer. In Thailand, number of patients with diabetes, high blood pressure, kidney diseases, and cancer are increasing, consuming huge amounts of resources in providing care and treatment. Medical care team and public health personnel spend a lot of time dealing with these diseases. In 2022, Thailand had diabetic patients 3.3 million people, and 1 in 25 of diabetic patients and high blood pressure are progressing to renal diseases. Actually, these diseases are all caused by a person's health behavior. Thailand has had quite many campaigns on health behavior, but still unable to reach the public widely, especially those who are already starting to get sick. But they are still not realized about taking care of health. Therefore, it is necessary to provide correct knowledge which meets needs and appropriate for each patient. Cardio-renal metabolic or CRM patient educator workshop was held on August 26, 2023. Was organized to create health educators by bringing together a group of people with diabetes, heart disease, kidney disease, and comorbidities to brainstorm, exchange ideas, and call for action. Objective of the workshop was to build CRM patient educator networks, which can provide knowledge on health promotion and prevention, patient empowerment, peer support, and collaboration with service providers. Health behavior is difficult to change. The important thing is convincing people that it's everyone's duty. We should look at each person's lifestyle. It could be a daily routine of them. For example, the patient doesn't like to exercise in the fitness room, but we recommend him to do. He won't do it because it's not the lifestyle he likes. Suggest options to patients about what they can do. Advise by asking about history to encourage him to think about what he will do, and when go back, how he can do it himself every day. There is an exchange continuous motivation interview or effective communication by Dr. Pontep Siri Wanarangsan. Dr. Pontep and Kitja. Dr. Pontep interviewed cardiac patient by motivation interview technique. He asked about daily routine in his life, eating, exercising, drinking, sleeping. He taught the patient to take notes how to improve behaviors and come back to tell a doctor. Can they do? Can they change? Does the patient gain motivation and can find appropriate options themselves? There is a showcase to provide appropriate patient knowledge for each disease. Diabetic disease, Supalak and Upakan. They both are diabetic patients. Supalak can improve her health and she has knowledge enough to provide to other diabetic patients. She asked Upakan about eating. Did he change eating behavior? Upakan told that in the beginning, he was very strict in eating. He was serious in calculating sugar. And he chose only some food that was sugar-free. So he felt very anxious and uncomfortable. However, blood sugar was not decreased. because of his temper. Heart disease, Supavadi and Likhit. They both post-coronary artery bypass grafting. Supavadi asked about eating, exercising, and sleeping. Likhit said that after surgery, he stopped eating fatty pork in spite of he very loved it before. He eat more vegetable, he planned himself. He do exercise by walking around and inspect the world. Supavadi taught him to take more water and take a deep breath in and out. Renal disease, Thanapon and Intira. They both are renal failure patients. Thanapon got kidney transplantation for 10 years ago. He has gained a lot of experience with kidney disease, and he worked hard to push policy on kidney disease. He just got award from Heart to Heart Foundation last year. Intira learned a lot from him. Now she is on hemodialysis for 3 times a week and can live happily with kidney failure. Comorbidity, Chunsuk and Sulachai. I have only high cholesterol and can control with medicine. However, I have another problem. It is low back pain due to degenerative disc. For Sulachai, I believe no one can guess Go back. Go back. Twenty. Yes. No one can guess what is his problem. Believe or not, he has cancer. He has liver cancer for about 5 years. However, nowadays he's still alive with happiness. He can get well because he got encouragement from his family. Everyone support him, pay money for him while he try to improve behavior such as eating, doing exercise, and sleeping. Provision of knowledge and importance of digital media. Virun, who is a pharmacist and being interested in social media, had problem to access knowledge while his wife got sick with cancer. He said that digital health is very important. Technology can help people to take care themselves and others. Next. For example, smartwatch, telemedicine, and social media. However, patients have to aware of information from social media because it may be information from business or other that very interesting and reliable. Next. The interesting session is group discussing among patients in 4 groups. Heart disease, diabetic, kidney, and comorbidity. The objectives are to develop patient educator with effective communication among members in their network. They form network and channels to exchange information, communication, and education about their diseases. In each group, they share experiences and knowledge to each other. Conclusion for 4 groups. Diabetic disease. There are diabetic club with about 180 members in Line group, Facebook, and TikTok. The content is sharing experience among members, supporting them, encouraging them about their disease. Next. Heart disease. There are heart disease club with 200 members in Line group and Facebook. They provide knowledge about practice after surgery because patients are afraid of doctor. They don't want to ask doctor. Sometimes the doctor have no time to explain in details. So this communication will help. Next. Kidney disease. There are Thai Kidney Friend Association with Line group, TikTok and Facebook, board, picture and community radio. The patient needs supporting and knowledge for them to take care themselves. Some patients are hemodialysis, some are CAPD, and some are kidney transplantation. So they want to know in different ways of information. Next, please. Comorbidity. They get knowledge from YouTube, website, Facebook, and share to patients. They go to visit patients at home. Next, please. However, coordination with medical personnel is very important to provide accurate information about patient self-care in each person. Next step will aim at how to link cardiac disease, renal disease, metabolic disease to comorbidity by strengthening and expanding CRM network from existing capacity. We should have cooperation and support among these groups. Next, please. The goal is for patients to be happy, comfortable, and able to be happy in society. Thank you.
Thank you very much. I think we are at the end of this session. What we went through was unusual presentations of unusual patient conditions. And I think highlighting them, bringing them forward, allowing them to be vetted and helped both by government and private sector makes a great difference to the individual because the individual often is homebound, unable to seek help except from the relatives or their own family. So this particular session, I feel, is worth its weight in gold. Thank you. And thank you very much to the organizers for having given us the time and attention to these conditions that are absolutely wanting help. Thank you again.
Thank you, sir. That was a very enlightening session, panelists, and all your experiences and insights are inspiration and motivation for us to keep holding our torch high and dedicatedly marching forward to our goal of equitable health services. The slides nicely quoted that they started as a small spark and now have been into a big fire in terms of good coverage and spread of welfare and care of patients. And that is a promise we all together hold today as a vision to future, to stand strong with our patients as a journey from illness to wellness, right? Thank you, panelists. A big hand of applause, please, for our great session here. I would request you all for a photograph, please, to conclude the session. Once again, thanking the organizing team, PAIR, and Dr. Ratna for giving us this platform. We're collecting beautiful instances and experiences and learning through this. Thank you, sir. Thank you, ma'am. Thank you, beautiful audience. Now we break for our lunch and we will resume. in about half an hour's time, please. Yes, sir. You want to come? Okay, yes. Ma'am have allowed us 45 good minutes for a beautiful lunch and connecting through there. Thank you. with our upcoming sessions. Thank you. All mobile phones to be put on silent. Namaste and good afternoon. I take proud privilege to invite you all for our first International Summit, Patient Summit, Day 2 afternoon session. Your enthusiasm and commitment to the goal of the summit is very evident, as is your honored presence here. Our afternoon session is on the topic mental health, the need for integration into all programs. The session will be moderated by Dr. Nand Kumar, Professor in charge ICMR Care in Neuromodulation for Mental Health, Department of Psychiatry, AIIMS, New Delhi. It's a proud privilege to have you here, sir. Please join us on the stage, please. Yes, a round of applause for Dr. Nand Kumar here. Thank you, please, sir. I take the opportunity to invite Dr. Vinay Kumar, President, Indian Psychiatric Society. Yes. Sure. So, we would like to hear, and your presentation is on access to mental health in Asia Pacific. Other speakers will be joining us shortly. So please, it's a privilege, please, sir, be our opening speaker for the day and session. Thank you.
Good afternoon. Thank you very much for inviting me here. And I'm really grateful to Dr. Ratna Devi for inviting me for this very important session. My thanks to Patient Academy for Innovation and Research, Daxma Health, the Philippine Alliance of Patient Organization, and the Heart to Heart Foundation. It's a very interesting topic in terms of mental health. The topic is equitable healthcare, co-planning, co-designing, and co-delivery. You might have perhaps faced in your neighborhood or somewhere the mental health issues and challenges. And this is one of the area that is most unequitable. Why? I will give you one example. We had 6,000 psychiatrists 4 years back, 5 years back. Now we had 9,000 psychiatrists. So number of psychiatrists have increased, in fact. But we had a suicide rate that also have increased. So every day, 408 people die in India because of suicide. So that means the number of psychiatrists we have increased, but the suicide also increased. The mental health problem or mental illness, in fact, that also has increased in the magnitude.
in the last 10 years. But we have more number of psychologists, more number of psychiatrists. So that means, no, either we are not able to perhaps co-plan, co-design with other part of the system or other part of the healthcare that we should have been by this time. Another important issue is that it is really unequitable distribution of the resources. If you look at the clinical psychologists, in Delhi, we had approximately 1,000 plus clinical psychologists. Go to Uttar Pradesh, you will find hardly 10 or 12. So huge difference. So there is no equality at all. If you look at the psychiatrists, we have 9,000 psychiatrists, and in some part of the country, they are surplus. They are more than what is needed. If you look at the WHO and other international agencies, they say we should have 1 psychiatrist per lakh. India have 0.75, much less than that. Now, Delhi, Goa, Pondicherry, they have the surplus. Much more number of psychiatrists than what is needed. Look at the Uttar Pradesh, they have deficit of more than 50%. Uttar Pradesh, Madhya Pradesh, and other land. Look at other part of the country, say Arunachal Pradesh, Manipur, and Uttarakhand, Jammu and Kashmir. The deficit is approximately 90%. It's 90%. So it's a huge deficits in terms of distribution of mental health professional if you just talk about psychiatrists and psychologists. But mental health is much bigger than psychiatrists and psychologists. Social worker is equally important. The other medical fraternity, they're also equally important. And unfortunately, they are also not aware of mental health issues and illnesses. I will just give one example. 5 months back, so one of the faculty, senior doctor in MAMC, Maulana Azad Medical College, he died by suicide. Just 3 days back, one of the bright boy who was doing MD in medicine, he was in 3rd year, and he died by suicide. So when we talk about mental health and we talk about the resources and distribution, so we always raise the point that we need to increase number of psychiatrists. Now look at the ironical part. This both the doctors within 6 months, one of the person who was a senior doctor, there is no dearth of psychiatrists in MAMC, Maulana Azad Medical College, and in Delhi, there's a surplus. But he could not visit. This boy who died just 3 days back, there is a department of psychiatry full-fledged in Safdarjung Hospital. And he was being treated or not treated, I'm not aware of that. But he has the access to the clinical services in psychiatry. And he did not know, perhaps either had gone there or I don't know what has happened in fact. So it raises a very important point. What we are doing is it right or wrong? Because mostly what we are doing is we are working in isolation in terms of mental health at least. In bigger institutions, the things are much better. But it is very painful to share with you that in bigger institutions also, the things are not that good. One of the student of MD psychiatry, he died by suicide last year. One of the faculty of psychiatry, he died by suicide 4 years back in Puducherry. So it's a very painful numbers, it's not numbers, painful feeling in fact. So that means we are lacking something somewhere very seriously. And I have attended a lot of conference. You have seen a lot of research paper also. So when we talk about mental health, increase psychologists, increase psychiatrists, and increase resources, make more mental health institutions. But how it is going to help? So perhaps it is very, very important to have the co-planning with the other stakeholders in the area of the health. And that most likely we are lacking very, very badly, in fact. And we had several discussion with Dr. Ratna Devi, how to integrate that. And you will be surprised to know, if you look at the mental health component. So in our All India Institute of Medical Science, if you look at the gastroenterology OPD, so there 30-40% patients are having functional bowel disease. So the mental health component is very, very important. That means they have irritable bowel syndrome. So a lot of issue can be resolved, no, if we have some sort of co-designing of a good program, how to address that. Co-designing does not mean that prescribing medication. It is just the 2A that is very, very important. Because in those, these two cases that what I had given the example, the two most important thing lacking was awareness and acceptance. If we talk about mental health, the awareness and acceptance is very, very key area, and we have perhaps failed to focus here. And we need to work, we need to properly co-design so that we can co-deliver in a meaningful way and in an equitable distribution. So I'm attached to Mental Health Foundation India. It's a not-for-profit organization working in mental health exclusively since last 20 years, more than 20 years. We have recently MOU with AIIMS Delhi and Deepak Chopra Foundation USA. And we are trying to do something in terms of health integration. And still we are trying to develop some model for that. Just for this reason that we should not work in the isolation. We should have some sort of integration in the community between different stakeholders in the area of the health. And I'm looking forward to work with Dr. Ratna Devi also, so that we can have some meaningful work and some impact to reduce the mental comorbid conditions or mental health issue and illnesses both. When I talk about mental health issues, the issues are more important than the illness. The illness is hardly 1%, 2%, maximum 5%. Issues are much more burning in fact. Say, for example, relationship issue, domestic violence. These are not illnesses, but the issues that can be resolved. But again, the two is very important: acceptance and awareness. How your brain works, how your brain responds, how your brain, excuse me, process the information. These things are important. With this, we can invite the speakers in this session. Dr. Vinay Kumar is online most likely. He has joined. Okay. Thank you very much.
Thank you, sir, for your insight and kind words. I would please take the opportunity to invite Dr. Vinay Kumar, President, Indian Psychiatric Society, Access to Mental Health in Asia Pacific. Sir will be presenting online for us. Sir, can you hear us? Dr. Vinay Kumar?
Yes, I'm connected.
Thank you, sir.
Wait for a moment. Hi. Just a minute. At times,
Yes, sir. Dr. Kumar?
I'm
Yes, you're audible.
I'm
You're
trying
audible.
to I'm trying
Okay,
to
sir is trying to, I guess, present.
find my talk here. Okay, fine.
Sure, sir.
I have to share that thing.
Dr. Vinay, just
afternoon.
allow
Good
me some
afternoon.
time so I invite other speakers on the stage as well. Yeah, yeah.
Yes, please. Yes, please.
Please just allow me 5 minutes, sir.
Sure.
We'll come back to you then. Okay, please. I take the opportunity to please invite Ms. Lopa Ghosh, our next eminent speaker here. Country Coordinator, Global Health Advocacy Incubator, India. Ma'am would be presenting upon NCDs and mental health. It is an honor to have you here, ma'am. Please join us on the stage. A round of applause for the lady, please. Thank you. I take the opportunity to also invite Dr. Harshita Umesh, Young Youth Ambassador, Mental Health Advocate, Internal Lead, Yongo HWG, United Nations. She would be presenting online and covering on mental health for young people, challenges and opportunities. Last but not least, Ms. Smriti Rana, Head Strategic Programs and Partnerships, Pallium India, India Advocacy Focal Point for the International Association of Hospice and Palliative Care, Board Member, International Drug Policy Consortium. Ma'am would be presenting upon mental health and end-of-life care. Thank you. A round of applause for the panelists here. Now I would please leave it to the moderator, Dr. Nand Kumar, and yes, Dr. Vinay Kumar. Sorry to interrupt. Please, sir, you can continue now. Thank you.
Sir, may I request you to start, please?
Yes, I'm doing that. I'm doing
Yes.
that. Is it audible?
Yes, sir.
Hello?
Yes, sir. You're audible. Yes, sir.
Fine. Fine. So I extend my sincerest thanks to the organizers of First International Patient Summit 2023. I wanted to be in Delhi with all of you, but due to some official constraints, I'm here in Patna and I'm talking to all of you online. I extend my thanks to Ratna Devi ji also for organizing such a good program, and especially to Dr. Nand Kumar ji, who has been the link between this conference and Indian Psychiatric Society. So my topic which has been allotted to me is access to mental health care in Asia Pacific, and time is around 10 minutes. So considering the length and breadth of Asia and time allotted, I think there is a huge mismatch. It cannot be covered. In 10 minutes, you can not take names and some salient features of all those countries, but some general things, some pinpointing things can be picked up. So I have tried to do that. Before I really reach to main points, I would like to offer you few points to ponder, and the points are: human genetic architecture imparts vulnerability, and it's a fact. You cannot wipe out schizophrenia. You cannot wipe out depression. You cannot wipe out bipolar disorders. There have been theories in past, and people have tried this kind of thing, that kill all schizophrenic and things will be okay. You cannot do that, because there is a genetic sharing between cardiac illness and schizophrenia. There is genetic sharing between diabetes and major mental disorders. So you cannot wipe it out from civilization, human race. Second important thing is a quote from Rousseau, that as civilization advances, mental illnesses step in. Again, a point to ponder. Are we going to back? Is it possible to go back? Can we remind the whole journey of civilization? Third point is, in the process of survival and cultivating happiness, we used to harvest some stress, but now we are manufacturing 24/7. Can we rewind this digital era? Can we rewind industrial revolution and medieval periods, all kind of wars and all? Probably not. And things have changed. The world is flat now. Stress is omnipresent. Almost all stressors are global citizens now. This is very important. In this flat world, if something happens in America, if something happens in Australia, if something happens in France, that affects India too. At times, a village in Andhra Pradesh, because his son is working in the US, his son is working in Japan, his son is working in somewhere, other countries or Europe. So this is the situation. And the most important thing is almost all cultures are losing their originality, leading to loss of immunogenic effects. Insulation part, safety part, care part, which was embedded in cultures, have gone. Apart from this, mental disorders are not only those there which are visible, which are syndromal. There are situations which are subsyndromal. Apart from that, there are many problems which are invisible. We don't know, we don't see. Lots of studies we do and lots of things we publish, but I realize, and I think majority of people realize, that we seldom cover rural areas of India. We seldom cover tribal areas. So very focused studies are being done, but we do not have very comprehensive. Suppose X study is about schizophrenia, and that is about Delhi, or that is about Mumbai or Patna or Jhansi. That is not going to talk about Andhra Pradesh, Telangana, or Tamil Nadu, or Bastar. That is not going to reflect that. Apart from that, there are many things invisible. There are many stresses are invisible. There are many problems are invisible. There are many mental issues are invisible. So this tells us about the magnitude of the problem. Global Burden Disease 2019 showed that mental disorders remain among the top 10 leading causes of burden worldwide, with no evidence of global reduction in the burden since 1990. It's a report of Lancet Psychiatry. Regarding Asia Pacific region, I would like to share a few lines. That in Asia, problems arising from poor mental health are the second largest contributor to years lost because of disability. The Asia Pacific region has close to half of the estimated 450 million people affected by mental illness globally. Across Asia, a growing percentage of the adult population experiences a diagnosable mental illness in any given year, from 4%, as reported in Singapore, to 20% in Vietnam, Thailand, New Zealand, Australia. In the People's Republic of China, India, Japan, Republic of Korea, Thailand, Malaysia, prevalent rates have increased significantly. When we talk about India, very important survey done in 2015-16, it's known as National Mental Health Survey. And this, if you see the core finding, the overall weighted prevalence for any mental morbidity by 13.7 lifetime and 10.6 current mental morbidity. Another study led by Dr. Rajesh Sagar, published in Lancet, and this talks about in a different manner. It tells us that in 2017, 197.3 million people had mental disorders in India, including 45.7 million with depressive disorders, 44.9 million with anxiety disorders. 1 in 7 Indians were affected by mental disorders of varying severity in 2017. This is more than 14%. The proportional contribution of mental disorders to total disease burden in India has almost doubled since 1990. And this study talks about 1 in 7 Indian is having psychiatric illness. Is it static? Is it growing? Needs to be studied. Most probably growing. So when we talk about mental health care, what kind of care we have for patients? Inpatients, mental hospitals, inpatient in two forms, general hospital, psychiatry, and mental hospital. Then OPD in hospitals, government sectors, private sectors. Then community care, telepsychiatry, and coupled with that, mental health promotion services. So these are key factors. When we talk about treatment part, and that includes rehabilitation as well. So now let's see how things are happening. WHO Mental Health Atlas of 2017, which has data from 177 countries out of 194 countries who are member of WHO. So this talks about the access related issues. It talks about how the public expenditure is being done. So it tells public expenditure on mental health in low income and middle income group country is meager. More than 80% of funds goes to mental hospitals. The allocation of human resources ratio, low to high ratio is like this, 1:72. Median is 9 per 1 lakh. Mental health beds 8 or less for 1 lakh population in low income group and middle income group population, but over 50 in high income group countries. Mental health promotion and prevention, only 63% of WHO member states have a minimum of 2 functioning multi-sectorial mental health promotion and prevention programs at a national, 53% only mental health law. So this is the situation. 63% WHO member states have some kind of mental health promotional programs, but 57% of them only mental health law. So this is the situation. Why I'm putting the complete range? Because when you look towards Asia, we have both kinds of countries, low income group, middle income group, and high income group as well. So the pathway to mental health care is like this. Community sample, if you take of having mental illness, is the base of this pyramid. And psychiatric hospital, where most money is being spent, is a kind of tip of the pyramid. In between lies all these things. And you see where the funds are, where the services available are at the tip only. From primary care to community sample, if you look, you will find that the large population is not being taken care of properly. Large population are at the hands of quacks. Large population are at the hands of other doctors, other discipline or faith healers and all. So this is the current situation, and probably this is valid for majority of countries in Asia Pacific as well. So mental health care, the situation is, I have already stated, that is the kind of top-down situation where inpatient mental hospitals are taken care most efficiently, and health promotion, other things are in a very non-significant manner. So it is important. We have to treat patients in inpatient services, fine, OPD at every level, it's important. But community care is also important. Telepsychiatry, which has been recently introduced, is also important. And mental promotion services, also very important. I would like to share photographs of 3 pioneers who changed the world vision of mental health care. The first one is, left side is Professor Vidya Sagar, who did unique experiment at Amritsar by treating cases of schizophrenia in camps with and family members were there with the patient to take care of them. Second one, in the center, we have Professor Edinidi, who gave us the sample of Raipurani block, and the kind of method he evolved during Raipurani block experiment is still being practiced in India in National Mental Health Program. And then Dr. Ravi Kapoor, who was in Neeman, and he did Sakalwara project in Karnataka. So these are the pioneer people who showed entire world that community care is important thing, and that has to be understood and that has to be implemented. So these Indian experiments initiated global trends in community psychiatry. In response to, actually, last year, few months back, I was talking to British Indo-Psychiatric Association meeting in UK, and I was highlighting this, that you gave us asylums, you gave us mental hospitals where patients used to be kept inside doors, locked doors. But what we did with the beginning of postgraduate teaching in psychiatry, with the beginning of general hospital psychiatry units, we started doing OPD on a larger basis. We started doing community psychiatry. So we unchained the whole concept of psychiatric care. We took it to community. So India is a kind of pioneer in this. In response to such global trends, now I'm giving some examples from Asia Pacific region, that in response to such global trends, many countries in the Asia Pacific region have begun to establish mental health policy and guidelines to move from institutional to community mental health services. An emerging network of representatives from governments, peak bodies, and key organizations is emerging in Asia Pacific to build supportive relationships to facilitate the implementation of locally appropriate policy frameworks for community mental health service reforms. The network is supported by Asia Pacific Community Mental Health Development Project, which involves 14 countries, regions in the Asia Pacific region, initiated this collaboration with WHO Western Pacific Regional Office. APCMHD project is led by Asia Australia Mental Health. I do not know more things about this, just got reference and I'm trying to share, but probably I do not know the details of this, how this is functioning, but now I am also interested that we must know about how it's functioning, how things can be linked with India as well with this. Now some more samples. There is a concept, good concept was developed in Malaysia. They thought about making their hospitals, mental hospitals, as a kind of hub to cater community care. And a good example, in India also, in other parts of the world also, this kind of services are available where a hospital is trying to do outreach programs. Even private sector hospitals also, for their commercial reasons, do outreach program. But if outreach program is being done in any form, it tries to bridge the gap, it tries to bridge the treatment gap and improves patient care in totality. Another example is from Korea, Gyeonggi Provincial Mental Health Program. It was established 14 community mental health centers across Gyeonggi province in 1998. And it was successful, and then it was made a national project in 1999. Another program is from China, National Mental Health Service Model Reform Program, 686 program, that's called. In China, it was developed by the National Center for Mental Health to increase access to mental health care through the development of 60 demonstration areas in 30 provinces. Globally, this has been one of the largest mental health reforms ever seen. Another project is in Indonesia for community mental health nursing, extended care patients intensive treatment, early diversion rehabilitation stepping stone project called Exeters project in Hong Kong. Now coming to India, but all of us, I think majority of us present in Delhi or online are from India. They all know what India is doing, but still I'm just enumerating. The first one is District Mental Health Program, DMHP, regarding which I talked that they are following the same model which was given by Dr. Enenvik way back, I think last century. So this was launched under the National Mental Health Program, aimed to create a decentralized mental health service to the integration of mental health into primary healthcare system. And majority of our districts now have a psychiatrist, majority of them, not all, but majority. Further, to bridge the treatment gap, India has started a tele-psychiatry system known as TeleManas. Things were being thought earlier, basically when COVID came, and this added kind of speed to all of these things. And I think all psychiatrists, also those who are working in their personal center, private center, or many hospitals also are trying to offer this kind of services, that once you consult here, then you can keep consulting online. That will save your time, that will save our time. Another thing is tele-mental health assistance and nationally actionable plan for states is TMANAS. This initiative was announced by NIMHANS under NTMHP to provide free round-the-clock tele-mental health services in all parts of country. Fourth one is Manas Mitra. It's an app to promote mental well-being among people. It was started in, again, COVID era. The feasibility and utility of this app is currently under field testing, but definitely time has come to have more apps, have more app-based treatment, because now everybody, the way the world has become flat, and in a similar fashion, each and every hand is probably having a mobile phone, and not only mobile, smartphone. Mental health promotion is very important area, because you cannot bridge the treatment gap completely. It's not possible. It's not possible. You cannot have required number of psychiatrists, psychologists, psychiatric social workers, psychiatric nurses to take care of each and every individual who is suffering. That's not possible. So one of the best ways is mental health promotion. Probably this is the reason even country like America has started talking on positive psychiatry. In last decade of last century, American Psychological Association President Seligman gave the concept of positive psychology, and in last decade of this century, Professor Dilip Jeste, an Indian origin psychiatrist in US, who was the president of American Psychiatric Association, he started working on positive psychiatry. Things are similar. When we talk about psychiatry, then neurology and other psychopathological.
We need to wind up, sir, because we have to discuss also.
Fine.
We can take
So
up some
now,
questions. Thank you, sir.
one of the last slides. So now things are being taught, now discussed at that level also. So mental health promotion is very important, because preventive wellness training is important. It should be made part of the school. Social movement kind of thing is required, the way yoga has been promoted in this country. Social involvement is also important. So this, I would like to remember this quote by Professor N.N. Vick, who said once that mental health is too big an issue to be left with mental health professionals. We only mental health professionals cannot manage the whole issue, and each and every person in society should be motivated to take part, because it's a quote of Shekhar Saxena. His experience is very important to share. The last slide, that during my time at WHO, I had the opportunity to interact with professionals in more than 100 countries. I learned that when it comes to mental health, all countries are developing countries. All developed countries are developing countries when it comes to mental health. This is the important message, including economically developed countries like the United States. If we extrapolate to Asia and say that Australia, Hong Kong, Singapore, all these developed countries are also developing nations when it comes to mental health. With these few words, I would like to say thank you. This is the Platinum Jubilee year of Indian Psychiatric Society. And
Thank you, sir. Thank you very much for covering almost entire aspect of mental health in Asia Pacific region. And so well, you have connected civilization with rising mental health illness and issues. Thank you very much. We will take up the questions later. So with that, I invite Dr. Harshita Umesh for her presentation. I would request to complete in 10 minutes. I think she's online.
Hi, yes, I
She's
am here.
online. Yes.
Can you hear me? Hello, am I audible?
Yes, yes, you're audible. Please go ahead.
I will begin. Thank you so much for this platform, especially to Mukta, who's been coordinating with me online. Just before I begin with the challenges and opportunities of working with the youth, I'd like to highlight how Dr. Vinay said that mental health is too big an issue to be left with mental health professionals. And also how you, sir, highlighted that we need more psychiatrists, but I would say we need more mental health advocates and we need more youth working in these spaces, because the youth are the people who are here today and the future of tomorrow and the leaders of tomorrow. With that, can we go to the next slide, please? Before I highlight on like why exactly we have so many deaths in the youth, so many suicides, as was highlighted recently by a colleague who died in the Safdarjung hospital, there's a lot of effects of poor mental health. And usually when we look at the narrative, we usually talk about this from a very individualistic perspective, saying that, hey, maybe this person wasn't really able to tolerate the stress. But from this image that you see here from the WHO's Determinants of Adolescent Health Development and Ecological Model, we see that there's something known as a ripple effect, where it's not just what's happening to an individual, but also what's happening with the family, like relationships, financial stability, domestic violence, what's happening with the community, that is your friend group, your peer support, your teachers, the academic pressure that's placed on us, the societal expectations, but also the neighborhood we live in. Because right now, with climate change being one of the biggest global heads of the 21st century, and I'm joining here live from Dubai, where the COP28 is going on, we talk a lot about climate anxiety and eco-anxiety, but also that which is exacerbated by situations such as the social and economic inequalities, the discrimination, the racism, the migrations, etc. In 2010, the cost was estimated to be $2 trillion to $5 trillion per year in reduced productivity, and it's expected to rise to up to $6 trillion by 2030. And while depression and anxiety are the most common, the global economy is almost predicted to lose at least 1 trillion. So I think when we talk about mental health, we should change the narrative from individualistic perspectives and actually realize that this impact is based on cumulative and intersectional experience, and that as individuals, we respond and perceive to these triggers differently. Next slide, please. So this is one of my favorite slides, mainly because of the memes on this particular slide. But even though it is an age of connectivity and communication is so vital when we talk about challenges and opportunities in the mental health space, in mental health advocacy. But on the internet, social media is one of the biggest triggers, because what we see on social media is often not the reality. It's just something that's very glamorous, and it kind of puts us under pressure to actually keep up with all the latest trends and stuff. And if you're not being kept up, you don't feel like you're actually there. And even there's a lot of issues about internet safety and cyberbullying. And often people consider it as one of the best mediums for campaigning. But it's also true that on these spaces, when we voice our actual feelings, we might actually be left out and bullied, and that would make us feel even more lost and isolated. With that, I'd like to go to the next slide, please. Yes, where we talk about language as a barrier. Even though there's been a lot of conversation that's happening around mental health and co-designing and co-planning, our language is one of our biggest barriers to actually to communicate with each other, because we use terms, we actually exchange terms very casually without realizing it. Oftentimes, I've heard my own batchmates, I've heard my own peers say that they're depressed when they actually mean that they're sad. And what this actually does is it does something called semantic satiation, where actually people get used to hearing these terms and the gravity of the situation really gets reduced. So I would say when we actually talk about critical issues and misconceptions, and we're dispelling these misconceptions, even though we're vocalizing it, we need to be very inclusive of our language. We need to actually understand that there's a difference between being stressed and being anxious. There's a difference between saying that somebody has bipolar disease and calling them bipolar. And there's a difference between saying, hey, I'm OCD because I like being organized, I like being neat. Next slide, please. But we still do this. We still tease each other about this. And here are the biggest reasons and the challenges that we face, even as youth when we work together, or even when we're communicating with the adult population. We romanticize it because it seems cool, it seems trendy. Sometimes people label it as attention-seeking behavior. And Google in these days, oh my God, like let's not really go there, but it's important. Google actually really helps us exaggerate the situation. It gives us information that's very readily accessible, but without having professionals to actually diagnose, it can actually put us down in this spiral. Next slide, please. So I would say that with all of this, there is a lot of challenges that we face, not only as youth, but as a community that's working to advocate for mental health. And I would say that to turn pain into purpose, to turn passion into progress, it is trying to find within us, what is it that we most resonate with? When you explain something logically to people, most often they'd be willing to listen to you, but it doesn't really help them feel connected to the issue at hand. It doesn't help them really understand why it is important for this particular issue to be addressed. But when you actually touch their heart and you say, hey, no, but these are the emotions that's coming into play. This is why you should be concerned. This is why you should care. People will actually come back stronger and say, yes, we want to support you with this. So next slide, please. And that is why I would be talking about the youth today. There's a quote that says, empower the youth with skills today and they will build a better tomorrow. And this particular picture is taken actually a couple of days back on Youth Day at COP28. So as you can see over here, even though there have been 1 lakh delegates to the Blue Zone at COP, there was close to more than 1,000 youth delegates here at COP advocating for more inclusive spaces. So it is known that we do have some experience, we do have some knowledge. Of course, we do come with the barrier of our age being the biggest issue. But if you empower us, if you engage with us, I think we could co-design and we could co-plan better, because we bring to these spaces cultural relevance, we bring to these spaces peer support, we bring to these spaces innovative approaches that might have not been otherwise looked at. So next slide, please. This was something that was done at the World Economic Forum, where they actually had something called as the Youth Mental Health Challenge. And in this particular challenge, we aimed to actually find solutions that were reducing the stigmatization of mental health and enabling young people to address their needs and improve their well-being as an overall. And the overview that we saw was that there were 118 submissions with 15 winners. And in these winners, we had people who built AI chatbots. We had people who opened up support groups. We had peer-to-peer counseling sessions. We had peer-to-peer trainings and capacity building workshops. We also had learning simulations, social networks that were being leveraged, art as a creative medium where there were other narratives being spoken about how you can advocate and utilize mental health in such spaces. Next slide, please. An initiative that I'm working on with friends is called VADA. And in that, we're talking about Project Semicolon, where it's okay to be not okay. Oftentimes we say that, oh no, this is such a trivial issue. It's fine, you know, you don't have to be so emotional about it, but it's all right. Let out your emotions. It's very cathartic. And what we want to do with this particular project that's actually onboarding relevant stakeholders and signatories, because we want to make this an international project, is we realized that there's been a lot of suicides, and it's only at the very end when somebody commits suicide that we say, hey, you know, it's really sad that this happened. I wish I could have done something. But we want to change that narrative. We don't want people to say, I'm sorry, a suicide has happened. We want to prevent that from happening. We don't need more tragedies to tell us that this is a pandemic. So what we want to do is, for the number of suicides that have happened, and I think the data for 2022 or 2021 is almost 706 1,000 youth deaths by suicide. We want to ask people to run the mile, like run about 7 kilometers. Either they can do it together or they can do it alone. And what we want to do is we want to create a network of people that are there for each other, because we do know that physical health is one of the contributors to mental health, because it raises our dopamine levels, our endorphins and everything. And we hope that by moving onto the streets and stuff, we educate not only the people who are affected by it, but other people who are promoting mental well-being in their societies. And we hope that that word that gets out will help us to raise funds for people who are unable to pay for their medications and for their therapy, and to actually raise our voices and leverage our platforms on social media to campaign for this. Next slide, please. So these are some of the initiatives, but I would say that even if it's not these initiatives that are being supported, there is a lot of ways to actually meaningfully engage with the youth. And I use the word meaningfully because there is a lot of youth washing, there is a lot of tokenism, there is a lot of times where people just have youth on the panel just to say, hey, we have a youth representation. And I'm so glad that this panel actually has meaningful representation, because I did collect a lot of data before coming here, and to be able to voice those voices who have not been heard for so long is a real privilege. And at this juncture, I would like to say there is no I win, you lose, but it is we lose. If one life is lost, it is a society that loses that life. It is a community that loses that life, and it's very overarched in its effects. I'd like to take 1 minute before I jump into the 10 points that I've listed on my slide about the 1.8 billion campaign that was held by PMNCH. And this was the Global Forum for Adolescents, where they collected all of these inputs, and they had 5 thematic areas where they spoke about all of these things. And the biggest thing was that all of the panelists, or at least most of the panelists, were all youth. And these were youth-led initiatives, youth-led advocacy efforts, youth who are bringing change, youth leaders of today, youth in the parliament. And 1.8 billion is out of 7 billion, that is our population today. That is amazing to hear. So when we talk about inclusivity, we don't want you guys to just have us at the very end as an advisory group, so that is something that is needed. But from the conception of an idea to how we progress on making it into a project, to finally implementing it on ground and taking feedback from it and having it something that will be revolutionized in that sense. Training and capacity building sessions where you have expert reviewers as people as experts in the field, and for us to actually peer teach each other, because very often we're able to tell each other things that we're not able to tell other the adult population or other people. Education and awareness. There are a lot of initiatives that are already educating and creating awareness, but it's important to have access to the right kind of information, because otherwise we're all going to be panicking over here. Technological integration, because this is a global world that is very modernized, and having that technology aspect of it does make it more accessible, but also affordability, because we're not an earning population, we are dependents. And a lot of times services like therapy or even the drugs, they aren't affordable, and hence a lot of people aren't really compliant to their medications, even though we tell them, no, it is important to stay compliant. Creative outlets, because art is one of the best mediums to actually express your thoughts, express your views, express your feelings. Campaigns, creation of youth-friendly spaces. We want spaces where we can be heard, where we can be engaged. But most importantly, we need financing and funding for youth-led initiatives. This is not just a phase for us. This is not just time pass for us. But this is something that we want to take into our future and take into our careers. Next slide, please. So I would just like to end the slide with these 2 pictures. The first picture is on the left, we had a mental health first aid workshop where we actually trained 20 people, and this was held in Bangalore for the International Adolescent Health Week. And what we did was we actually had we trained 20 people who were 20 students who were interested in learning more about mental health first aid. And the result of this was that we had more peer support groups that were formed, but also finally an establishment of a mental health club that's running campaigns and initiatives. The picture next to that is what we can possibly accomplish by funding and financing youth-led initiatives. So this is something called as Rising Resilience that was held by a project called Connecting Climate Minds. Here we actually were funded by the Wellcome Trust, and At this particular event, we are all climate change activists and advocates, and we spoke about the need for research on the intersectionality of climate change and mental health, the effects of eco-anxiety and nostalgia, and what exactly is the gap in research and how exactly can we move forward from there. I would just like to end by saying one thing, is that involving youth in the design and delivery of mental health programs is not just a recommendation, but it is a necessity. It is such a powerful strategy to create interventions that are not only effective, but also accepted and embraced by the very demographic that they aim to support. And together, let us commit to a future where mental health of our youth is a priority, and our voices are at the forefront of the solutions we create. Thank you.
Thank you. Thank you, Dr. Harshita. Very nicely explained. I completely agree with no ripple effect. It's very powerful, not only for suicide, but all serious mental illnesses, ranging from the family to the community, the entire society also. And of course, language is a very important barrier. So we have to find out something new for the language. We will come back to you for discussion. So once we listen to other two important panelists. So with that, I invite Dr. Smriti Rana for your opening remark. May I request you to finish in 10 minutes? Thank you.
While we get the hit, Dr. Ratna, thank you for having palliative care at the table. We often get left out, and I think some of you know that saying, if you're not at the table, you're probably on the menu. So I've taken the liberty to change the heading from mental health and end of life to palliative care, because I think that the myth about palliative care is that it is only for end of life. So I'm using this opportunity to advocate for the fact that it's not. And I think, is somebody controlling the slides? Okay, can you move forward, please? Having said that, I will talk about the quality of death in India. The Lien Foundation had commissioned the Economist Intelligence Unit to do a study on the quality of death index worldwide, and India ranked at 67 when it was first done in 2015. And this is along parameters that include access to medicine, healthcare professionals, community services, and so on. In 2021, we climbed up to 59. Big step forward. We have a long way to go. Next slide, please. So I think a lot of colleagues here have talked about the catastrophic out-of-pocket healthcare expenditure. And this is the figure. 55 million Indians are pushed below the poverty line annually, out of which, this is because of healthcare, and 38 million approximately because of the cost of medicine. Next slide, please. This is a story that we came across a few years ago, where this young couple had approached a high court in, a district court in somewhere in Andhra Pradesh, asking to euthanize their 4-year-old son because of the amount of pain that he was in. Of course, he was declined that request. And when we heard about it in South India, a bunch of palliative care organizations got together trying to track down this little boy. And we found in the course of that search that he had been to every major city in South India, from Hyderabad to Madras to Chennai to wherever. And he had even been in a children's hospital that was a stone's throw away from one of India's biggest pediatric palliative care units. And he did not receive a referral. Finally, when we found him, he was in an ICU in a Bangalore hospital. A social worker went overnight with morphine from Hyderabad, was denied entrance into that ICU, and this child died an excruciating death. His father was then in 12 lakhs worth of debt. Next slide, please. Why am I telling you all of this? This ties up with what Dr. Nand Kumar has also talked about. The National Crime Records Bureau talks about the reasons why people chose to end their lives. Number 2 after domestic issues is somebody living with a chronic advanced illness. In 2014, it was approximately 1 in 5 people. In 2021, we're still at number 2 as a reason why people choose to end their lives. There is no study that I know of that ties these two issues together. But I think any thinking person who applies their brain can understand why this might happen. Catastrophic out-of-pocket healthcare expenditure being one reason, of course, but also lack of access to palliative care and pain relief. I'll talk to you about that in just a moment. Next slide, please. So just coming to the idea of disease and illness, we use these words interchangeably, but disease is the abnormal condition that affects an organism. It requires treatment, etc. But what results from having a disease is illness, which is all your discomfort, emotional distress, dysfunction, so on and so forth. And disease usually causes illness, but there are people who have diseases that don't necessarily experience the illness aspect. If your hypertension is under control, you're not going to feel daily distress about it. And people who have early stages of cancer, they don't even know that they have early stages of cancer and they present very late. We also have a hot debate about somatoform disorders and psychosomatic illnesses. I'm not going to get into that. But how you experience your disease in terms of an illness will impact your disease trajectory. If you're too fatigued to go for your next doctor's appointment, it is going to have an impact on how your disease progresses. Your emotions have an impact on how you respond to certain treatments as well. Next slide, please. Next slide, please. Pardon? What is? Where am I? No. No, sorry. Not here. Okay. Okay, while we wait for that, I'll also just refer back to a few things that the speakers before me talked about, the invisibility of mental health. Palliative care is an invisible topic as well. So we have the double task of bringing two invisible subjects together and then making them visible. And just as mental health experiences all of these difficulties in terms of training, capacity, etc., so does palliative care. And the Kerala model of palliative care has been celebrated because largely we have included the community in the delivery system. And I think that ties up to universal health coverage, which is today, by the way, Universal Health Coverage Day, where we talk about, a system functioning if you include communities in the design and delivery. And I think Harshita was talking about that in the context of mental health. And I just have to say, I found her talk extremely inspiring just now. Sorry, my 10 minutes don't count, please. Okay, I'll carry on just to save time for everybody. The challenges that we face in mental health, in palliative care, I think all of you who are mental health professionals, if you take a crisis that people are experiencing or just the daily stressors of life, when you have a diagnosis of a serious illness added on top of that, you are, each of those stressors gets 1 second. So a family that is dysfunctional to begin with, you add on a crisis of a serious illness, I think all the fault lines are going to show even more. If your coping mechanisms are not healthy, that's going to show. So trying to resolve mental health issues, not just for the patient, but for the entire family at a time when serious illness hits the family is very, very difficult. Okay, here we go. Thank you very much. So these are some of the common illness-related mental health conditions that we see in palliative care, and I'm not going to go into all of them in detail, but I will talk about the fact that anxiety is one of the most pervasive, and the anxiety it could be because of all of these reasons: increased symptom burden. How many of you here look forward to a dental appointment? Even one person? No, just thinking about a dental appointment is going to bring the sound of that drill, right? Yeah. Some of you are thinking about it right now and getting anxious. So imagine if you have a serious illness and you have to go for chemo or you have to go for, all kinds of procedures, the anxiety is going to build. Decreased function. Suddenly I used to be somebody in charge of my life and taking decisions. And now I'm a patient. My autonomy has been taken away. I can't even drive by myself or use the toilet by myself. Of course, the socio-economic impact, I will not belabor the point. I think we all know how huge a deal that is. Loss of my role in my profession, within my family. Information. Somebody talked about an information black box. How many patients even know what is going on with them? There is collusion culturally in our society where we don't want the patient to know how bad things are for them. Decision-making. Shared decision-making is not a thing in most of our cultures. And the isolation that the illness brings, not just because of the illness itself, but because of various other socio-political, psychosocial reasons and so on. Guilt because of maybe not going to the doctor early enough, not doing enough as a caregiver. And of course, the fact that we're losing our futures or our sense of the future. None of us who had plans in 2019, I don't think most of those plans came to pass once the pandemic hit us. Okay, it's stuck again. Trying. I think I'll just go forward. Yeah. Yes. The thing is, I'm not quite sure what I'm. All right. Okay, here we are. So unlike in other mental health settings, some of the things that we need to look out for in a palliative care setting is the person in pain? Because if the person is in pain, that is going to cause them to behave in a particular way, to have anxiety, for delirium caused by the disease itself, dementia, substance abuse, the medications themselves, and worsening of the disease. And often breathlessness is something that causes a lot of anxiety, and whether the disease itself is the source of the anxiety. And at that point, I think what we really need to do is share information and really learn the skills of communication. In palliative care, we believe that communication is as important a skill as any of your medical procedures. If you're going to be upgrading your skills medically, you also need to educate yourself on how to speak with your patients and families. 2019 is when the Medical Council of India, the then Medical Council of India, introduced attitude, ethics, and communication into a doctor's undergraduate medical curriculum. 2019. Wonderful. Who's going to teach it? No one was taught it. So, but there is a skill, there's an art and a science to our communication. And there's a lot of stuff on this slide, which I'm not going to go through. I'm happy to share these slides, but there's a lot of things that we very systematically deal with. It's not just about, tell me about your feelings, tell me about your pain. It's not that. These are as intricate as surgeries. And also, restoring a sense of safety in a person when they're going through one of the most tumultuous times of their life, and what that safety means to that person. Sometimes we impose our preferences and values on our patients, but to sit with them and understand what's important to them is actually what's really necessary and vital. And to have the ability and presence to have frequent clarifying conversations with them. Symptom control, I cannot emphasize this enough. We cannot adequately and effectively help somebody with their mental health at this point in their lives if we are not aware of all their physical symptoms and what those physical symptoms mean, whether it's insomnia, fatigue, breathlessness, pain relief. And unless we manage their symptoms, there is no point proceeding forward and trying to understand what their mental health condition might be, because somebody who is in acute pain or has delirium is not going to even be able to work with you to improve their mental health. And depression, of course, there's quite a big prevalence of depression depending on the disease, on the disease type and so on. And depression itself leads to a decreased quality of life at an already complicated time. And it may lead to the desire for an early death. And the interesting thing is, if you provide good palliative care, that in and of itself is a key to prevent depression when somebody is seriously sick. So this is another reason why palliative care needs to be brought in at the time of diagnosis and not just when it's end of life care. I'm going to wrap up. And we need to make the distinction between grief and depression. Like Harshita said, semantics are so important. Very often people are grieving in anticipation of their death. That is not to be confused with depression, and it has to be treated as such. There are challenges in certain mental health conditions, especially depression, going underdiagnosed, misdiagnosed, or sometimes just the adverse impact of common medications in serious illnesses might result in them being diagnosed as having, a mental health condition. And a lot of the symptoms that you see are actually a result of the disease and the illness itself. Okay. And we have to be aware of the fact that many of us are not trained in understanding these things. So this is again where there's an intersection between mental health and palliative care capacity building. I'm not going to preach to the choir about this particular slide. There are many best practices that have been established. But I will end with just a couple of, if you'll indulge me, 1 or 2 stories. Mental health is not just about sitting with someone across a table and understanding what their problems are. In this picture, what you're seeing on your screen, maybe in 2019, there was this young boy who was about 18, 19 years old himself, who was in a road accident. He had a concussion, he had some spinal cord trauma. He was told by the doctor to come in for physiotherapy once a week to the medical college hospital. Simple, right? But this boy lived at home with his mother, single parent, no father. They lived in a house which had steps. He couldn't walk. He's a big made boy. That house itself was on top of a hill, and the nearest road was another hill across, 1 kilometer away, where there was no bus stop. If he had to go for physiotherapy, 4 men from the village had to take the day off, carry him on a khatia, take him to that road, where the mother had to spend 2 weeks worth of her salary to put him in an auto, take him to the hospital and bring him back. Of course, this boy didn't get physiotherapy. And as a result of which his mental health declined. What happened in the interim was our home care team found him. We started taking care of him at home. Parallel bars were put in. We did reverse innovation and all of that stuff. This boy is now walking on his own, and he's snapped out of his depression. So interventions in palliative care can actually go a long way. And a lot of people think palliative care is end of life, but this is a graphic that we developed to tell you it's a lot more than just end of life care. And lastly, I'll wind up by telling you this. One of the greatest barriers to effective palliative care is access to medicine, to opioids for pain relief. In spite of the fact that India has been one of the largest legal manufacturers of morphine, the raw material. The NDPS Act, the Narcotic Drugs and Psychotropic Substances Act, has been a huge barrier, which our organization and a few others, it took 19 years of advocacy to amend it, to get pain relief to our own patients in India. And today, less than 4% of people in India who need pain relief get it. That's after 19 years of advocacy and almost 9 years after the law has been amended. But this is the difference it makes. We found this man sitting in this position for 3 weeks. 1 immediate release oral morphine dose, and he was able to get up and have a cup of tea. And I wonder what the impact on his mental health was. And promise my last slide. I got into palliative care in the year 2000 because my adoptive mother, my Masi, who had adopted me, she got cancer. We had no pain relief for her. And this is the timeline of development of palliative care in our country. Okay, 2003, I had lost 5 more people, including my father and grandmother and a few others. And you'll see that in 2010 is when palliative care was recognized as a subspecialty. 2012, it became a part of the National Program for Palliative Care, thanks to Shri Keshav Desiraju, who's also, we all know and love him. The NDPS Act in India was amended as a result of 19 years of advocacy, making pain relief more accessible in 2014. 2017, it was included in the India National Health Policy, in the medical curriculum in 2019, 2021, in the DNB, as well as nursing curriculum. In 2023, this year, my mother died of idiopathic interstitial lung disease. I work with one of the most premier palliative care organizations in the country. I cannot tell you the hoops I had to jump to get her morphine for the relief of breathlessness. We had to go by a lot of, we had to go and get in touch with various doctors. And eventually the medicine came from Trivandrum all the way to Allahabad. So this progress that you're seeing on this timeline is wonderful, but what does it translate to on the ground is an entirely different story. So I know we talk about mental health, but mental health is incomplete without adequate pain relief. So I will stop with that and thank you for being patient.
Thank you very much. Thank you for picking up the quality of death. We talk a lot about quality of the birth and painless delivery and all that. But it's something very serious and need to work and perhaps understand that quality of death. Thank you very much. So with that, I will invite our last speaker. Please.
Good afternoon, everyone, and thank you, Dr. Ratna and the organizers for this opportunity. It's a post-lunch session, but the previous speakers were absolutely inspiring. So my job is easier today because I already have your attention. So essentially what we are going to do with today's session is that make the problem, or rather the issue of mental health, which is multi-layered and extremely complex, a little more complex by adding to the mixture the whole spiraling crisis of non-communicable diseases. So what I'm going to try and do today is basically make that connection, which to some extent was done by the previous speaker, that, you know, what happens when these two, very difficult situations come together. And now that is a story that is untold, and it is a story that needs a lot of telling. Next slide, please. So I work for an organization called, and the reason why I'm sort of introducing the organization is that Global Health Advocacy Incubator, where we are based in Washington, D.C., and we work across the world in different countries. We've been doing that for several decades now. We work on health policies because our slogan is that changing policy is the easiest, most self-sustaining and cost-effective way of quickly saving lives. Now, one of our primary areas of work is also non-communicable diseases with a focus on cardiovascular health. But as we started working on NCDs, we realized that this is, it's basically something, it was a reaffirmation of something that we already know, that unless we address the unrecognized burden of mental illness across the world, then our gains on mitigating the NCD disaster will be it will be difficult to basically save a lot of lives. And we really need to take urgent action, particularly on telling this story. So, these are figures that all of us know, but just to kind of plunge right into the heart of the crisis, we are looking at an explosion of NCDs across the world, and it is already happening. We are at a tipping point, and I like to call it a perfect storm where all of the complications, all of the disease burdens are kind of acting together to aggravate the situation. And what's also happening is that, apart from the fact that NCDs kill 41 million people, accounts for 74% of deaths globally, and of these deaths, 86% and more happen in LMICs. And of course, the burden of hypertension, diabetes, obesity, which are also risk factors for all NCDs, is also on the rise. Apart from all of this, this is coinciding with the fact that economic crisis and job losses are impacting people's access to healthcare. And global inequity is rising. Now, several years ago, when we were working on the Sustainable Development Goals, our favorite slogan was leaving no one behind. But the situation is such now that we are at the risk of leaving many, many people, millions behind, because the most vulnerable and the most marginalized are the ones that will fall off the treatment net. And people with mental illness, mental conditions, and severe mental health issues are the ones who are actually the most vulnerable. So just to, talk about the neglected connection, it is a fact that in the last several decades, there has been a lot of progress on the issue of mental health. We recognize today that mental health is a universal right. The definition of health, in fact, is no longer about the fact that, you need to be free of disease, but it is about well-being and also as much of the mind as of the body. All of these revised definitions and ways of looking is incredible progress, particularly after, all of the prejudice and injustice that has happened for so many decades. But as always, every day, there are so many people who are in urgent need for care and attention. And, so it's basically for us who are working on non-communicable diseases and on health system strengthening, we felt that the focus has to be on the last mile. So even as policy elites are setting the discourse right, there are policies that are being put in place. What is the situation on ground? What exactly is happening in the daily lives of people? And also the fact that there has been an epidemiological shift across the world. More and more people are going to live longer, and they will have some NCD or the other, and probably coupled with mental illness, because the fact is that mental health and NCDs are comorbidities that exist in a big ways. And not just that, it's also a fact we know from studies that poor mental health exacerbates consumption of tobacco, alcohol, which are top risk factors for NCDs. So, and of course, the fact that, as mental health experts will know that those with mental health conditions are least likely to continue with their treatment or to sort of receive their treatment on a regular basis. So what we are looking at, therefore, is a double burden. And I'm not sort of going to dwell on all of these data really, because there are some stories that have been told, for instance, of what happens when you receive a cancer diagnosis. And as a survivor myself, I can never forget the day that my oncologist told me about the diagnosis. And it was not just about the fact that there was chemotherapy the next day, or the fact that there would be radiation therapy, just the fact that it's a storm of emotions. It's a fact that you worry about your income, you worry about your family, you worry about so many things. But cancer, in fact, in our country is probably one of the rare NCDs in which, not a rare NCD in the sense that it's a rare NCD, but there is a lot of patient support in cancer. So there are many patient support groups. And I remember from day one, I had such fantastic family support as well as peer support, as it were, from these incredible women who were going through the same process. And that kept my hopes up. That never allowed me to slip into depression. And I think what all the experts talked about previously, that looking at this connection, that how is it that people who have been diagnosed with cancer or who have had stroke, because we have research that indicate that people who have suffered stroke have such high incidence of psychosis and various other psychiatric conditions. How are they dealing with that? We know that the health systems in our country are such that we are handheld through the treatment. Maybe there is quality of care in the treatment per se, but what about the quality of care as far as mental illness and mental health is concerned? So just to sort of therefore come to the conclusion that today's world is a world of survivors. So we need to look at survivorship in a very big way. And when we are looking at survivorship, we are looking at more and more people, millions of people across the world who are going on to live full lives, but they do have a chronic condition that they're dealing with every day. So that in case of living with NCDs, or the lived experience, as we like to call it, of NCDs, mental health is going to be at the center of that existence. So this is, I'm not going to dwell on this slide too much, but just wanted to make the point that this is so complex. I mean, it is, when NCDs is as complex as our mental health, if you sort of consider them as two separate verticals, because the problem of stigma, the problem of prejudice, the problem of apportioning blame, because you see NCDs is also there are many modifiable risk factors for NCDs. So be it tobacco consumption, be it alcohol, whether or not you have a fit lifestyle. So there is always the risk that you may apportion blame. So when you're spreading awareness about these risk factors, we have to do it in a way that we don't apportion blame. So plus the fact that it's a lifelong interface with the health system. Therefore, survivorship is a whole new world where there is an intersection of ecosystems like even the food system. Is your food system safe? What about climate change? What about increasing pollution? So we have to consider all of that. And at the heart of it is not only a policy framework that supports this change, but also change of social norms. So in our work on NCDs, just to come back to what I started with, we realized that we will continue to advocate for stronger health systems and policy change, but we will do so with insights from the lived realities of people who are living with NCDs. And, you know, those who are victims and survivors of many public health concerns. And while doing that, while looking at those stories, because, sorry, I'm just going to skip this slide. While looking at those stories, 2 minutes, yeah, sure. So we basically, I'll leave you with the parting thought because I have to wrap up now, that power of voices. So we need to look at people's stories, their lived realities, and how, and we are doing that. We are going to the communities, we are talking to people, we are asking them, why is it that it is so difficult to adhere to your hypertension treatment? Why don't you take your blood pressure medicines regularly? And in those conversations, we see that mental health is absolutely a very big obstacle. Apart from the fact that there are larger systemic obstacles like medicine availability, etc., we see that how they are feeling about themselves, how the external pressures, the financial pressures, how that's impacting their lives also has a very big sort of impact on treatment adherence per se. So these are just some recommendations of how to integrate mental health with the overall NCD agenda. I think important to have country action plans. Some countries do have action plans, but how do we communitize it? How do we take it down to the last mile? How do we create treatment protocols that consider mental health as a comorbidity and enable the practitioners to ensure that, you know, advice and counseling about mental health is integrated into the whole treatment process? How do we build empathetic and skilled health workers? So the frontline workers like the ASHAs and the ANMs are really the harbingers of hope, as it were, in the community. They are the guiding light. How do we enable them to also deal with mental illnesses? And of course, finally, population-based measures for prevention. So with that, I rest my thoughts. And of course, also, I echo what has been said before, that what we need today is a social movement and a social revolution. Thank you.
Thank you very much. Thank you all the panelists for very meaningful expression of their thought process and very meaningful dialogue, in fact. So I think Dr. Vinay Kumar is, he has left or is still available online. Sir, are you here? So Dr. Vinay Kumar has left. So we have 3 panelists, I think, with us. Dr. Harshita, you are here, available? Dr. Harshita, are you available online? No, not available. So we have.
Hi, I'm here.
She's here. She's here. Okay. So Dr. Harshita, thank you very much for your excellent presentation. It is highly appreciable. The ripple effect is very, very important, in fact, that we all know. And mental health is perhaps more connected to ripple effect, because ultimately it affects the entire chain. I would like to ask you one thing. You have mentioned language as a barrier. No? So language as a barrier. So would you suggest some language for non-barrier? No, that can be non-barrier. Like what we see commonly, that we express a lot nowadays. We believe in expression, and there is a perhaps lack or diminished non-verbal communication, and that is very powerful perhaps for expression of your empathy, support. So what's your thought on that?
So thank you so much for highlighting this. This is one of my most favorite things when I take my mental health first aid workshop for youth, actually. What we say when we talk about language as a barrier is that, as you mentioned very rightly, we are very vocal about our emotions. We're very expressive, but we're also not very mindful of the kind of language that we use. I think we need to I know how it's people say a lot of times, you need to think before you speak, and that we need to really wonder if what words we're making make sense, because words hold a lot more power than we actually assume them to. So when I talk about language as a barrier, I'm talking more about like the art of communication also, where we actually speak about how you can be more inclusive. You label the person not as a disease. So you would not say that he's a schizophrenic, but rather he suffers from schizophrenia. You would not say that he is depressed. You would not label the person and say that no, they are defined by the disease, but rather you would say that this person actually suffers from this particular disease. Or even then, when you talk about saying that you're sad or you're upset, you would actually use your emotions, like the words you attach to each of these emotions differently. Like you would say, I'm feeling a little scared right now, instead of saying I'm panicking about something. Because at the end of the day, when you actually use these words and you normalize them in conversations, in everyday conversations, you're diminishing the value and the power that these words hold. And that is the biggest issue when you call language as a barrier. So you need to be mindful of what you say, on how you actually express what you're saying. And I think this is not only an exercise in control for the youth, but also for the adults, where they're so quick to judge each other on these words.
Right. Thank you very much. So it's more about the communication and how you know express it, the skill about the
Yes.
communicating your feeling, in fact. But I feel that
Yes.
no, non-verbal things are also very important, and we are perhaps losing that. I think no, if you take your communication part further, uh, Mrs. Smriti has mentioned something about information and communication regarding palliative care. Do you think in palliative care, the communication to the self plays very, very important role also?
Communication to
Self.
yourself. Do you
I'm
mean?
suffering, and how to communicate my suffering with my own self.
Oh, that's a big question. I would even say that before I go to the patient, I'll check how the healthcare workers are communicating within themselves. I think that's the more fundamental issue. I would say that, one of the mistakes we make with people who are living with serious illness is like the toxic positivity of, don't worry, you'll be okay, think positive. By doing that, we diminish their reality, because people need to exist in that reality and find coping skills within it. It's our discomfort with illness that prevents us from having meaningful conversations. So I think the self-reflection is a 360-degree one. So this is why I feel that communication skill building in healthcare providers is actually urgent. It's an urgency that we need to recognize, because a lot of how patients see themselves depends on the kind of healthcare they're getting.
Right. So if I go about my experience, no, we see a lot of patients who keep on suffering, especially for chronic illnesses also. So what we have observed that coping skills are difficult to teach. Like, no, if I want to teach you coping skill, you want to teach me, it's your perspective. So the most of the patients are not able to perhaps understand their pain, and the pain is very powerful emotion. And we may need to find out perhaps expression of the pain into different emotions, so that no, the pain can be processed in a little better way and can be minimized. And here the role of communication is very important. How you communicate regarding yourself for your illness. Say, for example, why me? That's a communication. So I think it's very important and need further perhaps, because you have very well mentioned the painkiller, the opioid. It's very difficult to find now, and in the interior places, it's more difficult, in fact. So maybe country specific, cultural specific, perhaps we may focus perhaps in this area. So,
And if I may add to that.
sure, please. You can take this.
It is fine, thanks. If I may add to that, that when you mention culture and you're talking about individual responses as well, or communication per se, it is also about the popular culture. Look at how historically and even today, illnesses, various illnesses and chronic illnesses are depicted in popular culture, in films, in books, in just, sort of even in common parlance. How about also thinking of changing that? The fact that there has been advancements in treatment and we have hope, there is survivorship, there are, so the whole way of the manner in which you look at a stroke survivor or a cancer survivor, that too has to undergo that extremely, I think, the whole cultural change as well.
Thank you very much.
Yes.
You have mentioned very well survivorship program. No, do you think survivorship can be thrivership also? Like, no, you have thrived, I would say, you have not survived. You are thriving so well.
Yes, absolutely. And I think even in terms of designing health solutions, we have to look at survivorship. So how does a person who has lived and not sort of at least, has gone on to survive, it should not just be a data that you find, okay, 5-year survival rate or 10-year survival rate or survival rates for different cancers. Survival is a
beyond the
story.
statistics.
It's success, it's beyond statistics. So we need to celebrate that as well.
Thank you so much.
I'd really
Yes,
like to
please.
say something here, which is we shroud all talk about illness in the rhetoric of war. Losing a battle, fighting, and that pressure it puts on a person to fight, which in a lot of cases, yes, there is a place for interventions and stuff, but in a lot of places where it's futile, I'm talking about someone with 4th stage, 4th grade cancer, going for one more intervention, because popular culture tells them that otherwise you're going to lose this battle. And I think that prevents them from choosing more meaningful interventions for themselves, which focuses on quality of life, being with their families. And a lot of these people end up in ICUs dying alone. So this language, like you said, is so important. And I think we need to take away the war rhetoric when we're taking care of people.
So thank you very much. In fact, no, and thank you all the panelists for very meaningful communication. I would say communication here. And thank you audience for being with us. Thank you very much. With this, I hand over the mic to organizer.
Please stay for a moment, ladies and gentlemen. Sure. Very extensive and inclusive panel discussion, opening a new paradigm to think and modify on ground realities and policies to bring in positive and benefiting changes towards patient health. Our mission here upholds more stronger as to empower, educate with efficacy and efficiency about both the challenges and opportunities about mental health integration. As we conclude in the morning sessions and yesterday also, that the right question can lead to quest of right answers and solutions, and to reduce the size of information black box. And we vision soon to experience the ease of availability of rare vaccines and palliative care, as it seems to be easy on the slides in the timeline. Thank you for giving that picture to us, ma'am. And yes, I'll please request the panelists to please conclude the session with a beautiful photograph if we can have. And please, a round of applause. It was a very extensive session, a lot of knowledge and bringing, again, more hopes to bridge that gap between the reality, ground realities, and what we really dream of. Thank you, sir. Thank you, please. Thank you. Honored to have your time here. We have had spectacular 2 days here discussing very important events and, spurred beautiful ideas for future visions. Let's lighten up a little. And yes, there's a workshop in line for all of us on patient safety, patient and family engagement. But foremost, I would please request all our guests and speakers and delegates to please move forward if you could. to have this activity engaging. We all would work like family members together, and there's some activities in line. Please, I would request all the members sitting at the back, if you could please move forward. It'll be interactive session for us. So there'll be some activities. It'll be easier and interesting for all to participate. I take the opportunity to please invite Dr. Parminder Gautam, National Professional Officer, Patient Safety and Quality, WHO India. Please, ma'am, join us on the stage. Oh, sorry. So sorry, sir. So will help us moderate this session for us. Next, please, I take the privilege to invite Dr. Mahesh Devnani, Additional Professor and Joint Medical Superintendent, Department of Hospital Administration, Office of Medical Superintendent, Postgraduate Institute of Medical Education and Research. Sir would be taking care of medication and safety. Please allow me to invite Dr. J.N. Srivastav, Advisor, Quality Improvement, NHSRC, Government of India. Sir, yes, please. Please join us on the stage. Please, great round of applause for all the great panelists here. And I'll request Dr. Ratna, please, ma'am, join us on the stage, and ma'am would be introducing how we would proceed for the wonderful workshop ahead. Thank you. Okay. Dr. Parminder, do take the honors and please.
Good afternoon. Once again, after that enriching session on mental health, we come back to how to engage. The objective of this workshop is to raise awareness amongst patients and the civil society and the need for engaging patient for patient safety. So as the people we are already 1 hour behind, so we will avoid any introductory remarks. And with this, we will have first 2 brief presentations from our esteemed guests. And after that, we will have an interactive session wherein we have developed the 5 consensus statement as well as 5 consensus statements as well as the actions that needs to be taken to how to engage patients. So therein we will request your insightful, innovative and practical suggestions so that how we can further strengthen these statements and we can put it forward to the Ministry of Health for their endorsement. So to begin with, I will invite Dr. Mahesh Devnani. Sir, he is an Assistant Medical Superintendent with Postgraduate Institute of Medical Science, Education and Research, PGI Chandigarh. We more know. He would be talking about the medication errors. As you know, that 50% of the patient-related avoidable harm is related to the medications. He will also dwell upon what are the strategies that may be adopted to minimize and to avoid medications error, and more so what role can patient and the family plays in reducing medication errors. Over to Dr. Mahesh Devnani, sir. Thank you, Dr. Parminder, and good afternoon, everyone. Let me first start by congratulating the organizers for thinking about a conference on patients, one of the very important stakeholders. Why we have medicine? Because of the patients. And most of the conferences are for doctors, paramedical science people, nurses, etc. And I wish more power to you. And we would like to see more such conferences. And every year we would like to see this Patient Summit, International Patient Summit for next year. And thank you very much for having me here today and giving me this opportunity. And the objective of this talk is not to tell you what we do. What we want, the objective is first to apprise you what the medication safety is, and then how can you participate as the patient advocates, and how do you take it forward in your organizations in whatever work you do, so that we can improve the patient safety overall in the country and globally as well. So raise your hand if you are on some type of medication. Okay, raise your hand if someone in your family takes regular medicines. Raise your hand if you have ever taken a medicine pill. Raise your hand if you have ever been hospitalized. Any of your family member has been hospitalized. If you have ever visited a hospital, raise your hand. So see, we regularly take medicines. Someone in our family takes medicines. Let me share an incident yesterday happened in my family, and I was telling Dr. Ratna also. My parents are traveling right now, and they both are on different types of medicines for NCDs. So at home, what they usually do, they have separate boxes for their pills. So, and their timings are also different. But because they were traveling, my dad thought, like, let's put all the medicines for both of them in one box, and we have to travel only for 3 days. And yesterday he told me that I probably have taken one of the anti-diabetic medicine of your mother. See, this is a medical error. It may not have culminated into an adverse event yesterday with my father because it was just one tablet of anti-diabetic tablet. But just imagine if this was some, a drug with a narrow therapeutic index. Narrow therapeutic index means drugs which can cause some kind of error, some kind of adverse event. And imagine if the dose was higher. So these medication errors, as Dr. Parminder said, are preventable, and 50% of the preventable patient safety issues are related to the medication. So that is the context, that is the premise. And with that, I would like to share with you, and we'll understand from you also in the consensus statement when we develop, and if you have any questions also, how you can actually improve the awareness among patients, where patients demand patient safety, where the patients demand medication safety, where the patients understand their medication responsibilities and the responsibilities of the healthcare providers. So next, please. I'm just sharing some of the incidents that happened in my institute, and these are not isolated incidents. These incidents happen quite frequently. In those who don't understand Hindi, it says that there is an alleged incident of death by a wrong injection. So next, please. Another is that by injecting a drug, it has been alleged that someone lost the eyesight because of the drug was not the appropriate drug. Next, please. Similarly, a nurse inadvertently mixed a chemotherapeutic drug with the 5% dextrose instead of with the normal saline. So it also led to some of the problem. We prevented it because it was recognized immediately that the IV fluid that has been used to mix the chemotherapeutic drug was not the appropriate. It was prevented, but it could have led to a serious issue. Next, please. So what is a medication management? There are so many things that we need to make right. It has to be a right item of right quality in the right form, and administer it through the right route, given at the right time, at the right frequency, to the right patient as well, and the storage should also be right. At the same time, the right labeling, the right price from our perspective as the hospital administrator, the right source, we are procuring it from the right source, right systems, right approach, and right training to administer those drugs. As I just now shared, if the nurse has mixed it with the wrong IV fluid, then it can be a problem. So there are so many things that needs to be made right so that there is no problem. And this is what I'm talking about at the hospital. At the house also, the patients need to understand, and I'll share with you the 5 moments of medication safety that has been proposed by the WHO, and there is an app also for that. So patients also need to understand what are the things that they need to make it right. Next. Why we are talking about medication management, why there is a need. As I mentioned, there are a lot of harms that can be prevented. So as it says here, it's a little bit far from me. Can I have the, can I see here? Yeah, okay. 1 in 10 patients is harmed while receiving hospital care in developed countries, 1 death every day, and injure approximately 1.3 million people just in the US. And the cost associated to this is quite high. It's almost $42 billion US. Next, please. What is a medication error? As I discussed, a failure in the treatment process that leads to or has the potential to lead to harm to the patient, or any preventable event that may cause or lead to inappropriate medication use or patient harm. Next, please. There are adverse drug reactions and there are medical errors. These are technical terms. I'll just skip this and the next slide. Just skip them for saving the. Just next. Next. Now, there are subcategories to the medication errors, but from the patient's perspective, we need to understand that there are different stages of medication. So error can happen at any stage, and patient needs to be vigilant at all these stages, from prescribing and transcribing, just in case if it is an international treatment, is taking international treatment, dispensing, administering, as well as during the monitoring phase. Next, please. This is a Pareto chart. The objective to keep this here is that to just tell you there are different root causes for one issue. And when I share with you the 5 moments of the medication safety, you will understand that how these all things, when come together, ultimately lead to a medication error. And at every stage, we can actually prevent them. Next, please. So what could be the errors that can happen at the prescribing stage, and how the patients can be vigilant and prevent that? So inadequate knowledge about the drug indications, interactions, or the contraindications. Not considering individual patient factors such as allergies, pregnancy, comorbidities, or other medications. Wrong patient, many a time it happens, not just in the surgeries, but more commonly in the wards. It happens where the wrong medication is given to patient, either when it was said that the patient's name is same. So it's better to, identify patients with some other identifiers, whether it is a bed number or the registration number, not just the patient's own name. The inadequate communication, whether written or verbal, very common especially during the transition of care, especially when the orders are given on the phone, right? Or when there are some issues of cultural competencies, because in healthcare, we have healthcare workers from different cultures, different backgrounds, different linguistic skills. So if there is some kind of a communication barrier or a communication problem, can also lead to such kind of problems. The documentation are illegible. We sometimes make jokes about these also, but this is a serious issue, and that's why the NMC also says, and we also emphasize that when these are written prescriptions, they should be in the capital letters. In the generic drug form, write the drug in the generic, and if there is an online system, it is better to prescribe online. Mathematical errors when calculating the dose, this also happens, and incorrect data entry when using computerized prescriptions, duplication, omission, or a wrong number. Next, please. Look-alike, sound-alike drugs. This is one of the major causes, and a lot is being done worldwide to prevent this, but we have not been successful to completely eliminate it. The drugs, those look alike. Now let's see these red drugs. Similarly, if it is an injection, the cap would be of same color. The label would be of same, design. It's just the drug is different. It is written, drug is different. The strength is different. But for a layman or for anyone who doesn't understand medicine, this could lead to some kind of error. For example, these 2 drugs, these are 2 different drugs. One is amlodipine, that is an antihypertensive, and another is a salbutamol. This is for the asthma. Similarly, the drugs which sound alike, the phonetics is same. For example, if in the brand form, if I give you the example, for example, the Amset is an ampicillin, that is an antibiotic, whereas Amset is an amlodipine. It sounds Amset. One is A, another is E, right? Similarly, even in the generic forms, we have so many drugs having the same phonetics. For example, the there are different, but there are brand names, Alprazole and Adprazole. But even the generic forms, there are lookalike drugs. So recently, the next please. The WHO released a comprehensive report in which I also contributed on the lookalike sound-alike medicines. And I would encourage you people, you being the patient advocates, it's written in a very simple form and keeping in view the how the patients or the patient advocates can use it, because this year is to promote the patient engagement for the patient safety, and this was recently released by the WHO. Next, please. Now, what are the various causes of lookalike sound-alike error? One is the illegible or poorly legible prescriptions. Another is incorrect selection of medicines from drop-down menus in the computer. That is also very common in the hospitals. So I'm just right now giving you how these errors happen, and then later we will discuss where your role comes, how you can make us, the healthcare providers, more, concerned or aware or more vigilant about these things. So, verbal and telephonic orders, we discuss inappropriate use of error-prone abbreviations. The use of abbreviations, so very common in medicine. We start using abbreviations from the first MBBS itself when we start taking notes. We have different types of abbreviations when we take notes. The use of trailing zero, for example, if someone writes 2.0 gram, it could be taken as 20 grams as well. And adding a zero before the decimal is, or the forgetting the zero before the decimal also leads to such type of problems. So, next, please. The other causes are like during dispensing storage of Lassa medicines on the same shelf next to each other, as it happened with my parents yesterday. They kept the drugs together, and then because they look alike, my dad took my mother's pill. The during administration, unclear instructions saying as directed, patient doesn't know how it is being directed, or sometimes even the healthcare worker might not be aware of. Selection of products according to familiarity with the packaging or the strength. The next, please. Now, this is the stage, that is the administration of the drug. I believe many errors happen. And we as healthcare workers, we as healthcare administrators do a lot to make this a step more safer in the hospitals. But when the patient is taking drugs on his or her own at home, then your role comes, and we'll see how you can play a role in that. So, wrong patient, wrong route, wrong time, wrong dose, wrong drug. Omission, failure to administer also leads to complications, right? And the inadequate documentation of the medication. Next, please. At the monitoring stage, problems happen. For example, the lack of monitoring for the side effects, the drug not seized if it was not working, or the course completed, drug seized before course completed, or the drug levels not measured or not followed upon, and the communication failures happening at the monitoring stage. Next, please. Now, there are high-risk patients when we are prescribing or administering drugs, we need to be more vigilant about. So one is the patients on the multiple medications with the different comorbidities. Patient taking drugs for neuromuscular disorders, diabetes, hypertension, hypothyroidism, so many drugs. There might be drug-drug interactions. There might be lookalike drugs. So the drug which is to be taken in the morning before meal, you might take it after the meal, or you might take in the night. So just because they look alike. Patient with comorbid conditions, renal impairment, for example, because in renal impairment, the excretion of the drug, the rate of excretion of drug is lower. So the drug has to be lower for such patients. Otherwise, the concentration of drug would rise in the blood. Pregnancy. Definitely, because there are drugs which cross the placental barrier and could harm the fetus as well. The patients who cannot communicate well, bedridden patients, sometimes patients with the the different types of impairments, whether it is neurological impairment or muscular impairment or other psychological impairments. So patients who cannot communicate well, the patients who have more than one doctor, this is, and especially if you are taking drugs with different pathies, there is no problem in taking drugs from different pathies, but make sure that if there are some interactions, you are aware of them and you do not end up in having a situation where you do more harm to yourself by taking drugs from different pathies rather than improving your situation. Patients who do not take an active role in their own medication use, and this is where we want more patient engagement. And there are barriers to that also that I'll discuss and how we overcome those barriers, right? The children and babies are again at high risk because they don't understand, and the patients, the parents have to be more vigilant about that. And I have seen that parents are usually more vigilant when the drugs are being administered to their kids than themselves. And I don't know why that's because they love them more. But that is they have to be they have same level of vigilance when they are administering the drugs are being administered to them as well. So next, please. There are provider-related factors also. We'll just skip it for now. Let's go to the next one. Now, what are the various preventive measures? One is the use generic names. This is for the doctors, but then patient advocates, that patients can demand that please write drug in a legible and generic word. There are guidelines from the regulatory agencies. There are guidelines from the NMC to write drugs in the generic form, right? Tailor prescribing for each patient, that has to be done depending on, as I said, someone has a renal impairment. They know the high-risk medications and take precautions about those. They communicate clearly to the patient, develop checking habits, which is always beneficial. Active patient involvement, we'll come to that. The report and learn from errors, no blame culture in the hospital, and education and training, which we emphasize a lot. And in fact, we are collaborating with the WHO. We are to improve the medication safety in the hospital. Next, please. So this is this year's theme for the World Patient Safety Day. It was the engaging patients for patient safety and how we can engage patients in the medication error. Next, please. So this is just a Swiss cheese diagram, and I'll make it simple for you. What happens that there are different levels of checks and balances which prevent the errors from happening. And usually what we do, because of the oversight or because we do those things in routine, that we don't use those checks and balances. And one of the checks and balance is actually the patient engagement. If the patient is vigilant, he or she probably would block that error from happening, because when there are holes in the checks and balances, this is just a depiction in the Swiss cheese. When all those holes are in alignment, the error actually does happen. But if at any stage, if we prevent that hole being aligned with the other holes, then this can be prevented. And the patient engagement is one such check and balance that can help us in reducing the medication errors. Next, please. This is, I just put it just to let you know, I don't want to discuss it in detail, but the WHO's strategic framework for the global patient safety actually emphasizes, if you can see on the left, the patient and the public and their engagement, and there are different other subsections to that. So everyone recognizes that it is not just the system or the healthcare workers who are important to make to improve patient safety, but the patient itself is at the core of improving the patient safety. Next, please. Now, role of patients and families. How you as patient advocates can make patients more aware and the families more aware, and help us in improving the patient safety. So the know each medication prescribed, dispensed, and administered, including the name, indication, and strength of medicine dispensed, and the dose to be used. It takes some time, but you can, emphasize these things, educate the patients because patient many times thinks that probably what doctor has written is the best. They know the best, right? What I have to add to that? If they have written it, I have to take it. No, they should also, see and try to understand what these medications are, what are the doses, what time it is to be taken, why it is given before meal, why it is given after the meal. So if they can get some, if the you people, the organizations like you can have those types of education imparting sessions or some that, because you have a large patient base, like so many patients are members of your organizations, you can actually make them aware, improve their awareness about these things. Beware of potential errors with Lassa medicines and be vigilant about those errors. We discussed this. Learn to label and store medications appropriately at home to avoid Lassa. Check with the healthcare providers if in doubt about a prescribed, dispensed, or administered Lassa medicine. So there is no harm in asking. Many times we do not want to, question the doctor. We hesitate, especially people who come to the government sector. We have seen that they think that the healthcare worker might get annoyed, right? So probably he or she has given. Even I have seen one patient who the attendant was very vigilant. He said, yesterday the bottle's color was yellow. Today injection that you have given, it is red. Has the drug been changed? So the nurse said, yes, the drug has been changed. This simple observation that the color of the IV drug, the bottle got changed. Yesterday it was yellow and today it is red and pink kind of thing. Why so? So instead of just thinking that probably it has been changed, let's ask, has it been changed? Next, please. So this is the 5 moments of medication safety proposed by the WHO, and then there are different questions in that. This, for the sake of the time, I'm just putting it here. The presentation is with the organizers, and you can Google it also. This is very important from the patient's perspective. If the patient can learn to ask these questions at different stages of medication, they would prevent a lot of medication errors that are happening worldwide. At every stage, from the starting of medications to the taking of medications, adding a new medication to the already medications that are being taken, because there are drug interactions, right? And reviewing the medications and stopping the medications. Every stage, there are some questions that the patients should ask. The next, please. Now, there is an app which makes it easier. So you can check it on Google Play as well as the Apple Store. Next, please. Now, there are barriers to patient engagements, and here you can help, addressing those barriers. One definitely is the illiteracy or not having enough education. So that is one. Another is the low socioeconomic profile. Many times the patients of low socioeconomic profile, probably they think that I should not ask this question. How you can, make them more aware in the language they understand, at the level that they understand. And simple thing, as I said, the color change they saw and they asked the question. It's not a rocket science. For someone who is illiterate or literate, if the color is different than yesterday's color, anyone can ask it. So, but making them aware of these things would help us in reducing the medication error. The complete trust in doctors and nurses as authorities that we discussed. So, lack of knowledge about medications, and that is why we have this workshop today, that if you are aware of the medication errors, you can actually go back and work with your organization and your patients, make them aware a little bit in, piece by one, they will be, more aware over the years. So it's not going to happen overnight. We understand it. It will take time, right? But this is the starting point, the first International Patient Summit. And as I said, I congratulate Dr. Ratna for having it and giving this opportunity that we can have this discussion with the patients, because most of the time we are having these discussions in the patient safety conferences or some other conferences, and most of the time we are sitting and the nurses are sitting and we are then thinking how we make hospitals more safe. But the patients are taking drugs at the home as well. And most of the time we do not spend much time with the patients, at least in my hospital. I can't say about the other hospitals, but most of the time the healthcare workers are busy with their routine that they have very little time to discuss with the patients, counsel them about these things, right? The reluctance to ask questions, we do not want to annoy the healthcare workers. The difficulty of reporting errors and adverse events. This is also a problem. If there is an error happening or if something has happened at the home, who does the patient report to? So those mechanisms also we need to understand and develop. They might go and say the doctor, but then these are not being reported. There, there is no reporting. What I should say, mechanism at the national level that where we can have more such. There may be pilot projects, but then if we can emphasize that the hospitals should have some mechanism where the patients can report the adverse events, even if it is a passive reporting, it helps in improving the medication safety. Next, please. So the solution is you. There are barriers, there are issues, and you are the people who can actually help us make the medication safety and improve the overall medication safety in the world. So that is what we are seeking from you, your help. And if you also face any problems, then we are ready to help you in whatever way we can, give you the information, provide you information. If you want us to come somewhere, I would be happy to come and discuss. But because you have the engagement with the patient, you are working with the patients. You are the people who can, make it happen. So I think that's the last slide. Next, please. So, I have one more. So this is one of the pamphlets that WHO has prepared for the patients, and I made sure that I have got these printed and displayed in my hospital at different places where patient can see in Hindi, English, Punjabi as well. So before you take, your medication, check the date and time, and ask your healthcare professional. So these are at least 3 simple things that patient can do. Next, please. So thank you very much, and we look forward to your questions whenever we have that session. So thank you very much. Thank you, Dr. Mahesh, for demystifying and simplifying a very complex topic like medication safety and putting up the things in a very systemic way. More so how the patients can contribute in improving the medication safety. I also have a question to you, sir. As you told that there is a recent ongoing study, which shows that the maximum number of medication errors happen at the time of prescription and transcription error. So that is there. And you talk about be it the illegible handwriting, use of capital letter, tall lettering, and this trailing zeros and leading zeros, all these things. And so these are their part of the word. And one of the obvious solution that comes to our mind is the digital prescription or digital health record, but that's far from being realized in a country like ours. So I would like to know that what strategy can be adopted to improve the prescription behavior of the providers, because it starts from there. So, or anything, I've been told that your institution has taken some very innovative strategy to address the issue. So we'd like to know that how should we approach to this transcription error, to reduce transcription error, what strategy or the measures that we can apply. Thank you very much. The old habits die hard, as we say. So because physicians because they have a habit of writing in a particular way, and they keep writing in that particular way, you just can't expect everyone to do write in the blank letter. So 2-3 things that we have done. And so what we promote, as we say, that there is peer pressure. If someone is doing, and then the others also see that if they can do it, if one unit, one doctor, one department is doing it, then we show it to the others that, see, in the same day you have the OPDs in 2 blocks. They are writing it in the capital letter. They are writing it in the generic. Most of our doctors write the generic drugs. But even in the generic, let me tell you my example. When I was not well few days back, I wrote tablets ciprofloxacin 500 mg, 1 BD, 10 tablets. You know what I got from the pharmacy? Cefuroxime instead of ciprofloxacin. And it is despite writing in the generic and the capital. Instead of ciprofloxacin, I got the cefuroxime. So I sent back. So then it's not the end of the story, because then we have to make sure that if this error has come to my notice, then it must be happening at the other. So again, go back to the drawing board, go back to see what is happening, why it has happened, workload, etc., etc. So there's too many things. As I said, there are provider-related issues also, which I skipped because this is not a topic for this audience, but there are provider-related issues. Fatigue is one of the issues that we face. Burdened healthcare workers are more prone to errors. These problems easier explained than sorted out, because the HR issues, the recruitment issues, there are so many other issues. So one was that, and there was one more thing I wanted to share with you, which is skipping my mind right now. But if I remember, I'll share with you. So, does that answer your question? Yeah, So thank you, Dr. Mesh. Now I have the honor and privilege to invite Dr. J.N. Srivastava, the Senior Advisor with National Health System Resource Center for Patient Safety and Quality. He has been leading the quality and patient safety movement in India from the forefront from the last almost 15 years now. So you name it, anything that the milestones what we have achieved during our journey in India. And I have the privilege of working with him for over 2 years. And most of my learnings, my speech, my contributions, I contribute to you, sir. And he has been leading it from the front and in a very silent and very persuasive way. It is because of his efforts that we have an ISQA accredited national quality assurance standards for India, which many of the countries want to replicate. We have got Kayakalp, we have got Muskan, we have got, and the latest feather in the cap is the self-assessment tool for patient safety by the name of Sakushal. Sakushal is translation to be safe. So I invite Dr. J.N. Srivastava, sir. He would be talking about the community participation platforms that have been created by Ministry and Health, and how they can be leveraged to improve, engage patient safety. Over to you, sir.
Thanks, Dr. Parminder, for generous and very kind introduction. Indeed. So at the outset, in fact, I'm very grateful to Dr. Ratna Devi, PAIR, and many other organizations who have, in fact, taken this initiative to arrange the first patient summit. Because as Dr. Mahesh said, that too many conferences have been happening, are happening about the hospitals. Like on 14-15 itself, Academy of Hospital Administration has arranged SASH, that is a sustainable hospital. But talking about the patients and what role they can play in largely in the promotion of the safety culture is important. First thing I want to ask, I mean, this presentation is there, I won't take much time. How many of us are over here who have been at some point of time or other the practicing doctor, nurse, or the service provider? Can we raise the hands, please? Happy, unhappy, immaterial. But how many have been there? Yeah, at some point of time or other, who have practiced the medicine or have been in, thank you, who have been into the art of healing. So, I mean, and of course, Dr. Mahesh already did the head count that how many of us are taking the medicines, have been the patients nearby you. But tell me frankly, does any doctor or the nurse want to do the harm to the patient intentionally? And obviously, I mean, since time does not permit, I am at the fag end holding you. And before that important declaration of the network. Otherwise, I would have loved to communicate. None. Still, but the harm happens. And as a patient group, representing patients, have we thought that, I mean, with due regards to all the speakers, whom I have been hearing post lunch time. We are trying to address the small, just leave it. Okay, thanks. These are the, I would say, the band-aid approach. Pardon my language. But there is a, to my mind, it comes a large systemic issue, which unless we come together, I represent, in fact, on behalf of, like Dr. Parminder said, represent indirectly or indirectly the government of India and the government system. How do we collaborate the efforts? That is, in fact, either today or maybe at a later stage, we would like to hear. Because even at the policymaker side, whether it is the central government or the state government, or in the district health administration, nobody wants to create a system where the patients are harmed. And with this whole lot of thing that, okay, the prescriber should take the, they should change their prescribing habits and other things. But somewhere there are larger systemic issues, and unless we, my key message is that unless we address those issues, we may not be able to hit the root cause. To give a small, very small personal example, like just 3 days back, just 3 days, on this Saturday only, my own son, grown up, had to undergo a surgery. Question came up, he is grown up, self-earning, that which hospital to choose. Believe you me, those who of you are from Delhi, I took him to Preet, Bihar, to get him operated there, with the simple reason that the surgeon who was going to operate upon him is somebody who happens to be known to me and whom I can communicate any point of time. That's all. As a medical professional, as a practicing doctor, some point of time, I knew that this is the procedure would be undertaken. This would be the course. So somewhere the communication and the changing relationship between the service provider and the so-called user has to change. Still, I'm sorry to say, though I represent government, the relationship between the service provider and the community or the patients is giver and taker. That it is there. You have no right to accept, no right to ask that why I am writing this prescription, why I am choosing this particular drug, and why this particular procedure would be undertaken. No. And the larger issue, like Dr. Mahesh brought out, I was keenly listening. Few of you may recall that there was a board committee, though in the MBBS days we never liked. That is also a fact. But if one of you go through, I have still got copies with me, it mentions that somewhere they did the time motion study and they found that the actual consultation time between the doctor and the patient was 48 seconds. 48 seconds, I'm repeating again. As a patient group, please go to a district hospital or the community health center and just observe that by looking at the record, that how many patients a general duty doctor is seeing or a nurse is supposed to be taking care of, whether in the night duty. Again, quoting the personal example that day. This was the experience. I was staying in the night with my son and he had certain soakage. I got a bit concerned around 3 o'clock in the night, bent, looking around for the nurse, and I could locate. But fine, I knew the system. That's why I had traveled 40 kilometers away from Dwarka to that place. But imagine somebody who is coming over there. And that, in fact, that I'm looking at the watch also, and this presentation will be there. I will just quickly take you through in 3-4 minutes. Another important thing is that most of us are privileged to be working in the urban setup. Pardon if my perception is wrong, we do apologies to those people. But what are we doing where my 65% of the population lives, who are dependent on the health and wellness center, who are dependent on the PHC or the community health center over there. With the increasing focus on the ambulatory care. Now the government is very keen that, somebody quoted in the previous session about the Kerala model and the morphine group of drugs being flown to be administered at a particular place. But how do we replicate these practices in the northern majority of the so-called BMARU or the EAG states? So these are the couple of challenges which in fact I thought in the forefront, let me put on the, and the last point is that Dr. Parminder knows we were together then, that at NHSRC we were working on the standard treatment guidelines and developing on the methodology manual, and having in fact visited and learned from the NICE UK, we wanted to replicate their model. And one of the key requirements says that in any SDGs, patients group have to be there. Believe you me, that may be my own lack of communication, lack of networking, but for each those 14 clinical conditions which we worked, we could not get an appropriate representation. So these are the couple of challenges. Can you just put on my presentation in 3-4 minutes? So notwithstanding these challenges, and just pass on 3-4 slides. Yeah, move on. Yeah, move on. I'll come to the crux. Move on. Next one. Next. Yeah, just hold on here. So what the government has done, that initially there had been Rogi Kalyan Samiti, RKS, they call it. Now to make it broad-based, there has been the Jan Arogya Samitis, which have been created. Those of you who are interested in knowing a bit more detail, enough material is available on the website, and we will be happy to share with you. So one institution which has been created is the Jan Arogya Samit, which is a compulsory requirement. Even I'm basically a quality person. Though the division name of the division, Keshav, has been changed to not quality improvement. It is a quality and patient safety division since last 4 years. So the short point is that one of the critical requirements which we also look, which may be of interest to you, to know that when our national surveyor, who have undergone the ISCO accredited training program, they go and look at the functionality of the Jan Arogya Samit. That is in the rural area. Okay. Next one. Yeah, so next one. Just move on. I don't want to delay everybody. Next. And next, you come to the next one. Next. Yeah. So Jan Arogya Samit in the urban areas. In fact, that is where in fact majority of us may be ignorant. There is a Mahila Arogya Samit under NUHM, National Urban Health Mission. At the household of the 50 to 100 households. And the third is that village VHSNCs. These 3 critical institutions are there where I would urge as a patient representative, if you can develop some linkage. The government will be very happy. I have gone through the note which in fact Dr. Parminder in his present role has prepared for the government. Will be very happy to issue an order. But believe you me, merely issuing an order does not serve a purpose. Otherwise, this country would have been at some other level. We have got one of the best constitution in the world. We have got law, you name a thing, we have a rule, regulation, bylaws, well laid out. Our challenge is that how do we operationalize? And that is where we are looking for a support from the patients group or the organizations who are present today over here, that how do we connect these dots? Because there's a forum, and then in that case, there would be the requirement. It is not only that you involve the patients, what role they can play, and we will have to spoon feed initially to our medical superintendent, PHC in charges, even district hospital superintendent, that this is the critical role and you must incorporate in it whenever you are conducting certain proceedings. Because unless we define to begin with, later on certain, say, better performing states like Kerala, Tamil Nadu, and where the PRI system is already well developed, they don't need our order. They are already, in fact, much ahead. But in many states, these kinds of things would be required. And I'm sure that on these 3 institutions, as a patient support group, you can play a huge role. I would request the organizer to share my presentation with you, where the detailings have been provided for each of these 3 institutions. And but before I close, I've got a printout for all of you. 60 copies are there, and I don't think there are more than 60 participants over here. Kindly go through at your comfortable level. Think over it that what in this particular incidents, what perhaps the patient support group role, patient support groups, community engagement, what role they could have played for the betterment of the system in a country like India. So once again, thanks very much, and would not hold you any longer. Thank you.
Thank you, sir. Now to the most important part of the day. Yeah. So now to the most important part of today's workshop. What we are trying to do is to break down strategic objective 4 into the 5 sub-objectives that it has, and give each group some statements that have been made to define each of those sub-objectives, and to see whether we can agree to those statements that describe that for the 5 sub-objectives. And we will also give you a sheet of paper on which you can write your thoughts, because we don't have enough time to have a discussion. This will take about half a day of workshop. So what we will try and do is spend around 30 to 45 minutes in a group discussion, and then the group can capture their discussion points into the feedback sheet that we are giving. From the participants present today, we would invite people who are, willing to become part of the founding members for the Patient Safety Network for India. And somewhere in February or March, we are planning to have a national consensus workshop or a national consultation, which will take this initiative forward. So all of you who are present here, I would request that you distribute yourself into 5 tables, because we need 5 groups. And then all of us present here, as well as some of the amenities who are present in the audience, like Arshia, can facilitate each table so that we can collect and help the participants in that particular table to run them through the thought process and through the document that is there. So I hope that each one of you have received a copy of this document. It says Workshop on Patient Safety, Patient and Family Engagement Consensus for Patient Safety. Please make sure if you do not have one, then you get a copy. And please, what we can do is count from here, maybe here. So this is table 1, this is table 2, and then table 3, 4, and 5. So if all of you can get distributed to these 5 tables, then this can work on strategic objective 4.1. This table can work on 4.2, and then 4.3, 4.4, and 4.5.
Yes, just I am seeing that all of you are sitting in your comfort zone. So let's make you little bit uncomfortable, because when you become, we want more ideas. So all like-minded people are sitting on the same table. So you will just try speak the word 1, 2, 3, 4, 5. So 1 is group 1, 2 is group 2. So we will start from here. You are group 1, 2. Yes. Yeah. Yes, otherwise all, yes. 5 is there. No, there are only 5 groups. Yeah, start from 1. 1. 1 ho gaya, 2, you are 2. 2, 3, 4, 5. Sir. So, 1. 5, yeah. Two, 3, 4, 5. Yes. Next. 1, 2. Sir. 1. So now all group 1, please stand up and come to this table. And I am the moderator for group 1, so please come to this table. Come to the. So So follow me for group one, please.
No,
Group
that
one,
doesn't matter.
yes. Yes.
Yeah.
We can combine two tables actually, then one would be. Yeah. This one is one, let us see. Yeah, but I think that we will require more than 5 table. Yeah. So this is one. This is two. No, no. Two. Two वो कर लेते हैं. That's one. Group one. Okay, let me see.
परविंदर सर ठीक है
जी. Two, settle down, settle down. Only 3 members in one, it cannot happen. Two.
that one
Yes, yeah. Yeah, please join.
ma'am you are two you go to that table
That's,
Here.
yeah, this one is one. Please. हाँ? हाँ? नहीं, एक में वो इधर ही आ जाए.
थोड़ा सा दूर कर देते हैं ना हाँ 3 all 3 is here and I will be your facilitator any 3
This is one.
yeah
You are in group 1 or 2, but this one. That's it.
3
That's
number
basically-
3 on this table all number 4s 4
So just directly go
don't
to
have,
4.1. Yeah. Case that you can, this is not, the case study you can do later on and
4 yeah
where is the case study?
have a seat on this table 4
Four.
have a seat 5 we can have this one if that is okay
No. Because case study right now, not right now, that you can do later on. Case study is homework.
yeah this one is
Case study is the homework, the classwork is the
okay Here, this
compendium.
one you can take yeah 5
This document,
Yes.
in there are 5 consensus statements. Each group has to work on one. So you have to write from the statements and the actions that have been envisaged or advocated. So you are free to provide your inputs in terms of addition, deletion, modification. If you find you want to need or replace a word or the consensus, and there are 5, but if you think something else is required, we can have 6 or 7 also. No issue.
Okay. Okay. Or if you have revision.
Then we comment, so we do not agree with this consensus statement and we want to change the Okay, so your group, so this statement in the WHO document. This is the statement we populated 4.4, this is what it states. And from this is the consensus statement that we have. So it says that, transparency, establish the principle and practice of openness and transparency throughout healthcare, including the patient safety disclosure and of family.
So we all have this copy of this. So we have number 3 and our statement is 4.3. This is on page number 5. Right? So it has two parts, A and B, right? So just I would like you all to read it, take 5-10 minutes, take 10 minutes, read it thoroughly, and then we can discuss your thoughts one by one. How do you want to modify it? Is it okay? Something that it should be added to it, something to be subtracted, something to be modified. Your thoughts on it. There's something you want to join up? Oh, you're no. Okay. No, we have. Okay.
And that has been divided into two sections, A and B, each with each statement that further elaborates what this inclusion means. So the group has to go through these 6 statements and say that
I please request Dr. Parminder, Dr. Mahesh, Dr. Jain Srivastav to join us on the stage. As sir has to leave, so I like to have a group photograph for the panelists. Dr. Ratna, if you can please join us together. Thank you. No, that's okay. 5 more minutes, ladies and gentlemen. I would please request group number 3 to scan this code and fill the feedback form until other groups are wrapping up with the workshop. Group number 3, sir, can you please ask the group? No, they have to scan this QR code. Yes. Yes. The form will open up and you have to fill the feedback form. Those who have got free, they can start doing it until others are wrapping up. The QR codes are displayed on the screen. You can please scan those codes. A feedback form will open up. Kindly fill that feedback form. That will help us connect better for the future events.
One second. Yeah. So I see that some groups have finished their work and some are still work in progress. What I would request each table to do is to capture the group members' names and email IDs so we can keep the work ongoing, even if you have not completed it, and also look for feedback. The other request that I have is those of you who would like to be the founding members for the National Patient for Patient Safety Network may please get in touch with us, with Keshav, so that he can record your names and your consent. And then the last request is that let us all gather together for a group photograph so that we take the photograph and we keep the memory that all of us have worked on this initiative. Thank you so much.
Yes, thank you, Ratna ma'am. Ladies and gentlemen, honored guests, respected delegates, as we come to the end of this remarkable event, I want to express my heartfelt gratitude to each and every one of you for being a part of this memorable event. Your presence, enthusiasm, and participation have made this event a great success. Before we part ways, I would like to extend a special thanks to all the sponsors, volunteers, and contributors who made this event possible. Your dedication and support are truly appreciated. Not to miss our torch bearers, Ms. Karen, Ms. Aurajit, and Dr. Ratna, who made this dream vision a living reality. Very well done, the organizers and committee. As we conclude, let's carry the energy and inspiration from today into our life and work. Keep up the conversations going, stay connected, and let's look forward to even more remarkable events in the future. Thank you again and safe travels until we meet again. But few points to make a note. Thank you, sir. Please. Round of applause for each one. Everyone, I would say, let's motivate ourselves until we meet again, and we surely will. It's a very great initiative. 2-3 points, please, sir. There's a very nice photo booth being crafted where you can click your photographs and take memories. Before you leave, please remember there's a memory wall. Do write and comment on the memory wall. And yes, spare 10 minutes more. We would like to invite you all up on the stage and have a group photograph to conclude this event. Thank you. Once you're all over with the workshop, we'll gather together on the stage and have a group photograph. Please, everyone, take a moment and scan this code, please, so that you can fill the feedback forms. I would request all the efforts made by the organizers should be supported. Kindly take a moment to scan this QR code and fill the feedback form. This will help us connect for future events. Our team members and volunteers, can you please collect the forms from the group's tables?
Can we have photograph, please? Yeah.
Group number one. Group number 1, 2, 3, and 4, 5. Please, all, yes, yes. We want everyone here as a family, as our last session was that. Please, as a family, please stand together and we will all lead this journey. Ma'am, please, you can come from here. There are stairs here.